A very hearty good morning to respected chief guests, guests of honors, speakers, jury members, and respected doctors. I myself, Dr. Neha Soni, Senior Resident, Department of Anesthesiology, Bundelkhand Medical College, Sagar, MP. I'll be the host for the evening today. And as we all know, today, 16th October, is celebrated as World Anesthesia Day. On this auspicious day, let's very
Long live ISA! Long life ISA! Long live ISA!
बोलो जोर से बोलो
Long live ISA! Long live ISA!
सभी के बहुत बहुत बधाई
Now we would like to proceed with enlightening the lamp with Saraswati Vandana. Now, I would like to invite our organizing chairman, Professor Dr. Sarvesh Jain sir, and address us with few words.
Hello, good morning. This is always good to be organizing chairman of any conference or scientific meeting, but it requires a lot of responsibility and commitment. So myself, Professor Dr. Sarvesh Jain, organizing chairman of 35th ISA MP State Conference. And first of all, I would like to thank ISA National for registering us as a Sagar City branch, and this was a great achievement for Sagar City branch, which would ISA National Office bearers support. So my another thanks to our state office bearer, those who have granted us this conference within such a short notice period. And apart from that, my warm welcome to all the guest speakers, judges, chairpersons, and our PG students, those who are preparing paper and poster and sharing their ideas and researches by virtue of this conference. So thanks everybody to be part of this conference, and my again thanks to ISA office, national office bearers and state office bearers. Shukriya.
Thank you, sir, for your words. Now we would like to welcome Dr. V.M. Agnihotri, sir, who is the first head of department of BMC Sagar, past ISA national president, living legend, who built the foundation of ISA Sagar City branch.
It gives me immense pleasure to note that 35th MP State Chapter of Indian Society of Anesthesiologists will be organized by the Department of Anesthesiology, Bundelkhand Medical College, Sagar, on 16th and 17th of October 2021. It will be a virtual conference. Being the first professor and head of the Department of Anesthesiology, I welcome dignitaries, guests, speakers, delegates, and other participants. Now the department has grown to the present status that it is capable of organizing the state conference. Hope it will give the grand academic feast for the young generation and good opportunity to update their knowledge. I wish department should start the super specialty services to its earliest. I wish good luck to the organizers. My blessings to the department faculties for their commendable work. Long live ISA.
I would like to invite Dr. Dean and Professor Dr. R.S. Verma, sir, and address us with few words.
एनास्थेसियोलॉजी की एमपी स्टेट कॉन्फ्रेंस के पैटर्न होने के नाते मुझे गर्व है, क्योंकि मैं खुद एक जनरल सर्जन हूँ। इस कारण से आधुनिक चिकित्सा क्षेत्र में एनास्थीसिया के महत्व को सर्जरी में होने के लिए एक अति आवश्यक मानता हूँ। बिना इसके सहयोग के और बिना इसके ज्ञान के सर्जरी संभव नहीं है। मैं इस इनासिसिया विषय के इस बहुआयामी योगदान के लिए मैं उसका खुद कायल हूँ। इस संस्था का डीन होने के नाते हमारे कॉलेज के इनासिसिया विभाग एवं सागर सिटी ब्रांच द्वारा मरीजों की सेवा की जा रही है, उसके लिए मैं उन्हें धन्यवाद देता हूँ। मैं कॉन्फ्रेंस ऑर्गेनाइजर को आगामी कॉन्फ्रेंस हेतु अग्रिम शुभकामनाएं देता हूँ। धन्यवाद।
Now, I would like to invite Dr. A.K. Dave sir, who is a retired senior anesthesiologist and mentor of ISA Sagar City branch. Please address us with few words.
मैं डॉक्टर अरुण कुमार दवे आईएससी सागर सिटी ब्रांच की ओर से 35वीं स्टेट कॉन्फ्रेंस में आप सबका स्वागत करता हूं। सागर सिटी ब्रांच की स्थापना 1995 में हुई थी एवं 2021 में आईएससी नेशनल द्वारा सागर सिटी ब्रांच को मान्यता दी गई। मेरा यह सपना था कि सागर में स्टेट कॉन्फ्रेंस हो और आईएससी नेशनल और आईएसए स्टेट ब्रांच की ओर से उन्होंने हमें मौका दिया। उनके मार्गदर्शन में ये कॉन्फ्रेंस हो रही है। मैं सभी गेस्ट स्पीकर्स, सभी जजेस और सभी चेयरपर्सन्स का को शुभकामनाएं देता हूं एवं पीजी स्टूडेंट्स जिन्होंने यहाँ पेपर और पोस्टर्स प्रस्तुत करने वाले हैं, उन सबको हार्दिक शुभकामनाएं और हार्दिक शुभकामनाएं अग्रिम रूप से देना चाहता हूँ। धन्यवाद।
Thank you, sir, for your words. I would now I would like to invite President ISA Sagar and address.
Very good morning, respected teachers, distinguished guest speaker, esteemed senior faculties, and all my dear colleagues. Myself, Dr. Satyendra Vike, being the president of ISA Sagar City branch, it is my proud privilege to welcome all the delegates to Mpisa WebCon 2021. My heartfelt gratitude is extended to ISA National Governing Council, our President respected Dr. Mullida Joshi sir, the Vice President respected Dr. Suresh Kumar Bhargav sir, President-elect respected Dr. Venkat Giri sir, our Honorary Secretary respected Dr. Faith and providing us with an opportunity to organize this MP State Conference for the first time in Sagar, Madhya Pradesh. This 35th annual conference of ISA MP chapter is an opportunity to share innovative ideas, knowledge, skill and new research in the field of anesthesiology. We regret the COVID pandemic prevented us from holding the physical conference at the Sagar, but we are still excited about the opportunities of holding an innovative virtual conference, and we are trying our level best to make this conference successful. And the entire effects of our energetic ISA Saga City branch organizing team have shaped a wonderful and vivid scientific session of anesthesiology, and it will marked by a scientific deliberation that dwell upon current clinical issue and recent advances in anesthesiology. We are certain all of you find this virtual conference stimulating, rewarding, and meaningful. And I would like to thank and acknowledge all the delegates and the support team who have worked very hard to make this conference a truly successful. I request all the delegates and participants to take part in activities and discussion through this digital platform for 2 days. And I wish everyone a successful and fruitful conference and happy Dashera and prosperous Diwali ahead. Thank you very much. Long live ISA. Jai Hind.
Thank you, sir, for your words. Now, I would like to invite Secretary MPISA Dr. Jitendra Agarwal sir, and address us with few words. Sorry, because of the technical glitches, we have to move forward to Dr. I would like to invite ISA MP State Chapter Vice President Dr. Lalit Pandey sir, and to address us with a few words.
Warm greetings on the occasion of World Anesthesia Day, and a very good morning to respected seniors, colleagues, and my dear friends. A warm welcome to you all at Sagar for 35th State Conference of ISA. This is the first time that ISA Sagar City Branch is hosting ISA MP State Annual Conference. The team of young, enthusiastic members have been working hard to make all possible arrangements to make this conference fruitful and enjoyable. I extend most cordial welcome to all the guest speakers from the country who have spared their valuable time to deliver lecture and participate in deliberations. I also extend warm welcome to all the delegates, without whom the conference has no meaning, and entire success of conference depends on them. I sincerely hope that this platform will provide the opportunity for exchanging ideas and will benefit each other from discussions. This conference will give an opportunity for exchanging ideas and will benefit each other. This conference will give an opportunity to enrich ourselves by learning, sharing experience of meeting stalwarts of our society. Once again, on my own behalf and behalf of organizing committee and members of City Branch of ISA Sagar, extend a hearty welcome to distinguished guests, speakers, and delegates. Your online participation and deliberation and active participation and deliberation will certainly make the conference a great success. I would like to especially thank Dr. Sarves and Dr. Satin for taking initiative for such a Herculean task. Long live ISA, Jai Hind.
Thank you, sir, for your warm wishes to us. Now, I would like to move on to ISA MP State Chapter President Dr. Meenu Chadda. Ma'am, please share few words with us.
Good morning to one and all. Respected President, ISA National, Dr. Muralidhar Joshi, Vice President, Dr. Suresh Bhargav, President-elect, Dr. Venkat Giri, Honorary Secretary, Dr. Naveen Malhotra, Honorary Treasurer, Dr. Viren Sharma, Editor-in-Chief, Dr. Lalit Mehndiratta, GC Member, Central Zone, Dr. Bharat Bhushan, Academic Coordinator, Dr. Bala Bhaskar, respected Dr. V.M. Agnihotri sir, my seniors, my colleagues, and dear friends. It gives me immense pleasure to welcome you all to the 35th Annual MP State WebCon being hosted by the newly formed Sagar City Branch. It is really creditable and praiseworthy that Sagar City Branch, which was formulated about a month back, took over the onus of holding the conference. This time, the tenure of the office bearers lasted for 2 years because of COVID. I would say that COVID, in spite of all its pitfalls, proved as a blessing in disguise for me. 2 major achievements that I accomplished during this tenure is first, we organized the ISA-sponsored Central Zone PG Assembly. This is something of which I had dreamt because Indore City Branch never hosted a PG Assembly. I guess this was the beginning and we hope to continue it every year now. Secondly, I wanted to form new city branches. Forming 2 to 3 was my goal, but could achieve only forming Sagar City Branch. Ratlam and Vidisha are the next contenders. I hope the new team will achieve this. Another task that I would like to hand over to our new team is to formulate some bylaws regarding election of the office bearers of the state. There are guidelines at the national level, but our state presently has no guideline. Every year, 16th October, anesthesia professionals the world over celebrate and highlight the vital role of the anesthetist. This year, WFSA has focused on teamwork, stronger teams for better patient care. Multidisciplinary teams improve the patient experience, safety, productivity, and enhance the working lives of all involved. So it is important that we work as a team because a good teamwork leads to improved patient outcome, increased staff satisfaction, and reduced incidence of burnout. As it is rightly said, alone we can do so little, together we can do so much. I would like to convey my blessings and best wishes to the Sagar City Branch for their first conference because no endeavor is in vain. Its reward in its doing. I wish you all good luck, healthy and happy Diwali and New Year, the festival of joy and happiness. I would also like to thank you all once again for showing faith in me as the President of the MP State, and I would end by saying unity is strength. When there is teamwork and collaboration, wonderful things can be achieved. Thank you. Long live ISA. Jai Hind.
Thank you so much, ma'am, for your kind words. Now, I would like to invite President ISSP, Indian Society of Study of Pain, Dr. Kailash Kothari, sir. Please enlighten us with few words.
Good morning, friends. First of all, I thank organizing chairman Dr. Sarvesh Jain, organizing secretary Dr. Satyendra for inviting me for this conference, MPISA WebCon 2021, which is conference and workshop. I am very happy that organizers they have taken so much pain and included topic on pain, and these are very important because we have to give career option to new budding pain physicians, new budding anesthesiologists, so that they can know more about pain and what is the scope of pain management as a career. Close association between ISSP and ISA is always very fruitful for all our members, and we learn from each other so much, and this gives ample opportunity for the members of our society to decide which way they want to go in future. And I wish all the best to organizers for this fantastic conference and workshop. Thank you very much.
Thank you, sir, for your words. Now, I would like to invite Secretary MPIA, Dr. Richard Agarwal, sir. Since he was unable to join at the right time, now he'll come live with us. Good morning, sir. Sir, you are live now.
Good morning, dear ICN, respected President Dr. Muralidhar Joshi sir, Vice President Dr. Suresh Bhargava sir, President-elect Dr. Venkatgiri sir, ISA Secretary National Dr. Naveen Malhotra sir, Editor-in-Chief Dr. Lakshmandi Satta sir, Governing Council members, respected BM Abhinetri sir, past presidents, and all the present secretaries of the city branches of Madhya Pradesh, and all my dear colleagues and senior advisors. I welcome you all. It is a matter of immense pleasure inviting you all in the 31st Annual Conference of MPISA Con 2021. I congratulate Saga City Branch for organizing a state conference as it is in its infancy, because this branch came into existence just 1.5 months ago, and they are organizing the state conference with its all power and all its efforts. Saga City is also known as the Gyan Saga. In this conference, I hope the organizing team has chosen pearls from the sea to enlighten us. I'm sure that exchange of knowledge by this conference will definitely improve the outcomes and also create a good image of anesthesiologist in the society as an important organ of the medical profession. I hope you all will enjoy the topics selected by the organizers. I request all to spare some time to attend this virtual conference, from the home or from the workplace as possible. I wish Sagar City branch a great success for this virtual conference. Thank you. Long live ISA.
Thank you, sir, for your words. Now, I would like to invite Editor-in-Chief IJA, Dr. Lalit Mehndi sir. But since due to unavoidable circumstances, he could not share this video, on behalf of him, he has sent his best wishes.
President ISA MP Chapter Dr. Meenu Madam, Secretary ISA MP Chapter Dr. Jitendra, Organizing Chairperson Dr. Sarvesh Jain sir, Organizing Secretary Dr. Satyendra UK, Member of the Organizing Committee, President, Secretary, and members and Sagar City Branch, respected seniors, and my dear friends. Please register my apologies for not being able to personally attend and deliver. Congratulations and best wishes for hosting the 35th ISACON MP. Last 2 years have been a very tough time for each and everyone on the professional as well as personal front due to COVID-19, and because of which we have to arrange this virtual conference. I am glad that Sagar City branch, which is just a few months old, came forward and took the lead under the able leadership of Dr. Sarvesh Jain. I congratulate Dr. Sarvesh for hosting this 35th ISACON MP on such a short notice. I take the privilege to thank the members, my home state, for showing confidence in me and coming forward in supporting me to win the election and becoming the editor-in-chief of IJA. It would not have been possible without wholehearted support of all my seniors and dear friends. I hope I can live up to your expectations and take the name of our state to newer heights. I sincerely wish the organizing committee for a very successful conference. Best wishes to all the members of MP State, my respected seniors, dear friends. Long live ISA, long live IJA. Jai Hind.
For your words. Now, I would like to invite Treasurer ISA, Dr.
Good afternoon, respected President ISA, Dr. Muli Doshi sir, Vice President ISA, Dr. Suresh Bhargav, President-elect Dr. Venkatgiri, Honorary Secretary Dr. Naveen, President ISA MP Dr. Meenu Chadda ma'am, Vice President Dr. Lalit Pandey, Secretary Dr. Jiten, and all other members of ISA MP, Organizing Chairperson Professor Sarvesh Jain, Organizing Secretary Dr. Saten, and other members of the Organizing Committee. It's a matter of great pride that Sagar is organizing MP ISACON. I think this would be the first opportunity for City Branch Sagar to organize a state level function. I congratulate them. MP ISA has been doing quite good work participating in ISA activities from time to time, and in recently held elections I could see a great enthusiasm among members, large participation, and this would take ISA MP to newer heights. So I congratulate the organizers of Sagar City branch, especially Professor Sarvesh Jain, who is quite famous I often read his post in different WhatsApp group. He is very dedicated and enthusiastic towards the development of anesthesiology branch in general. So many congratulations to the organizers, to the ISAMP, and wishing all the best for the conference. Thank
Thank you, sir, for your words. Now, I would like to invite Honorary Secretary ISA, Dr. Naveen Malhotra, sir, and address us with few words.
Greetings from ISA National Headquarters. Wish you all a very happy World Anesthesia Day. Presiding officer of today's inaugural ceremony, Dr. Meenu Chadda, President, ISA MP State Branch, Dr. Murlidhar Joshi, President ISA National, Dr. Suresh Bhargava, Vice President ISA National, Dr. Venkat Giri, President-elect ISA National, my treasurer partner, Dr. Virendra Sharma, Dr. Lalit Mandiratta, Editor-in-Chief, Dr. Bharat Bhushan Bhardwaj, GC member, ISA Central Zone, and very respected past President ISA National, Dr. Agnihotri sir, Dr. R.C. Agarwal sir, distinguished faculty, delegates, and dear friends. Heartiest congratulations to team ISA Sagar City branch and ISA MP State branch for organizing this 35th annual conference of ISA Madhya Pradesh State branch. Special congratulations to ISA Sagar City branch. This branch has been recently formed and approved by ISA National Governing Council, and they are holding the state conference. This shows the determination and zeal to work for ISA. Heartiest congratulations to the organizing team led by Dr. Sarvesh Jain, Dr. Jitendra, the organizing secretary, and Dr. Amit Jain, the organizing joint secretary, ably supported by the secretary of the ISA Sagar City branch, Dr. Mohammad Ilyas, and treasurer Dr. Manoj Sahu. I also congratulate the Vice President of ISMP State Branch, Dr. Lalit Kumar Pandey, Dr. Jitendra Agarwal, the Honorary Secretary of ISMP State Branch, Dr. Manu Gupta, treasurer, and the other team which has done fabulous work to do this conference in such a short span of time. I've gone through the scientific program, and I'm very sure that the delegates who are attending the workshops and the conference, they will definitely, their scientific knowledge will be enriched and their professional skills will be sharpened. I congratulate the scientific committee led by Dr. S.K. Rajoria ji, Dr. Usha Saini, Dr. Mamta Timori, Dr. Shashi Bala Chaudhary, and Dr. Ajay Singh. A word of appreciation for Dr. Shashi Bala Chaudhary. She has been in direct contact with me over numerous occasions for this conference, and I congratulate you, madam, for your work and effort. Also, Dr. Amit Jain, organizing joint secretary, for doing the nitty-gritties of the conference. MP State Branch has done marvelously well under the banner of ISA, and all the national programs of ISA have been implemented effectively and rapidly in the MP State Branch. So I congratulate the team led by Dr. Meenu Chadda and ably supported by Dr. Jitendra Agarwal for doing the work effectively and efficiently. anything, whether it is public awareness programs, social outreach programs, working with other organizations, fit anesthesiologist campaign, COVID awareness programs, working in COVID pandemic. It has been a fabulous journey. And I also, the recently elections were held for the ISMP State Branch Executive. I also congratulate the incoming team led by Dr. Sudhakar Dwivedi, President of the year 2021-2022, Dr. Ruchi Chandan, Vice President, Dr. Lalit Kumar Pandey, Honorary Secretary, Dr. Mamta Mahobia, Treasurer, and Dr. Sadhana Sanvatskar, Madam, the President-elect for the year 2022. I am very sure that ISAMP State Branch will do wonders and keep on working like this in near future also. Sagar City Branch, you deserve special accolades for doing this conference plus workshop. The workshop on old is gold, PNS guided blocks of upper limb and lower limb, and nice deliberations of the conference topics in the 1.5 days or so. ISA National is always with its state branches. Whatever assistance, help, support you require, ISA National is with its branch. We firmly believe that if ISA city branches are strong, the state branch will be strong. And if ISA state branch is strong, the national body will be strong. ISA National Secretariat is just one phone call, one WhatsApp message or email away. We are always there to support our members, to support our branches, whether it is academic work, whether it is a clinical work, whether it is a research work, or it's a social work. Thank you very much for inviting me here for today's inaugural ceremony. Long live ISA, Jai ISCN, Jai Hind. Thank you very much.
Thank you, sir, for your kind words and warm wishes, and thank you for so much enthusiasm. Now, I would like to invite Vice President ISA, Dr. Suresh Kumar Bhargav, sir, and enlighten us with few words.
सुप्रभात आदरणीय प्रेसिडेंट आईएसए डॉक्टर मुरलीधर जोशी, सेक्रेटरी आईएसए डॉक्टर नवीन मल्होत्रा, ट्रेजरर आईएसए डॉक्टर वीरेंद्र शर्मा, एडिटर इन चीफ आईजेए डॉक्टर ललित मंजीरत्ता, आईएसए एमपी स्टेट ऑफिस बियरर्स डॉक्टर मीनू चड्डा, डॉक्टर ललित पांडे, डॉक्टर जितेंद्र अग्रवाल, डॉक्टर मनु गुप्ता, डॉक्टर सुधाकर द्विवेदी, डॉक्टर रुचि टंडन, डॉक्टर ममता, डॉक्टर साधना, मैं आप सबका हृदय से अभिनंदन करता हूं। आज 35th प्रादेशिक ऑनलाइन निश्चेतक सम्मेलन की मनोहर पाती के लिए मैं सागर शाखा के डॉक्टर सर्वेश, डॉक्टर सत्येंद्र, डॉक्टर मोहम्मद इलियास और डॉक्टर मनोज साहू को धन्यवाद अर्पित करता हूं। मुझे पूर्ण विश्वास है इस सागर मंथन से निकले हुए रत्नों से समस्त श्रोता लाभान्वित होंगे एवं उनका मार्ग प्रशस्त होगा। मैं समस्त कार्यकारिणी को इस विशाल सागर मंथन के लिए शुभकामनाएं देता हूं। जय हिंद, जय आईएसए, नमस्कार।
Thank you, sir, for your kind words. Now, I would like to invite President ISA-elect Dr. Venkat Giri KM and address us with few words.
Presiding officers today's conference and President of ISA Madhya Pradesh State Branch Dr. Meenu Chadda, ISA National President Dr. Muralidhar Joshi, ISA National Secretary Dr. Naveen Malhotra, Editor IJA Dr. Lalit Mahendratta, Secretary of ISA Madhya Pradesh Dr. Jitendra Agarwal, senior members Dr. R.C. Agrawal ji and Dr. V.M. Agnihotri ji, friends, colleagues, delegates, namaste. I am very happy to participate in this 35th annual state conference of ISA Madhya Pradesh State Branch being organized by ISA Sagar City Branch and Bundelkhand Medical College. We are very happy that this conference is organized by a branch in the periphery, not by the big branches or this thing. ISA lies in these small branches, and when the branches are active all over the state, ISA becomes more and more strong. So in that way, though it is a virtual conference being organized by one branch which is not in the center or periphery. So with this, the members come together and have good interaction, and we develop ISA activities. I wish all the best for this conference which is held virtually, and hope it will be useful for all the delegates, PGs and consultants as well. Simultaneously, I request you all to register for our national conference being held in Ahmedabad next month end, and if possible and if it permits, come personally there and be there on 28th when I will be installed as a president. Thank you. Thank you all.
Thank you, sir, for your kind words and warm wishes. Now, I would like to invite our chief guest, President ISA, Dr. Murlidhar Joshi, sir, and address us with few words.
Respected Organizing Chairperson, Dr. Sarvesh Jain, Organizing Secretary, Dr. Satyendra, Editor-in-Chief of ISA National to Madhya Pradesh, Dr. Lalit Mehta, Treasurer of ISA National, Dr. Virendra Sharma, GC member from Central Zone, Dr. Bharat Bhushan, dignitaries on the dais, off the dais, delegates, the faculty. At the outset, I would like to greet you on the special occasion of World Anesthesia Day. Simultaneously, I would like to congratulate Madhya Pradesh ISA chapter for taking initiative to conduct the 35th Madhya Pradesh ISACON 2021 with the help of ISA Sagar City branch. Speaks volumes about the zeal which is there in IS members of Madhya Pradesh in general and Sagar in particular. Even during this testing time of COVID, the academic activities are going on at great pace. It augurs well for the entire country in the long run. A lot of youngsters are participating in many events. It's a good sign. And the ISA body is becoming more and more younger and fitter these days. That's because that says it's ISA has become more vibrant than what it was earlier. And definitely we can look for much more better days in the following years. We wish all the delegates, faculty, and organizers a great success for the event. Our special thanks to faculty for taking the extra pain in preparing for these sessions despite the testing time of COVID. I'm sure this event is going to be a great success. Long live ISA. Jai Hind. Namaste.
On behalf of all ISA members, we ISA Sagar City branch would like to pay obituaries to late Professor Dr. K.P. Chansoria, sir. And all this valuable information about the legendary was provided by respected Professor Dr. T.C. Kriplani, sir.
Good afternoon, everyone. Today we are here not to mourn but to celebrate the life of a great man, late Dr. Keshav Prasad Chansoria. He was the legend of anesthesiology. He was born on 6th of June 1932. He did his graduation from Nagpur Medical College and diploma in anesthesia from Mumbai in 1955. He joined MP Health Services, Victoria Hospital, Jabalpur in 1956. In 1966, he did his MS Anesthesia from Darbhanga Medical College and became the head of Department of Anesthesia at Medical College, Jabalpur. He organized the National ISA Conference at Jabalpur in 1970. He was the key factor in the formation of MP State Branch of ISA and organized the first state conference at Jabalpur on 22 of April 1973. He was the member of Governing Council followed by President ISA for the year 1982. He was instrumental in starting late Dr. T.N. Jha Memorial Best PG Paper Competition in 1986. He clubbed himself with it in year 2000 and it became late Dr. T.N. Jha Memorial and Dr. K.P. Chansoria Trave Grant for PGs. He retired as Dean Medical College Jabalpur on 30th of June 1992. He was regular in attending national conferences. Last he attended was Jaipur in 2015. Many of his students have retired as professors and dean. On behalf of ISA MP, we pay homage to him. May his soul rest in eternal peace in heaven. A teacher of teachers is no more. Thanking you.
Now, I would like to introduce you to our newly formed ISA Sagar City Branch MP Society. Now, I would like to thank everyone for joining the inauguration ceremony of the 35th Annual Conference of MP Chapter ISA. Thank you, everyone, for joining. Now we are going to move on to our scientific session. We'll into Hall A and Hall B. We are into Hall A. Now I consider it a great honor to welcome Dr. Amit Dikshit sir on the screen with us. And we would also like to invite our chairperson, Dr. Mayank Masan sir and Dr. Lokesh Neti sir. Dr. Amit Dikshit sir, he is DNB DA, postdoctoral regional anesthesia fellowship in Ganga Hospital, MGR University. He is consultant anesthetist and acute pain specialist in Ruby Hall Clinic, Pune, and present affiliation. He is a member of Board of Studies, Research and Fellowship, AORA, peer reviewed IJ. He is also a member of PICEU Foundation. He is the course director for Structured Regional Anesthesia Workshop under PICU Foundation in association with USABCT.org. He has contributed chapters in regional anesthesia and focus handbook by Springer Publications, and he has also many articles published in index journals. So you may start. Chairperson.
Thank you for that kind introduction. I would like to thank the ISA Madhya Pradesh for inviting me here, Bundelkhand Medical College and ISA Sagar City branch. I have a recorded video for this workshop. Thank you, chairpersons. So could you please start the video?
You're not in this job for the technology. You're in it for the patients. You don't care about adjusting settings. You don't have time to wait for the machine to warm up. And you don't need a system that's too confusing to use. All you want is access to the answers you need, confidence in the images you see from an ultrasound system that simply works. This is point-of-care ultrasound. This is Sonosite.
So today is our focus session, and we'll be covering various aspects of focus which can help a physician, and it can help intensivist, it can help emergency medicine person as well. I welcome you all. Greetings from Ruby Hall Clinic, Pune. Now we'll start with the session.
So we'll start now with airway ultrasound. Now airway is challenging
for anyone. And there are few aspects with airway. First is we just want to be sure where our tube has gone. So I'm just placing my probe and I'm parking it more on the left side. So esophagus, as you can see, so esophagus, you can come on that side. Esophagus is there are tracheal rings, and by the side is the esophagus. So you can see the esophagus very well. So whenever we place endotracheal tube, we can see very distinctly either whether it has gone in trachea or whether it has gone in esophagus. Also we can see rise tube if placed, we can see rise tube also. So most of the time it is the position of trachea is posterolateral, and we should be very well aware of it. As you can see here, by parking the probe here, whenever somebody is intubating, we would like to park this probe here, so that once the person has done the intubation, we can very well see where the tube has gone. And this is even part of ACLS guidelines nowadays. Now, even for ETCO2 to confirm ET tube placement, you will require 6 breaths to confirm to get a good ETCO2 trace. But with this, you can directly see even with a single breath before putting or attaching any ventilation, you can easily see. So this is about esophagus. Now I'm putting my probe over the Adam's apple. Now, how to assess airway? Airway can be best assessed in sitting position, where I'll come from the back. The performer can be on the back side, and then we can just place the probe, or you can do it in supine position or with a little head high. Now I'm just placing my probe over the Adam's apple. So here you can see Adam's apple, that's the thyroid cartilage, and increase the gain a bit. So you can see the vocal cord movement here, and vocal cords move up and down as patient is breathing. So you can see the vocal cord movement very nicely here, and as over the Adam's apple, you can see down there are the arytenoid cartilage. So these two white dots. So as the patient is moving very smoothly, the patient is breathing very smoothly, you cannot see it. So you can see this vocal cord movement very well. So you can see true and false vocal cord movement, and this can be uncomfortable to the patient because it puts a lot of pressure. But you can see the movement of arytenoids very well, moving up and down, and as they are bilaterally equal, it is indicative of normal vocal cords. So post thyroid surgery, when patient has recurrent laryngeal nerve palsy, so these are the arytenoids which are moving simultaneously up and down. So this movement is very crucial. You can pick up vocal cord palsy at the end of thyroid surgery by placing this probe. Fine. Now I am putting my probe just over the thyroid cartilage, and over the thyroid cartilage you will see, as I am scanning down, I am showing all the important and the salient features. So over the thyroid cartilage, what we can expect is a hyoid bone, and we can also see epiglottis. So how to identify epiglottis? So epiglottis is seen as a black hypoechoic area. So can you show this epiglottis? Yeah. So that's the epiglottis. So reduce the depth, please. So you can see the epiglottis very well. Now freeze it, and calculate the distance. So this is one of the way of assessing the distance of epiglottis from skin. Now So the epiglottis distance is being measured as skin to epiglottis distance. Yes, so it is coming to around 1.4 centimeter. So 1.4 centimeter. Can you make it? 1.4 centimeter. Yes. So the cutoff line here is 1.85 centimeter. So any distance more than 1.85 centimeter is difficult intubation. Now another important aspect which we can see here, the orientation marker here is capillary. We can mark the cricothyroid membrane. So you can see the thyroid cartilage, the black hypoechoic area up. Now the below, just above the tracheal ring, is the cricoid cartilage. Yeah, in between is the cricothyroid membrane. That white glistening line is the cricothyroid membrane. So we can mark the cricothyroid membrane in case of difficult intubation. And below what you are seeing is the tracheal ring. Can you show us the tracheal ring? Yes. So this is first, second, third tracheal ring. You can very well see the tracheal rings down. So if you have placed an endotracheal tube, you can inflate it with normal saline, and if the tracheal balloon after inflation it is up to second and third tracheal ring, it is fine. But if it has gone beyond third tracheal ring, probably it is endobronchial intubation. This is very useful in pediatric population. Alright. Another thing is when it comes to assessment of difficult airway, there are papers in obstetric anesthesia that if we could see hired bone, then probably that is also one of the indication that when hired bone is not seen, then it is difficult intubation. Another important factor is thickness of skin. So here I am at the base of tongue. So this is the base of tongue, and yeah, so it is around 2.97 centimeter. So any thickness, the thickness of tongue more than 6.1 centimeter is a very thick tongue, and it will definitely be difficult laryngoscopy and intubation. Another way of looking at it is with ultrasound. You can measure distance, which is a thyromental distance. So now here my orientation marker is capillary, and you can see the mentum and the thyroid cartilage. So that's the thyromental distance. So now this is with the neutral position of head. So I'm measuring the distance, the thyromental distance. So that is from the mentum to the thyroid cartilage. So you can see it is around 4.4 centimeter. I am asking my volunteer to extend the neck. जितकं वर बघता येईल तेवढं वर बघा. Yeah. And I am now pressing it. Yeah. So now kindly measure the distance, please. So now the distance here, yeah, this from there. Now here you can see the distance has increased because his neck is mobile, and it is up to, yeah, from tip to tip actually. Fine. So it is coming just above 5. So you have to calculate the difference. This is around when the difference is more than 1.1, it means the patient has got very good neck mobility. Now there can be observer variation, there can be how you are putting the caliper and calculating. Actually it should have been little from the tip to tip, so that way. So once you are used to this type of interrogation, you will be able to have better calculation. And so the cutoff value, the difference of more than 1.1 is, it means the neck movement is quite normal and intubation can be very well done. When the difference between the neutral head and the extended head, if it is less than 1.1, it means it could be difficult intubation because there is hardly any motility. Another point which I wish to highlight with there are other parameters also where you can calculate skin to hired distance, skin to vocal cord distance. There are also different indices to predict difficult airway. Another thing is you can also place ultrasound probe over the nostril and increase the gain, please. When you place the probe over the maxillary sinus, so if you place the probe over maxillary sinus and if you see air fluid level, then patient is having maxillary sinusitis. Now there are no air fluid levels as such. If you see a very well circumscribed pouch full of hypoechoic area where you can see fluid there, then it is maxillary sinusitis. Maxillary sinusitis is a relative contraindication for nasal intubation. And with mucormycosis, we tend to put the infection posteriorly. So it should be avoided. So now what we are doing here is gastric ultrasound, and I am using a curvilinear probe, and here is the orientation marker, and we'll just do the scanning. So here the orientation marker is capital I, and we are moving from right to left hypochondrium. So I'm just placing my probe. So as I placed my probe, you can see few structures there. So over the screen. So what you can see as I'm moving more on the right side, here you can see liver. Here. Here. So just by the side of liver, can you see the evolving antrum? Yeah. So antrum has got a very good circular. You can see nicely the circumscribed antrum, and there is good amount of solid content. So whenever there is any solid content, it is risk of aspiration. Otherwise, if it is liquid, then the calculation is 1.5 ml per kg. Alright. So in 70 kg patient, roughly it comes to 100 ml. So by and large, if it is liquid content more than 100 ml, there is risk of aspiration. So in this case, as you can see, in supine position, I can see solid content. My volunteer just had lunch, so he is risk of aspiration. So you can see, even just reduce the depth, you can see the antrum very well. It has got a lining of, and even you can see some movement of solid content within the antrum. So this is a very well seen antrum, and we can calculate how much is the cross sectional area as well. So what structures you can see and you can identify here are, one is on the right side is the liver, on the left side it can be pancreas, and in between is the pyloric antrum. And lower down you can see vessels. Now these vessels can be the superior mesenteric artery. Sometimes you can see even aorta as well. You can put color down there and you can always see color there. So I could see few of the arteries. You only have to reduce the depth to appreciate color. So these are some of the vessels down there, and these are superior mesenteric artery and aorta. You can see those vessels and pulsations as well. Now this is one position, but for confirmation of gastric ultrasound, the more important position is right lateral decubitus position. So come on that side. So this is the right lateral decubitus position, and again you place the ultrasound probe and you identify. Now sometimes if the contents are less, you initially in the supine position it may be less, but as you make the right lateral decubitus position, you can see the content has increased. So here the content, you can see that it has actually increased with this position. So the whole circle can be seen very well with right lateral. So you can just freeze it, and we can calculate. So yes, so it's just calculating the cross-sectional area. So the cross-sectional area, you can see, yeah. So roughly the cross-sectional area. Now it is the observer and how the person is performing. So it is coming up around 24 centimeters square. So in our department, as you can see, we have this chart. So you need to know the age of the volunteer. So what is the age of the volunteer? I am just moving here. So my volunteer is here. You can see he is 40-year-old, and roughly I got around 24. So 23 to 24. So around 280 to around 300. 300 is the volume right now. So any volume more than 100 is risk of aspiration. Alright, so he is definitely high risk for aspiration. So we will just see some change what happens when we ask our volunteer to drink some water. So we are asking our volunteer to have some water content. So now our volunteer just had some water. So you can see the dynamics has changed and you can see hypoechoic areas, and this is also known as gazing star sign. You can see in that hypoechoic area. Also there are some solid particles and air. So it is casting some sort of all those shadows which are coming up. So now I would like to assess his volume in right lateral decubitus. So we will see how much is the content. So you can see now the solid content has gone down and it is very well seen, and it is like a gazing star sign. Yeah, you can all appreciate that. And even the pyloric antrum lower down, we cannot find the margin. So it is quite big now because it has increased in size that you cannot have it in one window. So it is really going down. So you will have to take the whole circle. Alright, it has gone even so we are just trying to get a bigger and brighter image. So here the solid content has gone on the, so that is all solid content, and the hypoechoic area, that's all saline, that what he has just had some water. So now freeze this, we will calculate it. Now calculate it. So we are just going to assess the cross sectional area. So alright, we will start the cross sectional area. So it is even gone beyond our screen, and it's okay. So I'm just going to, so it is around 73. So as you can see with the chart, you can show the chart here. It is up to, the chart is even only up to 29 cross sectional area. You can see the maximum, and here is this like 70. So it is too much of volume. He is definitely high. So I'm just showing, already he just had his lunch and now he's having more of water. So you can, this is how the pyloric antrum, the dynamics will change it. So we are doing bladder ultrasound, and what we are seeing here is a urinary bladder. I have placed a curvilinear probe in transverse, this transverse scan, and what you can see is a whole of bladder. Now here you can have, if the person has taken a lot of fluids orally, and or if patient is in ICU and you're giving a lot of IV fluids and kidneys are functioning well, sometimes you tend to see ureteric jet. Now there can be right-sided ureteric jet, which is seen as a color which is red in color, and because there is turbulence, so you can see the ureters throwing out urine. There can be, post-renal transplant, if patient has oliguria, then you can very well see whether the native kidney is throwing urine or it is the newly anastomosed kidney which is throwing urine. So you can very well see the ureteric jet here by putting a color Doppler and the flow. Now we will just do a bladder volume estimation. So what we do is we just see first the bladder. Now go on dual mode please. So we have just taken it. Now update please. Now I am changing the direction of the probe and going in the long axis. So here, let me have the best image. So we can see the depth here. Now freeze it. Yeah. Now he is doing calculation. So every time, yeah. So first is the length, and then the breadth, and then the height. So first is calculating the length. Now each the Sonosite H2 this machine we are having, we have to use the save update button. Save and update button. So this is D1 what he has calculated, which is 4.47. now it is calculating D2. More more precision with images, better are the calculation. So we are just giving you a brief idea. Today my fellow Dr. Ankit is helping me with all those calculations. So he has calculated D2, and D3 is like how much is the height, or somebody, we can also say it as depth. So this is another. So X, Y and Z axis, and so we can see it will automatically, the screen will show that here it is in the last line. Can you zoom in a bit? The last line. Here you can see that it is 103 centimeters square is the volume. Centimeter cube is the volume. So you can actually have a ready-made calculation, and you can calculate and decide whether the patient needs catheterization. He has just emptied his bladder some time back, and if volume is more than 5, so it is also useful in patients for whether we need catheterization, ERAS protocol, whether we want to empty the bladder or we want to put a police catheter. All those decisions can be made. So what we are doing is basic echocardiography, and one of the important steps for basic echocardiography is subcostal 4-chamber view. So here the orientation marker is towards the left shoulder, and we can place the probe on the right side and just move towards the left side. You can also move in down direction and try to figure where the hard shadow appears, and once you get some hard shadow, try to consolidate over that area. So that is another way of. If you do not get good quality of image, there are 2-3 maneuvers by which you can do it. So here we are seeing through the liver. So therefore we can see the heart. Otherwise, through lungs we cannot have, because lung is actually having the air interface. So we can improve the quality of image, one, by asking the volunteer to hold breath in inspiration. So you have to adjust with the patient and try to get good quality of image, and you can have. So different machine, different patients, and more of practice, you can definitely. Another maneuver what we can do is asking them to flex the knee. High over again. So now here, as we are seeing, eyeballing the heart, Jaya, you can show us. So there is above is the left, right ventricle. Right ventricle is up there, and lower down is the right atrium. Right ventricle, right atrium, then left ventricle and left atrium. So in between there is a mitral valve and a tricuspid valve. So you can see all the structures, and even with eyeballing, this view is predominantly used for patients with hypotension, where the cause of hypotension can be noted. So it can be because of either pericardial effusion or tamponade physiology, or it can be because of, you can see the contractility, severe MI, and also in this view we can see IVC. So how to open up IVC? So we concentrate on RA. Can you show us RA? So this RA-RV view is also beneficial if there is pulmonary embolism. The RA-RV gets dilated. So here we are turning our probe in anti-clockwise direction. So you can see the movement of probe. Here the orientation marker, I am turning capital. So that from RA, IVC is opening up. You can see the IVC has opened up very nicely, and you can see even it is collapsing. So now we can see how much is the collapsibility index. So we'll do some calculations. First put the M mode. So you can put an M mode. So take the M mode cursor 3 centimeters, roughly 1 to 3 centimeters beyond the RA. What is the M mode? So you can see with inspiration, expiration. Okay. So now here just show you the calculation part. So that's the IVC. So you can have a maximum diameter and a minimum diameter. So here is a maximum diameter, which is the bigger loop, and here it is around 2 centimeter, and minimum diameter is calculating with the with change in respiration. So with inspiration the IVC collapses and with expiration it expands. So here it is showing in a spontaneously breathing patient. You can have this change. And so here you can see the collapsibility index is showing that it is around 50%, nearing 50% collapsible. But if it is more than 50%, then you need to give fluid. Also, the maximum diameter we have to see. If it is more than 2.1 centimeter, then by and large patient will not require any fluids. So again, I am emphasizing it depends on how good you are taking the. It is observer dependent technique. So you have to get good images and then you have to put cursor correctly. So I am just explaining here the concept. So it's okay. So, but I am sure if you do it in a refined way, you will have better calculation. So by and large, he has a collapsible IVC which is 50%. Minimum diameter is around 1.1 centimeter and maximum is around 2 centimeter. So CVP could be between 5 to 10. And usually a fluid challenge of 3 ml per kg is the idea. We are doing basic echo and we have just seen the IVC assessment, and now we are slowly moving to see the apical 4-chamber wave. Okay, we have a better range. Yeah. So increase the depth. So could you explain what all the structures are, Jay? Yeah. So we have right atrium, right ventricle, left atrium, left ventricle. Now here with eyeballing we can see the contractility is good. The diameter wise you can see that LA, RA, and there is no dilated, RA, RV. We can also see descending thoracic aorta. Can you show, Ankit, where can be the descending thoracic aorta here? Just near the LA. Yeah, it's a circular structure down there, but it's not nicely seen. No, it's down there. Okay, it's okay. Yeah, yes, correct, over there. So you should know all these structures, basic anatomy. So we'll just put TAPSE there. So TAPSE is yeah, tricuspid annular plane excursion. Yes, so yeah, so put TAPSE. Yeah. So you will see when we put M mode and we can see now do the calculation for TAPSE. Okay, so this is TAPSE calculation. So TAPSE calculation basically tells us about how much is the RV function, so right ventricular function. So here you can see the difference between. So what is the difference? We are calculating between the two slopes, one up and down. Can you show which is up and which is down? So yes, that is the up and down slope. So yes, so the difference, whatever it is around. Can you zoom in a bit? You can show how much. So she has done the calculation. You can see it as 1.7 lower down.
Yes.
So can you focus on lower area?
Yes, focus.
Yeah. So it is 1.7. So normal TAPSE is anything more than 1.6. So that's the 4-chamber view. We can also put colors here. Can you put colors? Yeah. So we can see movement of if there is any regurgitant lesion or not. So or if there is any tricuspid regurg or not. So these are very simple ways by which we can identify. Okay, come take out the color. So even with eyeballing, we can understand that how much is the contractility, how the heart is moving. Now this is all about apical 4-chamber. Give me some jelly, please. Now we'll move to parasternal long and short axis. So where I put my probe, I put my probe over here. I'm moving my probe. Can you see my probe down there? So I'm going over second and third intercostal space, and you can see the probe movement there. So this is the second and third intercostal space, and you can see. So what all are the structures? So yes, so that's the left ventricle, then that is the right, that is the left atrium, yeah, and we have the wall. So you can see on the top is the right ventricle. Yes, so that's the right ventricle. So now we will just do EF calculation. So you can see the ventricles are contracting very well. So he's putting M mode over the ventricle. Again come to make 2D. We'll have a better view. We'll try to get a better view there. You can see ventricles contracting nice. So you can see some beads. You can scroll here. Take the yes, hold on. Take that bead. Now he will be doing the calculation for ejection fraction. So we have, you can see those beads. One is a bigger, yeah, that's a bigger bead, and then this is a contracting, then bigger. So the beads are like diastole. So you just calculate. So he's checking for the diastolic diameter. Yeah, left ventricular diastole. Yeah, go down. Okay. No. Alright. So now the zoom in, show the calculation part lower down. So you can see the ejection fraction is around 60%. The fractional shortening, the fractional shortening. You can zoom into that area, please.
More than.
So you can see the ejection fraction is 60%. So 2 times fractional shortening, and we have entered the diastole and systolic diameter. So it is very easy. So in parasternal long axis, those who are interested can do a basic fit workshop. Now again, yeah, this is what I am showing is a mid papillary short axis view. Again, it tells you about the. You can also do an EF calculation. We will not do it now. It's fine. But you can see a contracting left ventricle. Just show the which is ventricle. Yeah. So this is whole is the left ventricle, and there is the right ventricle. So if RV is dilated, you can see that classical D sign of pulmonary embolism and all that. Also, the contractility in mid papillary short axis view, you can have, you know, the blood supply. You can see the vascularity of all these areas. So L6, RC and LED territory are represented in this view. So if there are any regional valve motion abnormalities, you can correlate with ECG and you can pick up all that. Now as I'm moving my cursor, as I'm moving my tail up and down, I can actually see even the mitral valve morphology, and also now I am at the aortic valve with the Mercedes-Benz sign. So along the aorta is the pulmonary vasculature, so pulmonary trunk, and here again is the morphology of the mitral valve. So this is all about the eyeballing, and even with contractility you can see how much the ventricles are filled. The filling up of ventricle will give you idea about any hypovolemia. So if there is a kissing sign of ventricle, then again it is severe hypovolemia. You can also even pick up dilated, poorly contracting ventricles and can calculate here. So what I am showing right now is using a echo probe. You can even use curvilinear or convex probe, and in pediatric patients you can even use the smaller one, the linear probe also. So for diaphragm usually we use this echo probe only, and where we place the probe is actually along the posterior axillary line, and this is known as flaps area, and this is very important area to pick up any consolidation, pleural effusion, basal atelectasis. So lung examination is not complete unless we do examination of flaps area. So here what you can see here is liver, diaphragm, and the diaphragm is nicely seen as a hyperechoic image. So that's the hyperechoic area. So you can see this curtain sign as well with diaphragm moving, and If there are any fluid levels or any consolidations, you can very well see that the fluid at this interface. So whether the fluid is below the diaphragm or above diaphragm, you can pick it up. So I'm just concentrating on the diaphragm and I'm showing you the diaphragm here. Sometimes in between the rib you get to see those shadows and therefore you don't see diaphragm much. You can see with inspiration there is movement of diaphragm going up and coming down. So lung ultrasound is, so you can see those inspiration and then again expiration. So how you can also ask them to do sniff. So these are active sniff. So again you have to you can see the movement up and down. So you can calculate the distance. We will not do the calculation part, but the distance between inspiration and expiration, how we did for TAPSE, if we calculate the distance, if it is more than 18 millimeter in quiet breathing, it means normal diaphragmatic strength, and with active sniff, it should be more than 26 millimeter. So this is how we see the strength of diaphragm. So when it comes to assessment of lung, we predominantly do lung in the anterior area, assessment in the anterior area, where it can be divided into, upper half, lower half. Then in the lateral area, again it is upper half, lower half, and on the posterior side also, it can be upper half, away towards the midline, because there is again the scapula down there, and then the lower half, and last is the flaps area. So now I am just showing you when we place the probe, what we see here is the pleura, and pleura is like there is a parietal pleura and a visceral pleura. So yeah, so this is a white glistening line which is the pleura, and whenever there is pneumothorax, there is air between visceral and parietal pleura. So therefore we cannot appreciate the movement. Now here the visceral and the parietal pleura are moving, so you can have that shimmering type of effect. And if in some patients you cannot appreciate this movement, then you can put M mode, which is a motion mode. So this M mode will press M mode again. So this M mode will show seashore sign. So where is the sea and where is the shore? Shore is, yes. So this is the grainy appearance, which is because of the moving pleura, and deep inside is the calm sea. The whole is a calm sea, so there is no movement. Now sometimes whenever there is pneumothorax, or sometimes in the pneumothorax there is, you can have the similar picture. I can just mimic it on M mode. So you can see this pleura and in between is a rib. So you will see when I am putting it on the rib. So this is somewhat mimicking the picture of a barcode sign where there is absolutely no movement, and this is what you will see on during pneumothorax. So this whenever you see pleura, sometimes you tend to see white glistening straight lines starting from pleura going towards the periphery. These are called B lines. Now here you can't see more of B lines. So 3 or 3 plus, then it is pathological. 0 to 3 could be 0 to 2 could be physiological. Sometimes in patients with smokers and all that. So presence of B lines, you have to check all the areas and note if there are any B lines. So these are laser like white lines starting from pleura, and this is because of the water logging in between the septum. So here there are no B lines. Now even if, say for example, now I am checking bilateral air entry, so instead of checking bilateral air entry, I can put my probe and I can see movement of pleura. So if pleura is moving on this side, it means lungs are getting ventilated. If pleura is moving on this side, it means lungs are getting ventilated. So this is how I can pick up whether bilateral air entry is there or not. This is also useful when I am doing lung isolation technique, like double lumen tube when placed. I want to see whether there is any movement. I can always put M mode and see if pleura is moving or not. How much is the lung separation? Now coming to diaphragmatic assessment, I can just place my, so could you just show the diaphragm here? Could you just show? So it is a 3-layered structure. Yeah, use pen and just show them. So he is showing with an arrow. So that's the upper layer of diaphragm and lower level. Yeah. So this is the lower extent of the diaphragm. So you can see upper level वापस दिखाइए. Yeah. So it's quite a big structure and you can appreciate it very well. And so you can see the diaphragm moving. Yeah. You can see the diaphragm contracting. So with inspiration, its width increases. So you can even calculate the depth, how much is the change in diameter. Okay, come on. So this will also tell you how much is the diaphragmatic thickness, which is changing with inspiration and expiration. And if the fraction is more than 20, it is normal. So this criteria is often used whether we can extubate the patient or not. So depending on the strength and thickness of diaphragm, we can decide. So those patients who are difficult to extubate, who are continuing with ventilation, so there are good enough papers in cardiac anesthesia where people have decided looking at the diaphragmatic thickness and whether they can extubate the patient or not. So sometimes when you put color for bladder, you will see the jet. Now I am doing E first for this patient. So I just saw some jet, so I thought of shooting it. But anyways, just remove the color. So for E first, the first position is the right hypochondrial area, which is also known as Morrison's pouch. So give me some jelly here. So here, if there is any fluid collection, we will be able to identify the fluid collection here between kidney and the liver. So what you should be doing here is you can move the probe with both hands and you can try to identify what structures you are seeing. So here I can see kidney and liver. Could you show me where is the liver? Use a pointer, please. So pointer. So that's the liver, and below is the kidney. And yeah, and where is the inferior pole of liver? So that's the inferior pole of liver, and in between the inferior pole of liver and the kidney, you can see hyperechoic area. So if there is any fluid collection, you will see it as hypoechoic, black area, and that is like patient may require emergency laparotomy. So that is the importance of Morrison's pouch. Now in between you can see rib shadows, so you can rotate the probe in such a way that you can be in between two ribs and you can angulate your probe and change the direction so that you can have a better vision. You can store all these images. This is the position 1. Now moving to position 2, I am doing the same as I did here. I am doing the same thing for this side. I think you can see movement of my probe, and you can also appreciate the kidney down there. So that's the kidney, and upper area is the spleen. So now in between spleen, yes, so in between spleen and kidney, this area, if there is any fluid collection, you can see fluid collection there. So this is position 2. Now third position is usually what we do is for the heart. Could you give me some checking? Yeah. So actually, if you are using the convex probe, you can continue using the convex probe and move it to maybe a penetration mode. And here the orientation marker, you have to keep it on that side, and you can see the movement of heart. Could you show heart here? Heart, yeah. Where is the movement of heart? Yes. So that's the RA and that's the RV, and yeah. So you can have better images with better probes. An echo probe is the choice, but still you can get away with this type of use of convex probe for picking up pleural effusion or any collection around there, pericardial effusion, pleural effusion. So cardiac tamponade and everything. So these type of situations, even with a curvilinear probe, you can definitely have. Alright, so this was position 3. Now give me some more JD please. Now in position 4, JD please. In position 4 we move towards bladder. So this is the bladder assessment, and what we see is bladder. Try to reduce the depth a bit. Yeah, put some color. Sometimes you tend to see some movement and the ureteric jet. That also tells you about the urine, um, which kidney is functioning well and all that. Now my patient had water quite some time back, so we don't see that much amount of jet. Now we have to, this is position 4. Now in position 5, we turn our probe in long axis, get rid of color. Yeah. So here you can see my orientation. You should know the orientation marker. So I am placing my orientation marker capillary. Now below, that is behind the bladder, there is rectal. So my orientation marker here is capillary. So behind, so this side, not towards the orientation marker. Yeah. So this down. Yeah. So this is all rectum. So this is a rectovesical pouch. Now if there is any fluid collection over there, so you can pick up rectovesical pouch, and in females you have uterus down there. So the pouch, the area between the urinary bladder and the uterus, if there is any collection, you can easily identify. So this is another. So we have done 1, 2, 3, 4 and 5. Now 6 and 7, 2 positions are remaining. Give me some credit. So these are for pneumothorax, which are over the chest, and reduce the depth please. So over the chest, you can just put it over the chest, and you can see movement of pleura. You can see the pleural movement very well in between the ribs. Similarly, you can see on the other side. Now for diagnosing pneumothorax, the patient must be in supine position. Otherwise, you may tend to skip the diagnosis. So you can do this for position 6 and 7. So this is how we complete our EFAST. Now there is another situation when we have a patient who is in hypotension. So this was in 2012. There is one protocol which has been described, which is known as RUSH protocol. So it is rapid ultrasound assessment in patient with shock. So how to diagnose the predominant cause for shock? So the mnemonic, which is now very commonly used as a part of RUSH protocol, is high map. So first is H, stands for high, H stands for heart. So I'm just doing a heart assessment. Increase for the heart, make the arrangement for heart. Yeah. So we are here on the penetration mode, and we have increased the depth, and you can see the heart movement. So what are the causes that can cause hypotension as far as heart is considered? One is cardiac tamponade. So with severe pericardial effusion, tamponade physiology, you will see. So that is one of the cause of hypotension. Second predominant cause is massive MI. That also you can pick up with good eyeballing, regional valve motion abnormalities, that ventricles are not contracting, things like that. And third predominant cause related to heart is pulmonary embolism. That also you can pick up, because you can see dilated RARV and you can diagnose that. So of the high map, H is done. Now after H, I stands for IVC. So once you have done that, you can try and get the IVC assessment in this area. Now we have already covered the IVC part, so you have to I think that's better done with the echo probe, but you can concentrate on RA and then try to open up. I'm just trying to open up yeah, to some extent. Yeah, so that's the IVC. So you can still do it with this probe. So it will give you fair idea whether IVC is full or not. So it will give you. So that is HI. Then M is again for Morrison's pouch. So it will tell you about the abdominal cause of the so you can see the liver, you can see kidney, and if there is any peritoneal collection, that can be the cause of severe hypotension in a patient. So patient needs laparotomy. So patient is bleeding internally. The this is definitely the fluid is going to get collected. So HIM. Now A stands for aorta. So for aorta, sometimes there can be aortic. Now reduce the depth, please. Reduce the depth, please. Reduce the depth. Reduce the depth. Yeah. So inside you can see us in the middle of the screen a circular structure which is contracting. Yeah, that's the aorta. So you do the diameter assessment from inside to inside. No, it's okay. We will not do it right now. But you can easily do the diameter assessment from inner margin to inner margin, and you can see if it is more than 3 centimeter, it may be because of the aneurysm, pseudo aneurysm and all that. You can all see. So this arrangement, so you can scan it, scan the aorta lower down across the abdomen and how aorta divides and all that, and you can pick up any abdominal aortic aneurysm. That is another cause of hypotension. So high map. So H heart we have done, then I for IVC, M for Morrison pouch, A we have ruled out aorta, and another last P is pneumothorax. So for pneumothorax and supine position, we just have to identify the moving pleura, and if pleural sliding sign is present on both sides, we have ruled out pneumothorax. This can be the predominant cause of hypotension. So this is how is the rush protocol. So lung assessment, and it has combined the cardiovascular assessment also. It can be done very quickly. E-fast and rush protocol should not be done. It should not obscure the definitive analysis. If patient is going to get shifted for CT, just shift them. And if you are doing E-fast or rush, it should be done very quickly. It should be in a very less time. So what we are doing here is, could you just zoom in? You can show us we have applied a tegaderm here. So you can see the tegaderm being applied, and then we can do the probe here. And here the Sonosed H2 is with a specialized preset called as ophthalmic preset. And what is the significance of ophthalmic preset is the mechanical index is 0.2. So vitreous, so ultrasound beam produces good amount of energy. If mechanical index is brought down to 0.2, then it is safe for eyes. Otherwise it's a proteinaceous material. If we keep mechanical index more than 1, and if we put more Doppler for more time, then it produces good amount of heat. So I think not very all different machines have this ophthalmic preset, but here at least we have this ophthalmic preset. So what we do is we use a linear high frequency probe, and we just place it over the eye, and we try to observe the we try to see the ophthalmic. Yeah, so this is the optic nerve. So where is the optic nerve is you can use arrow. You can use arrow in this. Yeah, so that's the whole of optic nerve. Now where the optic nerve diameter should be done? So it should be done 3 millimeter behind the globe. Why it should be? You can freeze it. Why it is to be done at 3 millimeter behind the globe? Because it is said that the optic nerve carries all the meninges, and the CSF is very equitably distributed at 3 millimeter behind the globe. So here you should be doing optic nerve sheet diameter assessment. So we just do the calculations for us. So Dr. Ankit, my RA fellow, is helping me with the calculation. So yes, so yeah, 3 millimeter behind, and we are doing the calculation. So here what you can see is around 439 centimeter. So 5 millimeter is the cutoff roughly, and anything more than 5 is significant. So how we use this? So this is mainly used for laparotomies more than 5 hours or in patients with robotic radical prostatectomy. So pre-op we do the assessment, and before extubation again we do the assessment, and if necessary we can give Lasix, mannitol, we reduce the ICP and then extubate the patient. So it is a non-invasive way of assessment of ICP. Another thing what we can do with assessment is even with ophthalmic foreign bodies, retinal detachment and vitreous hemorrhage we can all see. Sometimes we tend to put color here, and you can put a color Doppler down, and again you have to adjust with the pulse repetition frequency, and uh, somewhere around 12 and 18 sometimes you tend to pick up the pulsations down here, and these pulsations these are suggestive of healthy ophthalmic blood supply. So in patients with central retinal vein and artery occlusion, you will not see pulsations. So this is slowly we have started doing it in patients posted for scoliosis surgery or COVID patients getting ventilated for with prone position for 16 hours a day. So it is good idea to do this pre-procedure and then repeat it later. So those patients who are on the verge are like uncontrolled diabetes, CKD patients. So you can do that. Another thing is sometimes patients with black eye. So increase the depth, please. So that's how we elicit. Sometimes it is not possible to open the eyelid of the patient because eyelids are completely swollen. So what we can do is we can elicit light reflex. That's the consensual light reflex. So when I'm putting the light reflex on this eye, both the pupils will constrict. So I'm just putting a probe on the swollen eye. Suppose this eye is swollen, I'll just put and I'll try to see the pupil. So you can see the pupils. Just show the pupil. Yeah. So this is the pupil. Now we are eliciting light reflex. So just show the light. So this is the light. Show towards the camera. That's the light which is coming up. Light, can you see? So that's the light reflex, and you can see the pupils are constricting. So we have a lighted room here, but if you do it in complete dark, you can see the movement of. So we have created a darkness here, and we are trying to elicit. So first thing is you have to get a good image, and here you can see a good image. Yeah. So just put light over here. So you can see that it has constricted. Again we'll do it. It has constricted. So this is how you can see the constriction. Now again it has got dilated. So now what I am trying to suggest here, you can see here a nice bulge of internal jugular vein which is compressible, and below is the artery. Now internal jugular venous cannulation is a common thing which we do in our operation theatre. So usually while selecting you can scan the neck and decide which is the ideal position uh, for cannulation. So there are some steps involved with IGV cannulation. First step is under vision we can do the puncture. So I am going to put a needle down there and bring it in the middle of the screen, and I can do a puncture here. So I'll be able to puncture the vein. Now for the second step you require a echo probe. So you definitely need a echo probe, and you change it to echo probe. So the second step, which I think most important step for IJV cannulation, is we need to get a subcostal four chamber view. Here you can show RA. Where is RA? Use a arrow and show the RA. So you have to concentrate here on RA, and here you tend to see a guide wire. So when you pass a guide wire, you will see a hyperechoic area. So that's the step 2. So unless you see guide wire in RA, you are not supposed to dilate. Okay, remove the arrow. So here you can see RA and RV. Once the central line is placed, the important confirmatory sign is swirl sign. So you have to put some agitated normal syringe. So with the 2cc syringe, you just have to push it through the central line, and you will see swirl, and these are micro bubbles which move from RA to RV, and that is the confirmation of central line. So ultrasound has role at 3 steps. One, first at the punctures, which we do with the help of a linear probe, and second, with the help of a echo probe, we identify the guide wire in RA, then we dilate, and step 3, we elicit swirl sign. So if we see positive swirl sign, those micro bubbles, in less than 2 seconds, then it means correctly placed central line. If it is more than 2 seconds, then it can be, the central line tip may not be in RA. So it is always desirable to do a step 4. Could you just show the probe position? The step 4 is after doing the IJV cannulation. Once you have done the scanning, if you are getting a positive swirl sign after 2 seconds, then you better scan the other side of the neck also, the other side of IJV also. Give me some jelly. So other side, so central line sometimes can go on the opposite side, and then you have a swirl sign positive, which is a delayed positive swirl sign. So you have to check for the internal jugular vein on opposite side, and also the step is not complete if you have a delayed swirl sign. You also have to see the axillary vein. So the axillary vein, give me some jelly. So where all the central line can go. So if you have a delayed positive swirl sign, so you can see the axillary vein. Sometimes you may tend to reduce the depth. Please show the axillary vein. Where is the axillary vein? The one which is getting compressed. Okay, the one on the top. Yeah, so that's the axillary vein. So sometimes you may see the central line over in this area. So you have to rule out if there is a delayed positive swirl sign which is more than 2 seconds. So I'm just showing here the popliteal vessels, and what we are planning to do here is 3-point, or sometimes it is also 4-point DVT scanning. So the basic principle of DVT scanning is to check the compressibility of vein. So here I am scanning in the popliteal fossa. You can see the popliteal, the nerve, artery and vein. So here is the artery, just above, just show the above the artery. This is the compressible structure, that's vein. That is, vein is getting compressed, you can see nicely. And just above the vein is the sciatic nerve, and the two divisions of sciatic nerve. So just below the sciatic nerve, you can see a compressible structure. That's the, you see it is getting nicely compressed. So if this is getting compressed, it means there is no clot down there and less chance of deep vein thrombosis. Now this is one point where we would like to check the compressibility test. You should do it gently because it can hurt the patient, and it can dislodge the thrombus also. So you should be careful while doing this test. Now another areas which are there, you can show up here. So I am scanning the groin area, and here my orientation marker I have kept medially. So you can see one is the mode correct? Okay, fine. So I'm just putting some more jelly here, and you can see artery. Everyone can appreciate artery, which is pulsating, and by the side of artery is the vein. Okay, yeah. So just the common femoral vein, the first branch to jet out is the great saphenous vein. So you can see the great saphenous vein jetting out, and this is on the medial side of the thigh, and my orientation marker is medial. So sometimes you can see clots in the great saphenous vein also. So this is the compression test, and you have to do it at the level where the the branch, that is the great saphenous vein, is coming out. So this is the at the common femoral vein point, which is at the femoral crease, and then you have to scan up and down to see the jetting out of great saphenous vein. Now I'm scanning it lower down. You can increase the depth, please. I'm scanning it lower down, and you can see as I'm scanning it lower down, the vein is moving downward, and now here you can see in between the artery also tends to divide, and in between the artery there is a pulsating structure. So that is mostly, yeah, so that's the most commonly the lateral perforator. Here you can see these lateral perforator. So between there is one artery, then a vein, and again below again is a artery. So in between is a lateral perforator which you can compress. So now the femoral vein divides into superficial and deep branch. Now deep branch is very difficult to make out, it goes really deep. But superficial branch is actually known as the regular, what we say is the femoral vein. And here you can see the femoral vein. Now you can actually, can you show the femoral vein here? It is actually the superficial branch of femoral vein. Again you can do the compressibility test here. Now another thing what you can achieve here is looking the vein in the long axis. So here I am just doing the maneuvering, and so above is the artery and below is the vein. So we can also put Valsalva maneuver and check with inspiration and expiration how it is happening. So if just like IVC, we can check for its, and also we can check for its compressibility. So here you can see the vein is getting nicely compressed and there is no DVT. So we have looked at the common femoral area. We have checked for its compressibility. We have seen the greater saphenous vein which is jetting out at that point. Then we have seen the perforator level, the lateral perforator, and lower down where it has become the superficial femoral vein, we have looked at the long axis, and the last point is the popliteal fossa where we have seen its compressibility. So this is more or less 4-point compression test to rule out DVT. So if we are lucky, we can directly see a clot down there, or with Valsalva you can see that the collapsibility has reduced because of clot, and also you can put color and Doppler and see the velocity in these areas. So any suspicion, any patients where you suspect PE on those bedridden patients. So how we use it for our surgery is those bedridden orthopedic cases, we can do a quick scan where we know for DVT we can scan both the legs, and we look at IVC, how much we need to give preload to these patients, and then we induce either general anesthesia. Also a quick scan of heart also tells us about the contractility. Spine anatomy is not part of because it will be discussed in greater detail. But what as anesthetist and even in intensive care area, lumbar puncture is very commonly done. So if it is in sitting position, it's easier most of the time. But if patient is in ICU with lateral position and different curvatures, it is sometimes very tricky. So the good idea is to just put the curvilinear probe, scan it up and down, and we just, when we are in the intervertebral area, we see the posterior complex and the anterior complex. Could you just show where is the posterior complex? Posterior complex. Yeah. So that's the posterior complex, which is made up of posterior dura and ligamentum flavum, and below is the anterior complex, which is made up of posterior longitudinal ligament and anterior dura, and in between the hypoechoic area is the CSF. Now my target area, just could you freeze this, freeze it, freeze it please. Sir. Freeze. So could you just calculate the distance for posterior dura? So yeah, so where my needle will come, yeah, so my needle, yes, so that's the probably the area which I am anticipating. And if my needle which is it's around 3.82 centimeter. So I will get spinal single shot, more or less, because we are doing it regularly, and what we have found, the needle redirection, the skin puncture, everything has gone down with the scanning. So even this transverse midline scan is just enough to get a good spine. So when we have a patient posted for any regional anesthesia, even like a spinal anesthetic block, we do spinal anesthesia. But before spinal anesthesia, a quick pre-induction scan of IVC will tell you about volume status. If you are anticipating difficult intubation, you can do a quick airway scan. If patient is posted during emergency, then you can do a quick gastric ultrasound to assess if there is any risk of aspiration. At the end of surgery, again you can repeat IVC scan to see how much the patient is hydrated. And in the end, you can always do a bladder volume assessment whether patient needs catheterization or not. If this patient is bedridden, I would probably like to do a DVT scan before induction. So this can be very useful intervention. Nowadays, people are doing all sorts of scan in various areas. Last time I recollect, we have picked up a PE, pulmonary embolism, in a robotic radical prostatectomy, and this is most often an autopsy diagnosis. So dilated RARV, we have already seen rush protocol. So I think with this we will conclude our session. Thank you very much. Sir, you are on mute.
Thank you, respected Amit sir. It was a very informative lecture and it was an amazing presentation. Now I would like now the session is handed over to all chairpersons, respected Dr. Mayank Masan sir and Dr. Lokesh Neti sir. If there are any queries, please proceed.
Excellently presented by Dr. Dikshit, and he has done a good job.
Thank you, sir. So it was just attempt on my part to sensitize all the anesthesia, mainly the PGs and those who are interested in focus. And we also have slowly changed. Our department has picked up a few of these skill sets, and it is benefiting in the betterment of our patient care. Thank you, sir.
No, it was an excellent presentation regarding everything which was covered up, and well covered topic. Any doubts, please, we are open for discussion.
All right, thank you. I think we have covered everything.
I think you have covered up everything, Dikshit sir. Dikshit, Dr. Dikshit, you have covered up everything, I believe.
Thank you.
Sir. Thank you.
Thank you.
Thank you so much.
Thank you.
Now I would like move on to the next session. As you all must know, just a technical issue, just wait.
वन के बाद 2, 3, 4, 5, 6,
7, 8, no. 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 इसमें 9 नहीं है. इसमें 9 1 2 3 4 5 6 7 8 9 10 इसमें भी 10 नहीं First, first, Tango, 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 Berry, Berry,
Welcome back, everyone. There was a technical glitch, so I'm just coming back. As you all must be aware that we had elections for the post of Vice President, Honorary Secretary, and Treasurer of ISA MP State Chapter this year. We take immense pleasure in announcing the new office bearers. The new office bearers are President Dr. Sudhakar Dwivedi, Vice President Dr. Ruchi Tandon, Honorary Secretary Dr. Lalit Kumar Pandey, and Treasurer Dr. Mamta Mohopia. Now we would like to have a video of past Secretary Dr. Jitendra Agarwal sir.
Good morning all. I am Dr. Jitendra Agarwal, Honorary Secretary IMP State Chapter from 2017 onwards. As you all know, this year elections occurred and Dr. Lalit Pandey from Jabalpur has been elected as the Secretary of ICMP State. Hence, I am handing over the charge of Honorary Secretaryship to Dr. Lalit Pandey sir. Thank you. Good morning all. I am Dr. Jitendra Agarwal, Honorary Secretary IMP State Chapter from 2017 onwards. As you all know, this year elections occurred and Dr. Lalit Pandey from Jabalpur has been elected as the Secretary of ICMP State. Hence, I am handing over the charge of Honorary Secretaryship to Dr. Lalit Pandey sir. Thank you. Good morning all. I am Dr. Jitendra Agarwal, Honorary Secretary IMP State Chapter from 2017 onwards. As you all know, this year elections occurred and Dr. Lalit Pandey from Jabalpur has been elected as the Secretary of ICMP State. Hence, I am handing over the charge of Honorary Secretaryship to Dr. Lalit Pandey sir. Thank you. Good morning all.
Now I would like to invite our present Honorary Secretary Dr. Lalit Pandey sir to address us.
Respected seniors, colleagues, and my dear friends, I am both humbled and honored that you all, esteemed seniors and friends, have placed your support and confidence in giving us a chance to work for you. We feel blessed as we begin this new era, and I assure you that we all together will work hard to live up to the expectations. Let's place ISA MP State Chapter glorious in national platform. I would like to thank all my dear friends for their unending love and support. I would like to thank each and everyone who has elected me and my team. I am falling short of words to express my gratitude and emotions for the confidence that you all have shown to us. Thanks again to each and everyone. I would like to seek blessings and guidance of my respected seniors, my National President, Dr. Muralidhar Joshi, sir, Vice President, Dr. Suresh Kumar Bhargav, sir, President-elect, Dr. K.M. Venkatagiri, sir, Honorary Secretary, Dr. Naveen Malhotra, sir, Treasurer, Dr. Viren Sharma, sir, Editor-in-Chief, Dr. Mehndi Ratta, sir, Past President, Dr. S. Balabhashkar, sir, Post-Editor, Dr. J.V. Divatia, sir, and our dear GC members, Dr. J.B. Subramanian, Dr. S.C. Ganesh Prabhu, Dr. Rajiv Gupta, sir, Dr. B.B. Bharadwaj, sir, Dr. Surjit Giri, sir, Dr. Deshpande, sir, and Dr. Chintala Kishan. I also thanks to my secretary from Family Benevolent Fund, Dr. Sugu Varghese, whose work we had to take further in making members of ISA FBF. I also thank and I request everyone to please get registered for for ISACON 2021 in Ahmedabad, Dr. Badresh Arvind Shah. I also thanks to PPF, Pankaj Gupta sir, our national coordinator, and Dr. Viren Sharma sir, and Dr. Ashita Rathore for our MP state coordinator. At the same time, we have to take our compression only life support team to the national levels. And I thank Dr. S.S. Chakra Rao sir, our Indian Resuscitation Council chairman, and the team of Chakra Rao sir, Dr. Rakesh Garg, Dr. Mukul Kapoor, Dr. Rashish Diwan, Dr. Saeed Mohid Ahmed, and Dr. Baljit Singh sir. At the same time, I also thank to my patrons, Dr. R.C. Agrawal sir, Dr. V.M. Agnihotri sir, and Dr. B.P. Singh sir, Dr. Kriplani sir, Dr. K.K. Arora sir, Amrita Mehrotra madam, Dr. Kothari sir, and all my seniors. Dr. Aditya Agrawal sir, Dr. Suren Rekwar sir, thank you. Thank you for all, and thank you, and happy World Anesthesia Day. Thank you very much. Long live ISA, Jai Hind.
Thank you, sir, for your kind words. Now we would like to facilitate. Thank you, sir, for your kind words. Now we would like to facilitate a new honorary secretary, Dr. Lalit Pandey, sir.
Thank you.
Now we would like to move on to our next session, the lecture by Dr. Sumit Gulati, sir, Complication in Pain Intervention and Risk Management. And I would like to introduce you to our chairpersons, Dr. Pratibha Shah ma'am and Dr. Sangeeta Bansal ma'am. Dr. Pratibha. Dr. Pratibha Shah ma'am, she is a professor in Pandit J.N.M. Medical College, Raipur, faculty, Academy of Dermatology, Ahmedabad, and she has a teaching experience of 24 years, and she has 42 publications and many chapters in books. Her area of interest is pain management, regional obstetric and pediatric anesthesia. She has done around 50 lectures in international, national, and state conferences and PGSMD. She is the examiner in various universities for MD, DA, and DND exams. Lectures around 15 international, national, state conferences and PG Assembly. She is examiner in various universities for MD, DA, and DNB exams, PDCC exam, and as a subject expert in PSC AIMS, ESI for appointment of faculties. Now we'll move on to Dr. Sangeeta Bansal. Dr. Sangeeta Bansal Agarwal, she is a professor in HOD Anesthesiology, Index Medical College Hospital and Research Center, Indore. She has done MBBS. She has done her MBBS and MD, both from the MG Medical College, Indore. She has a work experience of 24 years, and she's a consultant anesthetist at Geeta Bhavan Trust Hospital. She is senior residency in Bombay Hospital, Bombay, and published several papers in national and international journals. And she has areas of interest in academics and research in anesthesiology. Now we'd like to start the video.
Start.
Doctor, wait. I would also introduce to the speaker, Dr. Sumit Gulati, sir. Dr. Sumit Gulati. Dr. Sumit Gulati, MD, FRCA, FFP, MRCA, EDRA, is a consultant in pain medicine and anesthesia at Walton Center of Neurology and Neurosurgery in Liverpool, UK. He has trained in pain medicine in London and Leeds and is currently practicing in Center of Excellence for Neurosciences and Spinal Care in Liverpool since 2013. He has a special interest in complex spinal pain, painful peripheral neuropathies, pelvic pain neuromodulation. He is a chair of the Interventional Pain SIG of British Pain Society and has organized courses for Royal College of Anesthesia, BPS, and another societies. Lecture.
Yeah, you want me to go live? Can you hear me?
Yes, sir.
Okay, just give me a second. Just bear with me. Can you help me, Neha? My screen is not getting shared. It says host disabled screen sharing. Can you please enable screen sharing?
Yes, sir, done. You can share.
Okay, thank you. Can you hear me and can you see the screen okay?
Yes, sir, perfectly.
Okay, thank you. Thank you to the Madhya Pradesh and Sagar colleagues, ISA colleagues, and I'm really honored on this special day as the anesthesia day, and I'm really grateful, and I'm really honored to be talking to you all. I have the pleasure of obviously being in elite faculty colleagues and my teachers, including Professor Mpisa, who I owe a lot of my education to in anesthesia while studying in Bhopal and while doing my MD there. So I'm really happy to be here. I'm actually sat in Delhi today. I was in Bhopal a few days ago, but I'm just about to travel back. So thank you for inviting me, and I'll just start the presentation. It's a slightly long presentation, but I'll try and sort of make it relevant to sort of a bit of anesthesia, a little bit of pain, so that we can try and see a few things that are hopefully relevant to everybody. So this is where I work, and thank you for the introduction earlier. I am working in about 200 miles from London in Liverpool, which is a standalone neurosciences center. And it's one of the oldest departments for pain management in the country, where back in early 1980s, started some really high-end work like cordotomies and spinal cord stimulators with the neurosurgeons and pain specialists. So I'm quite honored to be working there. These are my disclosures. I think there's not much relevant for this meeting, but I have attended courses and I've spoken for a few companies. And my aim of the presentation today would be to sort of discuss about why this is relevant, risk management, and discussing complications. I'm going to sort of show you some complications, but I think the most important thing I want to get across is to foster safe practice in the Indian context and discuss about why it is important for the next stage of evolution in any science and any specialism. When we have perfected the techniques, when we have perfected our knowledge and our skills, why is it important to then evolve to try and maintain that at a level which then becomes the next standard of care for, because that's where the respect and the credibility of the specialism lies. I'll discuss a little bit about patient consent and medical legal practice. I'll discuss about duty of candor, and I'll discuss about complications. And I would encourage all of the anesthesiologists, all the anesthetists, all the pain specialists to be champions for the safety culture, because we are the largest of the population of clinicians working within operating theatre setup. And therefore, we need to have this as our strength, that we are able to encourage all the staff members, both medical and non-medical, to learn and discuss about safety and risk management. So I'll just put a couple of MCQs, and if the audience has any doubts, questions, obviously there will be sort of time to discuss that. So I've put this question, and this is something about duty of candor. And it started not that long ago in the UK, and it's now part of the good medical practice, which is part of what we have to, abide by in as the sort of GMC is the regulator, and General Medical Council is the regulator for us. So if you just look at the options here, is the duty of candor involves duty of support and mentoring for your colleagues, duty to your organization and medical associations for safe practice. Is it a duty to explain and consent the procedures to your patient? Or is it a duty to be open and honest to the patient when something has gone wrong? So we will discuss this in a slide, and the answers will come along. And the second question is about adhesive arachnoiditis. It can occur due to, and these are the 5 options, you might want to read it, and if there are any questions, we can discuss this later. So it's contamination of needle with wet chlorhexidine. Can it occur from a prolapsed intervertebral disc, from repeat spinal puncture, from contamination of needle with alcohol, or contamination of spinal needle with dry chlorhexidine? And if you have any questions, if you want to volunteer any answers, please do write in the chat box, and if I can ask the moderator to just let me know at the end the choices and if there are any questions about these MCQs. So risk management. Let's be sort of clear about what is the risk management. And I think the surgeons, from where our history evolves as an anesthetist, we were part of the surgical sort of fraternity, and then the Royal College, and then the Indian Society of Anesthesia, and all of these organizations started as following on as branch out from surgery. So the risk management, the surgical risk management has already evolved. It's part of the culture. within surgery and as part of their curriculum. But in pain and regional anesthesia, it's a smaller part of a wider anesthesia training. So safety as such is less standardized to discuss in this regard. And there is no universally accepted means of gaining competency as such. If you think about how you learn about these things, you learn pretty much on the job, and you learn based on the teacher you have and the trainer you have, and you go to courses, you learn things. Often the courses will focus on the techniques, and this is all about learning the skill. But there's not much conversation as there Gawan with the whole what eventually became a checklist. So that Royal College of Surgeons has got very clearly laid out in their domains for the good surgical practice about safety and quality and the consistency in patient safety is maintained. So this is where the background of safe practice is. And this is obviously can you hear me okay? Sorry, I think I might have lost. Am I audible? Sorry, bear with me. Moderator, can you hear me?
Yes, sir.
Okay, thank you. Sorry about the little glitch. So risk is about primum non nocere, which basically is what we abide by. And there's a difference between risk and hazard, what you call risk and what you call as hazard. Risk is potential for undesired consequence and the probability that such a consequence will occur, and hazard is the potential for undesired consequences without the probability. James Rathmell and Joseph Neal have published a textbook and several articles. I think they were the sort of initial champions in regional anesthesia and pain medicine who talked about the risk, and they've talked about the medical decision making. So understanding the risk, identifying, considering the alternatives, and then decision making based on the risk and benefit. So everything is a balance. And this is part of our communication with our patients about when we tell them about what they should or should not have as a procedure. We talk about the risk and benefit and allow the patient to be involved in the decision making. But when you discuss the risk with the patient, how do you express the numbers of what do you call as, low risk, high risk, very high risk? And this is just a perspective of what is a sort of risk. Now, 1 in a million chance of somebody getting a GBS, Guillain-Barré syndrome, with a flu jab. This is something probably not that's discussed with the patient when they get a flu jab. And a lot of you would have had the vaccine for the COVID. So, and this is the same risk of dying in an accident if you're on a 10-mile bicycle ride. So it's quite a rare thing to happen. And often these rare things are not discussed with the patient because then there will be a long list of things to discuss. And what's a 1 in 10,000 risk? That's about the sort of risk which some people will quote for risk of significant neurological damage, possibly from neuraxial block or from sort of a pain intervention or regional anesthesia block. So it's less than 1 in 10,000. And that's the same risk of a blood clot for a woman taking a birth control pill. And it's the same risk of a person being struck by the lightning. And that's an easy way to communicate with your patients to explain them how rare or how common this is. Now, I've put this last one, which is interesting because most people in anesthesia would sort of say, what's the risk? And so what's the evidence base, or how do you prove that anesthesia works? And this is an interesting paper. I would encourage you to read this. It's a bit of a joke, but there's a paper which says that there's a 0% risk of death or major injury from jumping without parachute. Now, on the face, it would look like it's a lie. But if you look at this RCT, which was published in 2018, it's a clever sort of way of interpreting what exactly is the risk. And what they did was they sort of recruited about 97 volunteers, and out of them, about 23 agreed to be part of the trial. So they randomized between somebody carrying a backpack without a parachute and somebody carrying a parachute. But this is exactly what they did. They did not specify, and this is important because in most of the studies, you have to read how was the methodology of the study, how was the interpretation, and how were the statistics looked at. They very cleverly presented the whole study, and very cheekily, they said that the aircraft was stationary and it was on the ground. And therefore, the risk of dying in somebody who jumps out of the aircraft is 0% if it's without a parachute or with a parachute. So just something to be mindful of when you're reading about accumulating the knowledge to understand the methodology of papers. So what's the risk of dying from traffic-related death? And I've put this slide. I probably wouldn't be standing in the middle of the road in Sagar or Bhopal or Delhi for that matter. And that's the risk of dying from a traffic-related death, comparing India and UK. And it's about more than 5 times of traffic-related deaths in the UK as compared to India. And these are figures from WHO. So this is, I think I would recommend that sort of you try and communicate with your patients based on this number scheme that has been published. And it says that high risk is more than 1 in 100 chance of something or of an event happening. And there, 1 in 1,000 is moderate, 1 in 10,000, 1 in 1,000 to 1 in 10,000 is low, and very low risk is 1 in 10,000 to 1 in 100,000, which is where you would probably want to discuss the risk of major neurological complications, stroke, things like that from neuraxial block or regional anesthesia block. And thereafter, you have things which are very, very rare, which is minimal and negligible. So then comes the question of what you decide you can offer as an intervention, which is either a pain intervention or a regional anesthesia block. So something that is necessary is never a risk. So if somebody needs a leg amputated because they've got gangrene, the conversation is very easy about what is a risk. Okay, if they did not have it, they are most likely to die. The chances of them dying from a sepsis is probably 100%. But if they had that operation, there's a risk of certain complications from the surgery itself, but it's a necessary risk. It's almost sort of saying that it's a 100% chance of you dying if you don't have it, but there's a lesser chance of you surviving. So lesser chance of you dying if you had it. So again, Neil and Rathmal have sort of in their textbook sort of given this quite a helpful little way of explaining what is risk, and it's either a non-observable, it is uncontrollable, it is observable, and it is controllable. And regional anesthesia, if you look at this, lies in the same category as a not observable and uncontrollable risk. In the same line of terrorism, nothing that relates to terrorism as such, but how you classify risk, and it's just an understanding for you to know what risk means, okay? And why do complications happen? I think everybody would have read this, a Swiss cheese model. When things line up, mistakes are happening all the time, but when the mistakes line up in a way that there is an inadequate technique, perhaps, there's a lack of supervision, there's a line of confluence of different factors like that, including poor communication, that line up, and therefore major incidents happen. It's relevant about a wrong side block in the same way as a wrong side surgery, because if you do a wrong side block, there is a chance that you might predispose the patient having a wrong side surgery, or even just a wrong side block can be quite catastrophic for the patient. So you have to be mindful of these things. That in England, the National Patient Safety Agency has put this as a never event. So the list of never event is actually a very, very strong message to say that this should never happen. And if it does happen, there's a root cause analysis after this in any institution. This is again from a Safe Anesthesia Liaison Group, which is part of the Royal College of Anesthesia. And they have a mechanism which is part of a national mechanism of National Reporting and Learning Service, and they have identified 67 wrong side blocks, 67 wrong side blocks from a period of 15 months, and majority of these blocks were given by the anesthetist. And they've looked at the reasons why this may have happened, and these include distraction of the anesthetist, lack of marks specific to the block, lack of anesthetic timeout, discrepancy between the operating list and mark or the consent form. And some reports stated that the site was marked, but covered up by drapes or obscured when the patient was positioned. This slide I presented in a meeting a few years ago, and so it's a relatively old slide, and it didn't mean much to me. And I can tell you by my personal experience that I've actually been at the receiving end where a drape moved and I was about to do a wrong side block till the staff around me sort of pointed out to me. So it can happen to anybody. And this is true for all of us. So Safe Anesthesia Liaison Group, you can look up the website, and they talk about how you report incidents, and there's a mechanism for anesthesia e-form, and we are expected to report that any sort of major incidents. There's another sort of paradigm shift in how the safety was managed, the risk was managed rather, in mismatch of spinal, epidural, and regional devices with incompatible connectors, because there were case reports in 1990s and 2000s where there were wrong connections of a local anesthetic of an epidural infusion set to an IV line, and patients have died. And based on those incidents, they came up with a solution for this. And that solution, which was implemented in 2017 in the country, involved a completely non-lever connector. So if you look at this connector, it's a completely different connector, which is not unlike anything you can connect to an IV line or a nasogastric tube. So this is a specific connector mainly to connect any neuraxial or spinal or epidural needles or infusion catheters. I'll try just get through to the next set of slides, which is about risk and interventional pain management. So the things I would talk about is the what happens if. Okay, I'll talk about the practice, the procedures can go wrong, the drugs can go wrong, needles can go wrong, equipment, the radiation safety, the anatomy, the procedures, and the implants. So what happens if something has gone wrong? In the medical legal context in the UK, which is a relatively evolved system for medical legal implication, because this is where we all sort of had to follow what was called as a Bolam test, and it was to determine what should be disclosed. So if I did a wrong site, so for example, let's say I gave a wrong drug, and the two drug ampules had a very similar label, and I ended up giving a wrong drug to the patient, but the patient didn't suffer any harm. What they would then discuss in the sort of court of law, and they would ask an expert as to what he would have done. And if he said that he might have made the same mistake as I did, then that is considered as, I wouldn't be charged, or I wouldn't be considered guilty, because it is a mistake that is likely to happen. So it was based on the support from a responsible body of clinicians. So it was a group of my colleagues who, if they supported me, obviously in a legal scenario in the court, I was okay. This changed, and this is very important because this will go across the world over a period of time. There's something called as the Montgomery Law, or the Montgomery case. This came to light in 2015, and this rejected what was so far being followed, which was the Bolam test for consent, and it introduced a patient-focused test to the law. So from a responsible body of clinicians, the focus changed to what actually the patient might say. And I'll just explain to you about that in the next slide. It talks about materiality, which is whether a reasonable person in the patient's position would be likely to attach significance to a certain risk. So this is what happened. Nadine Montgomery was a woman with diabetes and small stature, and she had a vaginal delivery in 1999. The child was born, but experienced complications with hypoxic insult. because of shoulder dystocia and thereafter suffered cerebral palsy. Her obstetrician had not disclosed the increased risk of the complication in vaginal delivery, and therefore she was not consented and taken up for a cesarean section. Despite Nadine Montgomery had asked if the baby's size was a potential problem and likely to suffer harm. So thereafter, she sued for negligence and she won, arguing that if she had known about the increased risk, she would have requested a cesarean section. So what this says is that it's not just a doctor who can make a decision, it's about patients' understanding of the risk and patients' involvement in that decision-making process. And this has changed quite significantly our practice in the UK, where we have to, for any simple or major procedure for pain or regional anesthesia, we have to discuss with the patient and agree with them that they feel that that risk is adequately explained for whatever the risks are for that particular procedure. So Montgomery law is a very important piece of legislature in the country. Duty of candor, this came about again in the last 5 years, and it's part of now the General Medical Council regulations, including the Nursing Council. And it's about your duty to be open and honest with the patients or those close to them if something has gone wrong. It is also your duty to be open and honest with your organization that you work for, and to encourage a learning culture by reporting the adverse events that lead to harm, as well as near misses. So what happens if something goes wrong? And I'm sort of the risk lead for my hospital for paid medicine, and I have to sort of do these discussions when things have gone wrong. It's very, very clear that these are the 4 points. You have to tell the patient or the carer or the family when something has gone wrong. You have to apologize to the patient, and you have to offer an appropriate remedy or support to put the matters right. And you have to explain fully to the patient the short and the long-term effects of what has happened and what has gone wrong. Now, most of you would think, you know what, this is all very good in the Western scenario, but it's not applicable to the Indian situation, where if you tell the patient that you have done something wrong, the relatives will come and bash you up. But listen, this is about culture. This is about not just the fear factor of you hiding things from the patient, but being open to the patient. You would know, most of you are, as adults would know, that when you have done a mistake, even in your personal relationships, when you apologize, you try and make the other person understand much better, rather than being defensive and saying, you know what, I have done nothing wrong. And it's putting that same culture in a patient-doctor relationship. And this is what slowly starts to transform the culture of healthcare systems. So saying sorry, I must say here, it is apologizing to a patient does not mean that you're admitting legal liability. So don't be worried. If you were ever in a court of law because you had said sorry to a patient, it does not mean that you've accepted liability. And there's a lot of legal support for this in the UK medical legal system. So moving on to, we have created a WHO surgical safety checklist for procedures under local anesthesia. And this was relevant because we have a slightly different setup. This has been supported by Faculty of Pain Medicine. They have a template for this if you want to look up. And it does not talk about the surgeon, but it talks about the operator, which could be me doing some procedure on a patient for pain conditions. And this is, again, something to help safeguard of the team. So the recommendations of, but I'm sure it's locatic toxicity can happen because of drug, too much of the correct drug route or wrong side. It can happen in ways. The wrong drug can be done because of the syringe mix-up, because of the because of a certain age group, for example, megalomania, because of hello, did my slides am I audible again? Sorry.
Yes, sir, but you are audible.
Did I miss a few slides? Sorry, my internet connection is probably playing up a little bit.
Yes, sir. The slide is visible.
I'll just go back, make sure that. Have I discussed? Has everybody heard this one? Okay, so I'll just go through quickly about the duty of candor is about being open and honest to the patient and to your organization so that there's a culture of learning. Everybody can learn from mistakes. In Indian scenario, yes, there would be challenges to be honest and open to the patient, but it does need a culture change rather than being defensive. You have to allow patient to be known that something has gone wrong and thereafter things should change. It takes time, it takes years, but this younger generation, we should be educating our patients. And if things go wrong, we should be saying sorry. It's okay to say sorry. You will not be legally liable if you say sorry. Sorry does not mean legal liability. And this is the safety checklist for procedures under local anesthesia. This is what can go wrong when you're doing regional anesthesia or pain interventions. There could be local anesthetic toxicity because of the wrong drug, because of mix up in the syringes, because of local anesthetic allergy, because of adrenaline or other additives, because of contamination and certain age group. And you prevent that by making sure the drug labeling is correct and you have had the patient history and knowledge of the pharmacology. You can give too much drug, and most of the anesthetists would know about the cardiovascular and neurological toxicity. I must pause here to reflect on my experience. I think this was 2002. I was doing my MD in Bhopal, and I was in this very meeting, and I presented for the TN Jain Professor Chansoria citation, which I was selected for, and I presented in the national meeting. And I remember I was asked about the mixed toxicity of local anesthetic drugs. And I still remember that question because at that time my answer was a bit woolly. I didn't get it quite right, and I'd lost the first spot. So those are the sort of learning points in memory about how you remember your drugs and how you remember different aspects of safety and safe practice. So neurotoxicity of drugs, this is all available in textbooks. I'll just glaze through this slide. Safety guidelines, when severe local anesthetic toxicity has happened, you can find it in the AAGBI safety guideline. This is all available online. Wrong route or wrong site. This is going back to where patients have died, and these are some reports in the press when the hospital had to pay out because a patient died when the local anesthetic was attached to, instead of an epidural infusion, it was attached to an IV drip. And there's also a very important note here about where the non-liver system started was from 2001 when a patient who was having treatment for leukemia had chemotherapy, and instead of prescribing it, instead of administering the drug IV, the doctor on the day gave the vincristine intrathecally, and the patient was then paralyzed and later on died. So this is where it all changed. Again, there's a lot to talk about. So I would just keep it brief about anticoagulation and interventions. It's difficult to make an accurate estimate of the incidence of complications related to coagulopathies because just the nature of reporting and what you can't do a randomized controlled trial for this. So what we think from the retrospective data that's been reported in literature, there's 0.4 to 0.5% serious thromboembolic risk with stopping anticoagulation. So therefore, it should be very carefully balanced with the risk of actually bleeding from surgery or from your procedure. And you have to remember that abnormality of coagulation, however severe, is always a relative contraindication. It's never absolute contraindication. And this is the list of procedure for understanding what are the low risk procedures, what are the intermediate risk procedures, and the high risk procedures. And this comes from the publication by the ASRA, which I think was the last slide. Unfortunately, the picture has gone missing. But this is the Sameer Nehru's and group's publication, and it has changed my practice. So for things like anything peripheral, which includes peripheral nerve blocks, sacroiliac joint injection, facet joint injections, and trigger point injections, musculoskeletal and joint injections, I don't usually stop warfarin or their anticoagulants unless there is a major vessel lying close by and I'm worried about it. For intermediate procedures, I normally stop. So that includes most epidurals, cervical injections, intradiscal procedures, sympathetic blocks, and trigeminal. For high risk procedures, you definitely have to stop. And if that means bridging with low molecular weight heparin, that has to be done for most things like spinal cord stimulators and epiduroscopies and such. This is another graphic from the AGBI and RA Regional Anesthesia UK's practice about classification of low or normal risk to high risk procedures for regional anesthesia. Sorry about this busy slide. It's a table from the Samir Narou's paper about what drugs you need to stop for how long for high risk, intermediate risk, and low risk procedures. So I keep this as ready reference for when I'm booking any patient for a procedure in my pain practice. And it involves the novel anticoagulants like dabigatran, the rivaroxaban, apixaban, indoxaban. Most of them have to be stopped for 3 to 4 days for high risk procedure. For low risk procedure, it says you have to discuss with the patient, the risk stratify them, and thereafter make a decision. Please note that antidepressants and serotonin reuptake inhibitors also have anticoagulation risk, and you therefore should be mindful of that, besides all the other drugs, including the clopidogrel, the prasugrel, the ticagrelor, and the GP2B3A inhibitors like abiximab. Should you discontinue aspirin? Now, this has always been sort of controversial to a certain point, but this is again a paper that came out in 2019 by the Manchikanti group in US, and they've said that there's a good evidence that you should discontinue the low-dose aspirin for the high and the moderate risk procedures for at least 3 days. Now, this is based on the evidence base for, obviously, for the high-risk procedures. In pain practice, that's important. In regional anesthesia practice, again, it's not so relevant unless you are doing a procedure like a lumbar plexus block, for example, or epidural, like a thoracic or a lumbar epidural. Okay. So more of the same from Narou's paper. Touching on steroids, and something that a lot of pain clinicians do. The practice changed again in the 2012-2015 period when there was contamination of a steroid formulation in the US, leading to fungal meningitis and about 60 deaths. And a lot of focus came on the steroid formulation. And they looked at all the data and they found that the size was also important. And this is the size of the particles of methylpred, triamcinolone, betamethasone, and dexamethasone, which is non-particulate.
Hello, sir. Sir, sorry to interrupt you, but sir, we are running a little late. So how many slides are left?
Yeah. I'm going to just go through the slides for. So these are all the publications for the steroid risk from steroid injections. This is, again, something I would recommend you would probably want to read about this. It's a Rathmel paper from 2015, and it talks about how the blood supply around the foramen, around the nerve root, makes it a high-risk procedure for all the cervical root block or cervical epidural injections. Just to try and close up things, I would want to discuss something that's relevant to an anesthetist here, and that is the procedure setup. And I make sure that everything here is not just aseptic, but also my trolley is not touching anything and everything is clean. And this is based on my teaching and learning from the contamination and arachnoiditis case that happened in 2001, where one of my professors at that time sort of encouraged that any contamination of chlorhexidine can happen on the tray. So any wet chlorhexidine and alcohol, which is neurotoxic, should not come in touch, including any sprays or anything lying in an open tray. So none of these things are in an open tray. Everything is in syringes. The chlorhexidine has been applied and dried before I start the procedure. Okay, so this is the setup. Most of you would be aware of the risk of posterior puncture headaches, and there are different needles. So I'll just whiz through these. One important point about vascular injection, which I think all anesthetists and pain specialists should be aware of, when your blocks don't work, when you've done an epidural injection, please be mindful that the risk of vascular injection is much higher than what you think. It's about 26% for a caudal epidural and 9% for a transforaminal epidural for lumbar and about 19% for cervical interlaminar. So, and I find this in my pain practice all the time because we have got a digital subtraction angiography, and every time I do an epidural, I make sure I've saved an image of a contrast spread, which obviously is not available for the anesthetic practice when you're doing an epidural. So please be mindful of this risk. Okay. I would just get to the end of the presentation and just remind you that corticosteroid has several risks, and that includes even a single injection can suppress the hypothalamic pituitary adrenal axis. Just be mindful of that. Be mindful of the immune response, and it can cause a dose-dependent suppression. This risk was mentioned during the outbreak of the COVID pandemic, but now the risk has been downgraded because there hasn't been any ongoing evidence, but initially this was a caution. Be mindful when you're doing epidural steroids that the glucose can go up, so be mindful in your practice. I'll probably stop at this slide and the next slide about minor and the major complications from epidural steroid injections. Most of the minor complications include vasovagal, accidental dural puncture, transient increase in pain, accidental disc puncture are considered minor. But the major complication, which includes ophthalmological, which includes retinal venous hemorrhage, neurovascular epidural hematoma and ischemia, and such, including direct trauma to the nerve, is possible. And please be mindful when you're doing these injections, epidural steroid injections, you understand the abnormal contrast flow patterns. I wouldn't go through these slides, and I'll just go to the last slide for any questions, but I'm happy to share my slides. Thank you.
Thank you, sir, for such a lovely presentation. So it was very enlightening to us and very knowledgeable. The question and answer round we'll do at the end of the third speaker.
Sure. Okay.
Thank you, sir. Now let's move on to the second lecture, which is by Dr. Shiv Kumar Singh, Predictors and Management of Perioperative Pain. Dr. Shiv Kumar Singh, MBBS, MD, FRCA, Consultant Anesthesia, Royal Liverpool University Hospitals, UK. He is a chairman, theatres and anesthesia, specialty audit and improvement lead, regional anesthesia lead, visit faculty, BIDMC, CTO, Idea Meds, editor anesthesia, pain in intensive care, journal and journal of anesthesia and critical care case reports, review central commissioner, faculty, research management system. He is having 30 years of anesthesia experience, 6 years in India and 24 years in UK. He's having publications 46 in total, book chapters 1 and chapter in teaching manual, book review 1 and review articles, editorials 4, original research and case reports approx 37.
Are you going to play my recorded video, or you want me to share screen? Okay. Good afternoon, everyone, and greetings from Liverpool, the city of Beatles.
So we are playing the recorded video.
Thank you, Amit and Satyendra, for inviting me for this MPISA WebCon 2021, which is your 35th annual conference of MP chapter of the ISA. So I've been asked to talk about managing perioperative pain, how we predict it and how we manage postoperative pain. My name is Dr. Shiv Kumar Singh. I'm a consultant in anesthesia. I work at the Royal Liverpool University Hospitals, which is part of Liverpool University Hospital Foundation Trust. So what is the ultimate goal in anesthesia and how do we achieve it? That's a big question. And I'll come to the answer later on part of the talk. We're going to use these two acronyms. We're going to arrest the pain as anesthetists. That's one of our jobs. And we're going to be smart. Anesthetists are always thought to be smart people. They're clever people. When you're called for an emergency, okay, there'll be a lot of people surrounding the patient. The moment the anesthetists arrive, everybody disappears. You are the Superman of the A&E or for the hospital. So we work smart as well. So the first part of arrest or arresting is assessing. Yes, assessing and predicting pain. So we're talking about predicting post-operative pain. It's about recognizing who is at greater risk of severe, moderate to severe post-operative pain. So why do we need to predict that who is going to be in moderate to severe post-operative pain? Why not just give morphine or fentanyl or tramadol to everyone anyway? So it has been seen that post-operative pain still remain undertreated in almost 80 to 85% of the patients. These patients with a wake up with moderate to severe pain in the post-operative period. This was seen in 2003 and 2014 and later on as well. So if the patient wake up with severe, moderate to severe post-operative pain and remain in pain, it leads to poor outcomes, which translates into increasing length of stay. It causes sleep disturbances because patient can't sleep with pain. It stops them from mobilizing. Okay, that might be because of the pain itself, or it may be because you have used more opioids to treat pain. It can also lead to delirium in the elderly because you're going to use more opioids or try to calm them down. And if you don't treat this postoperative pain adequately, it can progress to persistent post-surgical pain, or it can also progress to chronic pain syndromes. Not treating pain appropriately is associated with cardiopulmonary and thromboembolic complications as well. Some of them may be related to pain itself, and others may be related to the way you treat the pain with opioids. So what's the solution? Solution lies in understanding the preoperative pain predictors so that we can anticipate pain and we can individualize the pain treatment for these patients. Some patients are going to require greater amount of painkillers than others. So what are the predictors of poor postoperative pain control? So we're going to look at the various factors, and the first of them is looking at the sex or the gender. And it has been seen that females tend to feel 30% more pain than their counterparts. That translates into 11% more use of opioids in females than in males. So females are more prone to severe, moderate to severe postoperative pain. Then comes their age. So how is age related to pain? It has been seen that patients who are more than 50 years of age, that every decade, that is every 10 years, the pain reduces by 30%, or the requirement for post-op pain relief reduces by almost 30% as you become older. So the younger patients are more prone to severe postoperative pain. Smoking has been related to increased requirement for post-op pain relief. And then comes depression and anxiety. This is very important because this is a common factors in patients requiring more post-operative pain relief, but also in progression of the post-operative pain to persistent post-surgical pain and then to chronic pain. Whether depression is self-reported or it is diagnosed by a psychiatrist, it doesn't matter. Even mild to moderate depression or anxiety is associated with requirement for higher pain relief, greater pain relief in the postoperative period. Then preoperative analgesia use. This may be related to poor postoperative pain control. That is, the patient already has greater severity of pain even before the surgery. It may be related to opioid-induced hyperalgesia and to central and peripheral sensitization of the pre-existing nociception. So these patients are going to require greater pain relief than their counterparts who do not use opioids or other analgesia before the surgery. Obesity is mildly linked to increase. It is not a great one to include in the predictors, but sleep difficulty has been. But this may be indirectly related to presence of anxiety and depression. We know that patients who have anxiety and depression don't have good sleep at night. So these patients also require greater amount of pain relief in the postoperative period. So all this has been studied by multiple authors. So there's a whole list of these papers which have been used to synthesize the results and create a simple kind of scoring system. So it was a meta-analysis and that looked at more than 50,000 patients. And then they put up this forest graph and you can actually see the odd ratios. So anything which is more than one is actually important. That affects the outcomes. So if you look at the younger age, which was seen in 14 studies and females in 20 studies, you can see that the odd ratio is more than one. That means it is a significant factor which affects the outcomes. So is smoking, history of depression, history of anxiety, sleep difficulties. They rank highly. Okay, presence of preoperative pain and preoperative analgesia use rank highly. Whereas BMI is more near to 1, so that's why it's not a very important factor, but still can be considered. So how has severe postoperative pain been defined for study purposes? So worst pain since surgery where the NRS scores are more than or equal to 7 points is considered as severe postoperative pain. So the simple risk score system for predicting these, severe postoperative pain consists of obviously if the patient is female or not. So if the patient is female, then you get 1 point. If the patient has persistent pain of NRS intensity of over 3, so even mild to moderate pain, you get 1 point. If the patient is using opioids before admission, you get a 1 point. Now look at the age. Now, if you're less than 30 years, you get 2 points. So if you're a female in less than 30 years, you already have 3 points. Patients for 30 to 49 get 1 point, 50 to 70 0 points, and more than 70 minus 1 point. So elderly patients tend to actually have less amount of severe postoperative pain. Now, not treating the post-op pain appropriately or letting it persist can lead to persistent post-op surgical pain, PPSP, which can then progress to chronic pain. So when you have an acute injury, there is, you have, tissue injury, which is, surgical or anyway. The acute pain which is associated with this usually resolve because of the healing process. Now, healing process will take around 7 to 14 days at the most, but it can take as long as 3 months in certain conditions. So anything which is, between 2 weeks to around 3 months, it could be persistent post-surgical pain. But if the pain persists beyond 3 months, that is the definition of the chronic pain. In UK cross-sectional study, observational studies, which was reported in 2016, they looked at the post-op pain in the first 24 hours, and 11% reported severe pain. Now, this is later on. So I talked about the study in 2003 and 2014. Now, this is 2016. And 37% reported moderate pain. Okay, so 11 reported severe pain, 37 reported moderate pain. So we are slightly better off. Then there was PQ study, that the perioperative quality improvement program. The report came out in 2017, included 2017 to 2018, and then 2018 to 2019 data. And this data was collected from 79 UK hospitals. And they looked at, again, surgical site pain in the first 24 hours. And this also showed that moderate pain was seen in 48% of the patient, and 19% of the patient actually suffered from severe postoperative pain. Now, that's not good. This is despite all the advances in pain management, understanding how pain can be treated. Now, this is not only in UK. A German prospective cohort study, which was published in 2013 in anesthesiology, compared 179 surgical procedures and more than 50,000 patients. And their results showed that 47.2% experienced severe pain. This is NRS score of about more than 8 or nearly 8 in the first 24 hours after surgery. This obviously was variable depending on the type of surgery performed. But what is important to know that all these hospitals actually had acute pain services, inpatient acute pain services. So despite having the acute pain services, the patients are still suffering from moderate to severe postoperative pain. So what are the concerns with poor pain control? I've already talked about the outcomes. The most important thing is that the pain should not progress to chronic or persistent post-surgical pain, because this is associated with the long-term psychological, social, economical adversities. And optimum pain control is it is a humanitarian thing. Everybody should actually have good pain control, and it's also important for delivery of efficient health services. So if the patient actually have pain, they will stay longer in the hospital. They will need opioids. There will be associated complications, nausea, vomiting, constipation, drowsiness. Okay, so cardiorespiratory complications will increase. Thromboembolic complications will increase because they will remain in bed. They're not able to mobilize. Okay, so there are actually concerns with poor pain control. So this is a statement I'm making that postoperative pain management should be a priority for everyone. It should be core part of patient care and outcomes. It is a very essential aspect of patient care. And it's also important that the pain management is individualized. Not everybody requires the same amount of pain care. Some will require less, others will require more. And that's what I've discussed in how you predict pain. If you give too much morphine to elderly, you're going to have more complications. Whereas if you give less amount of morphine or the same amount of morphine to a young patient who is in his 20s, he will still continue to have pain. So it is in the top 5 national improvement opportunity to influence care of surgical patients, that is individualizing pain management, having specific pathways or having various multimodal analgesia pathways for specific surgeries is part of national improvement opportunities. So coming back to the first question I asked, what is the ultimate goal in anesthesia? See, ultimate goal in anesthesia is about dreaming, okay, having a good sleep and be able to wake up smiling and saying cheers. Okay, cheers here actually is about carbohydrates. So there are certain things we need to achieve in the pre-op. Patients should not feel hungry, so they should have carbohydrate load. This is part of the early recovery after surgery, the ERAS protocols. They should be hydrated. They should not be thirsty. So patients should be allowed to drink water till at least 2 hours before the surgery. These two things will ensure the patient is euvolemic. That is, the patient has right amount of fluid. This will also ensure that patient is eunatremic. That is, sodium levels are within the normal range. Once this is done, they're ready to start dreaming. Okay, so they go to the theaters. Obviously, there is a lot more here to that. But once they wake up, if you apply these protocols, the ERAS protocols, the various multimodal analgesia protocols, then patients should be able to drink as soon as possible. They should start eating and drinking, and they should be able to mobilize as soon as possible. So that is the dreaming. So DR is for drink, EA is for eating, MING is for mobilizing. Okay. So these are the the outcomes we look at. Are the people able to do that? Certain patients are going to be really unhappy with the kind of care they might be provided. So what are these things which makes patient unhappy? So first of them is awareness under anesthesia. Okay. So we're not actually discussing awareness, but appropriate level of anesthesia need to maintain for all patients, especially if they're under general anesthesia. This is what we are talking about, that patients should not wake up with moderate to severe postoperative pain. Some patients will wake up with some pain, but you should be able to actually manage that appropriately. Patients should not feel sick, so you should give the antiemetics intraoperatively. You should be able to actually score them for post-op nausea and vomiting using Apple score. Okay, so history taking is very, very important. And then also write up for post-op antiemetics. Especially if the patients are going to wake up pain, you will likely end up using opioids. And that means if you use opioids, even a single dose increases the risk of post-op nausea by almost 33% in patients. So you need to actually prescribe them antiemetics. So how are we going to achieve our goals? We're going to achieve our goals by being smart. So what is the smart? So I'm going to talk to you about, go through this smart thing. So first thing in smart is about structured approach. It's about pre-assessment and planning. Okay. So the optimal pain management starts even before the patient actually goes under the knife. That is before the surgery. So this need to start in the pre-op assessment. The pre-op assessment should include a column for or section for pain management, where you're going to actually discuss with the patient, what kind of pain relief are you going to provide? Are you going to give an epidural? Are you going to give a spinal opiates? Are you going to do blocks? Or if the patient is not ready for that, are you going to plan for a PCA morphine or oxycodone? You can also educate them about taking their painkillers regularly in the post-operative period. You talk about their expectations. What do you think? What kind of pain they are expecting after surgery? Are they expecting lots of pain after surgery, or are they think that the pain will be controlled well? When do they expect to go home? And then comes delivery of care. Who's going to deliver this care, and has it been communicated to them? What are the requirements for that specific patient? So there is need to be a structure to how the pain management is done perioperatively. So that is the first of the SMART. Then comes the multimodal analgesia, MMA. So there is no single perfect analgesic drug. It's no magic bullet that you give one drug painkiller to the patient and you think you have sorted out everything. No. So multimodal analgesia not only requires pharmacological interventions, so various agents we will talk about in a minute. It also requires use of regional anesthesia technique, whether it's a central neural axis like the epidurals, spinal opioids, or continuous catheters. It also involves psychological preparation of the patient, knowing their expectations and preparing them through the journey they're going to go through from the time they come to the hospital till they are discharged from the hospital. You need to have the idea about the surgery, okay, how much tissue damage the surgery is going to cause the patient. Certain surgeries are associated with more pain than a superficial surgery. For example, if you're having a thoracic surgery, the rib resection, they pain like hell. Okay. Whereas if the patient is coming for a lipoma excision, now that's not going to be very painful. Then again, there are certain surgeries which are associated with persistent post-op surgical pain and progressing to chronic pain. Now, mastectomies, hernias, amputations, these patients need to be treated slightly different to someone who is just coming for a lipoma excision. You need to assess and reassess pain. So you get a patient, you actually have given them morphine, you need to come back and see how the morphine has affected the pain. Has the pain scores come down or not? You tend to continue to assess and reassess till you reach your target of low VAS or NRS. The patient should say the pain is no worse than mild pain. Okay, that means almost near to scale of 1 to 2, or even 0 for that matter. You do not let the patient go to the ward with moderate to severe pain. You need to target that pain control. And that's why it is important to assess and reassess pain and treat it appropriately. And that's where the SMART comes in. So it's structured approach, multimodal analgesia, reassess the pain again and again, and target to a low VAS or NRS scale. Now we're going to go through some pharmacological agents which we use in multimodal analgesia. They should be part of your armamentarium. I'm now going to talk about opioids. Everybody has their own favorite opioids. Some like fentanyl, some like morphine, some like tramadol, some like, there is whole range of opioids. We're not talking of opioids. Rather, ERAS protocol likely aim towards using as less opioids as possible as part of multimodal analgesia. It's also important to understand the pain pathway, the ascending pathway and the descending pathway. So the ascending pathway consists of transmission of pain, modulation of pain, and the perception at the higher center. So that's our ascending pathway. We have A beta fibers, A delta fibers, and C fibers, and then we actually have the gating mechanism in the dorsal horn, and that's where the descending pathway comes in. So descending pathway can actually affect the way you perceive pain. So the higher centers actually affect the modulation of pain at the dorsal horn level. So modulation occurs via the descending pathway. So when you're looking at pain management, you want to actually facilitate descending pathway, whereas you want to inhibit the ascending pathway. So multimodal analgesia looks at using various agents along this pathway. Locally at the peripheral nociceptors, we can use local anesthetic infiltration of nerve blocks. We can use anti-inflammatory agents like COX-2 inhibitors. So we can use dexamethasone as well, which is also anti-inflammatory. Paracetamol can also help in pain relief at the peripheral level. Then at the sensory fiber levels, before it reaches the dorsal horn, we can use local anesthetic via peripheral nerve blocks or catheters. At the spinal level, you can use local anesthetic along with opioids or alpha-2 agonists, NMDA antagonists, COX-2 inhibitors. And then centrally, we can actually look at the opioids, so they work at the higher centers. Then look at alpha-2 agonists, so we have central effect of alpha-2 agonists like your clonidine and dexmedetomidine. Paracetamol, okay, it's metabolite. The anandamides actually work at the central level. Then you have NMDA receptor antagonist, ketamine, magnesium sulfate. Then, of course, we have our general anesthesia itself. Okay. Paracetamol, everybody knows, 1 gram of paracetamol, if given at the end of the surgery 20 minutes, is known to reduce the morphine requirement in the first 24 hours. The numbers needed to treat if it is used on its own is 3.6. So lower the NNT, the better it is, that is more effective it is. So the paracetamol becomes a lot more effective if it is combined with 400 milligrams of ibuprofen, 400 milligrams given every 8 hourly. So the NNT comes down to 1.5. If you actually combine with codeine, 60 milligrams, NNT is 2.2. That's because certain patients do not convert codeine to morphine. So there is a pharmacogenetical reason for that. And then if you use it with 10 milligrams of oxycodone, it is reduced to, NNT is reduced to 1.8. So paracetamol combined, so you can actually combine with ibuprofen and codeine and oxycodone, all three, then you can see that how effective it is going to be for treating pain. Anti-inflammatory drugs, steroidals and non-steroidals, are equally important part of multimodal analgesia. But you need to be careful that there are side effects associated with the use of non-steroidals, like acute kidney injury. So patients who have deranged renal function, you're not going to use it. Elderly patient who are especially dry, you're not going to use it. The colorectal surgeons are worried about the anastomotic leaks with the use of the non-steroidals. There is considered to be increased thromboembolic events and worsening of cardiac failure. This has been seen with COX-2 inhibitors, but that is with long-term use. And dexamethasone can cause hyperglycemia. So especially in insulin-dependent diabetic patients, it can cause hyperglycemia. So anti-inflammatory are still very good as combined with paracetamol provide good pain relief. And we tend to use dexamethasone 4 to 8 milligrams at induction. And it not only helps as an anti-inflammatory, but it also helps in Hello, the audio has stopped completely. Hi, Naya, there's no sound. Is anybody listening? There is no sound to the audio. There's no audio at all.
Hello, sir. So
Yes,
there's
Neha.
so there's some problem with the sound, or people are not they are not able to hear it. So can you sir continue? Can you go live with this with the PPT?
This is just as the end, almost the end of the recording now.
Yes, sir.
I mean, I can just talk over this anyway.
Sure, sir.
You want me to start talking from here? You can start playing that.
So you can start from previous 2-3 slides.
That's fine. It's okay. We can start from here.
Yes.
It's fine. Or we can go from the gabapentinoids, I think. Now what's happening now? Are you able to see my screen?
Yes, sir.
Okay, I'll have to actually just click over to. Yes. So gabapentinoids, they
Yes, sir,
actually
start.
affect both the ascending and descending pathways. So they are actually affecting both your nociceptive pathway and the affective pathway. That is what has been the descending, where modulation happens. Now, the very previous studies on meta-analysis actually have shown that gabapentinoids are not of much use in management of acute pain. But as recently as last week, they came up with this study which was presented at ASA. This comes from the Harvard Medical School. And they have shown that using low and moderate dose gabapentin or pregabalin actually reduces with the readmission at 30 days. And they think that this is because of lower use of opiates, because the patients have been given gabapentinoids. So we tend to actually use gabapentin at the dose of 300 to 600 milligram orally. And more than gabapentin, we actually use pregabalin. So patients are actually, started on pregabalin, 75 to 150 milligrams orally, especially for our limb arthroplasties like TKRs and total hip replacement or limb reconstruction. These patients will be actually put on pregabalin in the preoperative period. Alpha-2 agonist, India probably has got a lot more experience with dexmedetomidine than we have. We have clonidine available to us freely, but not dexmedetomidine. And obviously, clonidine can be given orally, but dexmedetomidine is basically IV. You can use it along with local anesthetic for nerve blocks. You can also administer it intrathecally, even though it's not FDA approved. Clonidine, again, we do use it IV, small boluses. I use a dose of 30 micrograms as infusion over 20 minutes, added to paracetamol IV. And some of us actually use intrathecal clonidine, 30 to 50 micrograms, along with our heavy bupivacaine or liver bupivacaine. It's used. So they are very, very effective. So alpha-2 agonists are actually present. Receptors are present not only peripherally in the spinal cord and in the central system as well, and they tend to actually reduce our sympathetic flow, and that's why they cause not only by vasodilation, local vasodilation, but also by sympathetic flow, and that's why they can cause hypertension. And because they are augmenting the endogenous opiate release and modulating and facilitating the descending noradrenergic pathways, they can also cause bradycardia. That's seen more commonly with dexmedetomidine, which is more of alpha-2 specific. Specificity around alpha-2, alpha-1 is almost 1,600:1 as compared to clonidine, which is only 220:1. The next agent, which is actually important part of the MMA, is magnesium sulfate. So this is usually given at the dose of 30 to 50 milligrams per kilo. We give it as infusion, slow infusion. And this is important to do that You don't want to actually give it too rapidly because it can cause hypotension and bradycardia. So give it slowly as an infusion, never give it as a bolus. You can use it as an infusion as well. The greatest advantage of magnesium sulfate, it not only potentiate your analgesia or reduce the requirement for opioids, but it also reduces your shivering, post-operative shivering. Okay, it reduces post-op nausea and vomiting. So that's a great advantage of magnesium sulfate. And people have always asked me, they say, oh, does it not affect the neuromuscular blocker? Yes, it can, but not to great extent. And can it cause toxicity? That's only possible if you actually are going to use, or the levels are going to go about 4 to 5 millimoles per liter. So normal levels of magnesium sulfate is only 0.7 to 1.1 millimole per liter. And to actually get to the level of 4 to 5 millimole per liter, you need to actually almost give 4 to 5 times this dose. So you're not going to get that kind of effects of that. Then we all know where the ketamine and the magnesium work. This is the NMDA receptors. They also block the calcium channel. So they are acting at NMDA receptors. Magnesium as a blocker, NMDA receptor blocker. The next thing which has been very topical is using lignocaine for pain relief. What the recent meta-analysis actually have shown that actually it's okay to use lignocaine only for the colorectal surgeries. That's the only place it has been shown to be effective. In other places, they have not shown it to be as effective. And this may be related to because the doses used on the studies is very variable. People have used doses as much as 1 to 5 milligram per kg, which is very high dose. So I would take this with a pinch of salt, and you can still use lignocaine for other surgeries as well. So the loading dose is 1 milligram per kg. You can use it at the time of induction or intraoperatively. This can be followed with an infusion of 40 microgram per kg per minute. And then it is reduced to 0.5 to 1 milligram per minute. That is approximately 60 milligrams per hour. And this is continued into the post-op care unit, that is the recovery, and then into day 1. So same dose is used, and by day 2, you can actually stop it. Now you can actually see that even if you actually infuse the lignocaine for 3 days, the context-sensitive half-life, that is how quickly the lignocaine will be metabolized, is only around 20 to 40 minutes in most patients. And again, the toxic doses, you have to be careful. Like if you actually see, you only see neurological symptoms in patients where the plasma levels exceeds more than 6 microgram per ml. If it goes up to 10 microgram per ml, then you will invariably see CNS effects. Okay. And the normal therapeutic range is narrow for lignocaine. It's only 2.5 to 3.5 microgram per ml. So, if you're having any doubts, you can always get plasma levels of lignocaine actually done for that. Lignocaine is not as cardiotoxic, so you normally only see cardiotoxic effects of lignocaine with levels more than 10 microgram per ml. So it's a pretty safe drug. So even though it has got a narrow therapeutic index, it's still a very safe drug to actually use. Regional anesthesia, I'm not going to go into details because itself is a big topic on its own, but regional anesthesia, whether it's epidural or it is just spinal single shot opioids, which is very commonly used in the ERAS protocols, using abdominal blocks, using peripheral nerve blocks, they're all important part of multimodal analgesia. No, epidural has fallen out of favor for prolonged surgeries, so like the abdominal surgeries or laparotomies. It is very effective form of analgesia. We all know that. But the problem with epidural analgesia is that these patients can be tied to the bed because you need to use an infusion pump. So mobility is reduced. And like I've been saying before, one of the things for ERAS is mobilizing. So dreaming is drinking, eating, and mobilizing. It's very good for eating and drinking because it maintains the gut motility. So that's very, very good for that. But it stops mobilizing. They can actually have motor blockade can be there some amount. Even if you're using very low concentration, you can still have motor blockade. There are actually patients who have fallen after only using 0.125% bupivacaine infusion. So what's more topical is actually using intrathecal opioids. We tend to use diamorphine around 500 micrograms, so 300 to 500 micrograms of diamorphine is used intrathecally as a single shot for the abdominal surgeries. Other people use fentanyl, some use morphine, but these are very useful. For abdominal blocks, again, you need to be careful with ultrasound. You need to actually have that expertise so that you don't go into the peritoneum or into the liver if you're on the right side. And now the other thing which is very topical is rectal sheath catheters by the surgeons. Some of them have shown good results, but we're also seeing complications of them. The catheters getting knotted, catheters actually getting into the suture line, patient coming back to theaters for removal of these catheters. So something which we need to look forward to. And then there are neuroblocks like erectospinal blocks, which are more of a universal block, can be used for anywhere in the thoracic to abdominal surgery to neck, head and neck surgeries. So for the recovery, please don't forget to prescribe the pain relief, additional pain relief, because despite your best of your blocks and multimodal analgesia, patient can still wake up with pain. And don't forget that because if you use opioid, even a single dose of fentanyl is enough to cause post-op nausea vomiting in almost 30 to 33% of patients, just a single dose. So don't forget to prescribe your ondansetron, cyclizine, Stemetil for post-op recovery. Post-op instruction for home or for wards are important. So this is WHO guidelines saying that the anesthesia should be given by mouth and by the clock. So preferred route for administration of analgesia should be by mouth. So giving it orally and giving by clock. Do not just not on demand. So it should not wait for a patient to actually ask for analgesia. It should be delivered by the clock. And as the drugs, most of these, like analgesics like paracetamol, ibuprofen are easily available and can be taken orally. Make sure that ibuprofen or non-steroidal anti-inflammatory drugs should be given with food 3 times a day, or prescribe them some for PPIs. There are fixed dose multimodal combination available, and there is a combination of paracetamol and tramadol easily available, paracetamol and ibuprofen, and there are also ibuprofen and codeine sulfate is also available. So multi-dose combinations actually help in a post-op analgesia, especially for patients going for home. I've seen a lot of Indian elderly not wanting to take tablets. They have some kind of allergy to actually taking tablets. So giving all analgesic in a single dose actually helps in that. And like I said, don't forget your PPIs if the patient is going to be on non-steroidals. So coming to the end of the lecture, in summary, we need to identify predictors of the poor postoperative pain control preoperatively, and this will actually help us in individualizing their treatment. It will better our pain management. And because we are bettering our pain management, this will also reduce our requirement for opioids in the postoperative period, which have their own associated complications. There need to be increased awareness about these predictors. Even the anesthesia fraternity, I think lots of you will be actually hearing about this predictor for the first time. I spoke about these predictors last week at the ISA Thrissur meeting, and a lot of people obviously haven't heard about them. There is similar predictors for chronic pain, which I have talked about in my lectures on chronic pain. So what this will help is in developing very personalized, very discipline-specific clinical care pathways. That is, you can have multimodal analgesia strategies for specific group of surgeries. So you can actually say 4 thoracic surgeries because they have high pain killer requirements and they have greater post-operative pain, we can actually have such and such protocol. Every patient should get these at least. And because if we're going to have a better pain control, this will reduce the length of stay in the hospital, and this will also reduce our perioperative medical complications. I say this all the time, adequate pain management is based on multimodal analgesia. And for this, you need to know your doses. You need to know what the side effects are. For example, patients who have got acute kidney injury or chronic kidney injury or elderly patient, you need to reduce your doses or maybe increase the duration between the doses. And the adequate pain management will actually help patient achieve dreaming. So they're able to drink early, eat early, and mobilize early, which are the outcomes for the early recovery from surgery. And favorite of all of us, regional anesthesia is important part of the multimodal analgesia. It does not matter whether you know how to do blocks or not. At least the surgeons can actually use local infiltration anesthesia or put like rectus sheath catheters for abdominal surgery. All these are going to be very useful for management. Okay. Thank you very much for listening to me, and thank you for giving me the opportunity to talk to you, all of you. I'm happy to take any questions now. Thank you.
Thank you so much, sir. We are so privileged to have you today, sir. And your lectures were so amazing, sir, and so informative. And so we know that you also take teacher and student video group sir, in YouTube. So much, sir, thank you for everything.
I will post this lecture as well because I've already recorded it, so it'll be easy for me to just post it on the video, on the YouTube. So I will post it today itself. I'll post it so people can actually listen to it if they have missed it out or not been able to listen to all of it.
Thank you, sir. And sir, question and answer now we'll be doing after this third speaker, Vaishali.
Yeah.
Thank you, sir. So now next we move on to our third speaker, who is Dr. Vaishali Windiskar, and she'll be giving a lecture on analgesic adjuvants in peripheral nervous system. Dr. Vaishali Windiskar, she is a professor and head Department of Anesthesiology, Critical Care, AIIMS Bhopal. She has experience of 20 years, and her main region of interest is pediatric anesthesia, pain and palliative care, thoracic anesthesia. And she has a many number of published papers, 35 original research articles and case reports, and reviewed many original article case reports meta-analysis. And she has attended many CME and workshops on pain and palliative care, mechanical ventilation, chronic back pain, cancer pain management, artificial intelligence. She is a member of many national and international associations. She chaired the sessions in state and national conferences and delivered lectures on WHO safety programs, CNB in spinal surgeries in national conferences. And we are very pleased to have you here, ma'am. Let's start the lecture.
Good afternoon, everyone. I'm Dr. Vaishali Windiskar, Professor, Department of Anesthesia and Critical Care, AIIMS Bhopal. I wish you all a very happy World Anesthesia Day. And I would like to thank the organizing committee of Mpisa Sagar for giving me this opportunity to present this topic on analgesic adjuvants in the peripheral nervous system. Coming to the historical background of local anesthetics and peripheral nerve block, cocaine, the first local anesthetic isolated by Niemann in 1860 from the leaves of coca tree. Its anesthetic actions were demonstrated by Karl Koller in 1884. Halsted performed the first peripheral nerve block in 1885. Epinephrine was isolated by John Abel, and Heinrich Braun in 1903 recommended the addition of adrenaline as a vasoconstrictor to local anesthetics. The first effective and widely used synthetic anesthesia, that is procaine, produced by Ethon in 1905, and it was introduced in clinical practice by Braun. Intravenous regional anesthesia, which is also known as the bias block, was first described by August Bayer in 1908. The lignocaine was introduced by Lofgren in 1948, and these anesthetic properties by T. Logard in 1949. So what are peripheral nerve blocks? Peripheral nerve blocks are type of regional anesthesia technique. The anesthetic is injected near a specific nerve or bundle of nerve to block the sensation of pain from a specific area of body. Adjuvants are the drugs which when co-administered along with the local anesthetic agents, they improve the latency of onset and duration of analgesia and counteract the disadvantageous effect of local anesthetics. Regional anesthesia techniques, including the peripheral nerve block, have also become the need of an hour during the recent times of COVID-19 pandemic. As per the recent practice recommendation, American Society of Anesthesia in 2020, the regional anesthesia is preferred to avoid the aerosol generating procedures associated with the general anesthesia. There are several methods affecting the prolongation of analgesia, that is continuous techniques with catheters, liposomal forms of local anesthetic agents or adjuvants. Due to numerous limitations and problems associated with the catheter techniques, these techniques are not preferred. There are issues with the availability of the liposomal local anesthetic agents, so only the adjuvants which are available for prolongation of the peripheral nerve blocks. These adjuvants are broadly divided into non-opioids and opioids. The non-opioid agents are vasoconstrictors. These are epinephrine or phenylephrine, referred to adrenoreceptor agonist, clonidine or dexmedetomidine, anti-inflammatory agents, then acetylcholinesterase inhibitors, that is neostigmine, adenosine, ketorolac, midazolam, magnesium sulfate, verapamil, sodium bicarbonate, and dexamethasone. Then in opioids, they are lipophilic, fentanyl and supentanyl, and hydrophilic, that is morphine. The classification of the block. Basically, the regional anesthesia techniques are divided into central neuraxial block, peripheral nerve blocks, and IV regional anesthesia, which is again a part of peripheral nerve blocks. Then central neuraxial block is divided into subarachnoid and epidural block. Peripheral blocks are divided into truncal blocks, plexus block, distal block, field and topical anesthesia block. IV regional anesthesia is again, we can say, is the peripheral nerve blocks, because the procedures on the arm or fingers can be done under this anesthesia, or the procedures on the leg or foot can be done by using the intravenous regional anesthesia. The advantages of peripheral nerve block are superior pain control, higher patient satisfaction, improved patient safety. It avoids the GA-related complications. Patient remains awake, and so the communication is possible. Hemodynamic stability is more compared to the neuraxial and general anesthesia block. It is associated with the less post-operative nausea vomiting because of the less opioid use. Post-operative analgesia can be continued with the help of catheters or adjuvants. It is associated with better cognitive function because of less sedation use or less opioid use, and this is basically important in patient of pediatric patients. Early discharges are possible, mobilization can be done early, and it is safe in the remote locations and comparatively cheap. The disadvantages. The advantages of peripheral nerve block are superior pain control, higher patient satisfaction, improved patient safety. It avoids the GA-related complications. Patient remains awake, and so the communication is possible. Hemodynamic stability is more compared to the neuraxial and general anesthesia block. It is associated with the less post-operative nausea vomiting because of the less opioid use. Post-operative analgesia can be continued with the help of catheters or adjuvants. It is associated with better cognitive function because of less sedation use or less opioid use, and this is basically important in patient of pediatric patients. Early discharges are possible, mobilization can be done early. And this is the PNS. So what are the indications and contraindications? Indications are basically of the individual blocks. Like if you are planning the interscalene block, then you should know the now supply of that particular area where it is going to supply. Like shoulders, if the shoulder procedures are there, then you can give the interscalene block. If there is procedure on the forearm, then the axillary block can be given or supraclavicular block can be given. But if the surgeon is planning tourniquets and if you are giving the axillary block, it is not going to help you. So proper anatomical knowledge and proper supply of the particular area is very important. In general, the indications are for outpatients, for day care surgery patients, patient at high risk of respiratory depression unexpected to GA, and if any patient, if you want to avoid the systematic medication in those patients, these are the indications. Then what are the contraindications? There are some absolute contraindications, that patient refusal, then coagulation disorder, that is DIC and hemophilia. Anticoagulation drugs is again one of the contraindication, and then the infection at the site of puncture, then the ring block at the site of end arteries like fingers and toes and penile artery. Then the local anesthetic, allergy and anaphylaxis. These are the contraindications. Then the relative contraindications are uncooperative patients, then surgeons which are not compatible with these peripheral nerve blocks, then uncertain duration of surgery. If you are putting the catheters, then there is no issue, but if you are only planning to give some adjuvants and procedures are long, then definitely this is the contraindication. Then the bloodstream infection and the peripheral neuropathy. This is the PNS system which is used for the peripheral nerve block. Here you can see the display screen, and which is the knob to adjust the current. Selection of the current is important, because if you are getting the stimulus of more than 0.5 amplifier, the chances of failure are more, because the distance between the nerve and the tip of the catheter is more. And if you are getting the stimulus with less than 0.5 amplifier, then the chances of intraneural injections are more. And this is the disposable manometer to monitor the pressures, and ideally it should be less than 15 psi, and if it is the more than 15 psi, that means the chances of intraneural injections are more. Here you can see the 3 different infusion pumps designed for the perineural local anesthesia infusion. These are manufactured by different manufacturers, having different programs, inbuilt programs. The first one is the elastometric device with the adjustable basal infusion rate and 5 ml patient control bolus function. Then the second one is the electronic device with programmable basal infusion rate and patient control boluses with lockout duration, and maximum total infusion volume can be adjusted with this electronic device. And this third one is the electrometric device with a manufacturer determined fixed basal infusion rates without a patient control bolus in. So these systems can be used for the continuous perineural local anesthesia infusions. USG guided blocks are very commonly used nowadays. You need the knowledge of USG for performing these blocks. These blocks can be seen. The preoperative assessment before performing the block should include the baseline vitals and the systemic examination. Laboratory testing, the CBC and the coagulation profile. Weight of the patient is important in pediatric patients, and if you are planning the block for palliative care purpose, then the weight is important. Then the current medical problems, if any patient is having, past history of medical events, whether patient has been exposed to local anesthetic agents previously, any history of any allergy or hypersensitivity reaction, and the mental status, which includes the emotional state and the level of consciousness. Then the communication ability of the patient, whether patient is having any hearing impairment or any language barrier, that should be documented in your PSC form. The block should be performed in the designated room or block room or in OT, where the resuscitation equipments and the drugs are available along with the anesthesia machine. The minimum monitoring which is required is the ECG, NIBP and pulse oximeter. Intravenous access is must, and the block should be performed under all aseptic precautions along with the patient consent. And adequate knowledge of the technique and how to manage the complications is must before performing any block. The equipments and drugs which are required for the peripheral nerve blocks are PNS with ECG electrode, unipolar insulated B-bevel needles, and the sizes which are available are 20 to 25 gauge and 25 to 250 millimeters in length. The catheters for continuous perineural infusions, then USG machine if you are planning for the USG guided block, and local anesthetic drugs and adjuvants. The choice of the drug depends on the various factors such as the duration, intensity, and the level of anesthesia desired, the anticipated surgical position of the patient, and the surgical procedure. These modifications, some modifications which are done in the local anesthesia just to increase the efficiency and efficacy of the drug. This modification can be done either by mixing of the local anesthetic agents or by mixing the drugs which are not local anesthetics. These are known as the adjuvants, which eliminate the need for continuous catheters and thus reduce the risk of catheter-mediated infection. There are certain characteristics which are desirable and needed in a drug to be labeled as ideal adjuvants. They are physical properties and the pharmacological properties. The physical properties are easy solubility, easy miscibility, so that there should not be any precipitation when they are added to the local anesthetic agents. They should be non-irritable when they are injected, and they should increase the pH of which results in increasing the proportion of the active ingredients of the local anesthetic agents. They should have longer shelf life, so that they should be stable, and there should not be any need to add the stabilizer or preservative. The following are the pharmacological properties that should be there in the local anesthetic adjuvants to be labeled as ideal adjuvant. They should enhance the onset of action. They should prolong the duration of action. There should not be any inherent systemic side effects, and not only enhance the efficacy of local anesthetic agents, but they should have their own inherent local anesthetic activity. They should have higher potency so that the requirement of dose is minimal, and they should maintain a rapid and steady peak of action, and they should be completely devoid of the systemic toxicity. This is the table which shows the commonly used adjuvant drugs to local anesthesia for producing the peripheral nerve blocks. The first one is the buprenorphine, which is the opioid and is used in the doses of 150 to 300 microgram in adult patient. The limitations are it produces the side effects of postoperative nausea, vomiting, sedation, respiratory depression. It has not received the Food and Drug Administration approval for the neuraxial or perineural administration. The second one is the adrenaline, which is the alpha agonist and used in the doses of 2.5 to 5 microgram per ml. Currently, the adrenaline is used mainly as an adjuvant to improve the safety profile of the local anesthetics and as an indicator of unintended intravascular delivery of the local anesthetic. Clonidine, the alpha 2 agonist, used in the dose of 1.1 to 1.5 microgram per kg, and the limitations are higher incidences of cardiovascular side effects like bradycardia and hypotension. Then the fourth drug is dexmedetomidine. It is again the alpha 2 agonist used in the doses of 0.5 to 1 microgram per kg for peripheral nerve blocks. It produces the adverse effects same as that of the clonidine, that is bradycardia and hypotension. Then the dose, the steroid, the dexamethasone, which has been used in the doses of 1 to 8 milligram, and the limitations are steroid-induced hyperglycemia. Then the drugs like ketamine and magnesium sulfate, these are also been used for the used as an adjuvant for the peripheral nerve blocks. Then some more drugs which are used are sodium bicarbonate, midazolam, morphine and fentanyl. Sodium bicarbonate increases the amount of non-ionized drug and it reduces the pain on injection and the onset time of the block. It precipitates, if it is added in too much quantity, then it can cause precipitation in the local anesthetic solution, and so the recommended doses are the standard dose for lidocaine is 1 ml of soda bicarb per 10 ml of local anesthetic solution, and in case of bupivacaine it is 0.1 ml of soda bicarb per 10 ml. The use of sodium bicarbonate as an adjuvant does not increase the duration of analgesia but can only shorten the onset time. And then the midazolam, which is the benzodiazepine group, it provides the analgesia via its gamma aminobutyric acid receptor agonist action, and it is avoided in the PNB because of neurotoxic effects which is seen in the animal models. Morphine and fentanyl have also been tried. These are the opioids, but their use in PNB has not been proved as successful. This is the table which is showing the maximum single injection dose of various local anesthetic agents, and the doses are very important to calculate before taking the patients for blocks because they may land up into the cardiovascular or CNS complications, and the cardiovascular complications like dysarrhythmias and even cardiac arrest can occur in these patients. So proper calculation of the doses are very important in these patients. Here the two studies are mentioned on the combination of dexmedetomidine and dexamethasone. In first study they are used this combination for the popliteal nerve block, and in second study for the pectoralis nerve block. Both these studies are published in 2020, and the results shows that the synergistic effect which lasts for more than 3 to 7 days post-operatively, and there is significant reduction in the post-operative consumption of the opioid. However, they also mentioned that there is a lack of sufficient data on the safety of this combination, and they want the further investigation and studies. The study is published in Journal of Anesthesia and Clinical Pharmacology in 2017 regarding the off-label use of drugs in regional anesthesia, a need for setting up policies, because many drugs which we are using in the peripheral nerve blocks, they are not FDA approved. So the American Society of Health System Pharmacists recommends the judicial use of published evidences by the prescriber, who holds the ultimate responsibility of safety and efficacy. Furthermore, such information should only be drawn from the standard peer-reviewed journals managed by an organization with an editorial board with experts in the subject of the article. They also mention that for drugs which are lacking the scientific database, informed consent also needs to be complemented with the investigational new drug application registry under an authorized body. This may include the potential adjuvant drugs such as the adenosine calcium channel blockers, calcitonin, and cannabinoid receptor agonist. This is just systemic review on the adjuvants for intravenous regional anesthesia for surgical procedures, which was published in 2015. And it includes the 29 studies, which shows that NSAID has the most potential to offer as an adjuvant to the intravenous regional anesthesia. Two more studies which are conducted for the intravenous regional anesthesia, they have shown the addition of the 1-densitron to lignocaine improve the quality of intravenous regional anesthesia and prolong the post-operative analgesic in the patients undergoing the hand surgery. One more study which was conducted by Honarmand, which concluded that addition of the 1-densitron to lignocaine for IVRA reduces the intraoperative and post-operative analgesic use. This study by Reddy et al. Shows that the 1-densitron acts by the blocking the sodium channel similar to that of the local anesthetics, and it produces the local anesthetic effect approximately 15 times more potent than the lignocaine. These are the references. The questions are: after an interscalene block is performed, it is noted that the patient develops anesthesia in the shoulder earlier than in the fingers. Why? The second question is: which peripheral nerve blocks are required to provide regional anesthesia for total knee replacement? Thank you.
Thank you so much, ma'am. It was such a beautiful presentation, such an informative lecture. And now we hand over the session to our respected chairman, Dr. Sangeeta ma'am and Dr. Pratibha Jain Shah ma'am. If any questions are there. Are you able to hear us? Okay. Since we are not having. So there's a question from Dr. Shiv Kumar sir. How many people have access to us with all types of probes to conduct focus studies?
Hello. Okay. I think that question was in general, likely probably like a poll, because there is so much in focus that, okay, fine, you can, initiate people into that, or you can actually give lectures. But if the trainees or PG students or senior students are not able to practice, then this has got no point. They need to have access to ultrasound, at least in the teaching hospitals. Easy access to ultrasounds.
Thank you so much, sir. If there are no further queries, let's move on to the next session.
I thought Satendra wanted to ask a question to me.
Yes, sir. Fine.
Okay, if there is no other question, then we'll leave the. Can go on to the next session. Yeah.
Okay. Now let's move on to our next session. T.N. Jha award paper. Our three judges are respected Dr. Shiga Mehrotra ma'am, Dr. Sadhna Sansarkar, and Dr. Sukhminder Bajwa. It's an honor to introduce Dr. Shiga Mehrotra ma'am because she is my mentor, she is my teacher. I have studied under her guidance, my post-graduation. So I'm very obliged. Dr. Shiga Mehrotra ma'am is a professor, head of the Department of Gandhi Medical College, Bhopal. And she was the past Honorary Secretary ISA City Branch, Bhopal, Honorary Secretary ISA MP chapter from 5 to 2011, Honorary Secretary of ISA West Zone from 2007 to 2009, and delivered guest lectures of various national, zonal, and state level conferences. Coordinator ISAS MP State, President ISA Central Zone from 2012 to 13, and President ISA MP State Chapter from 11-12. She has fields of interest in pain management, pediatric anesthesia, obstetric anesthesia, and regional anesthesia, and she has publications in international journals and 5 in national journals. Our next judge is Dr. Sadhna Sansarkar. Dr. Sadhna Sansarkar. She is presently Dean and Professor of Anesthesiology, LNCT Medical College, Indore. Presently, earlier she was Professor in HOD Department of Anesthesiology and Critical Care, Sri Aurobindo Medical College and PG Institute, Indore. And she has areas of interest in pediatric anesthesia, high-risk patients for anesthesia, and regional anesthesia. And she is a recognized PG teacher and examiner in various universities. She was the president-elect of ISA MP and chief editor of ISA MP Newsletter 2019-21, course coordinator of PG Assemble MP, scientific committee chairman of MP ISACON 19, chairman Oracon 2016, workshop chairman in ISACON 2014. Published many papers and review articles in various national and international journals, national faculty in many conferences in various capacities. And a third judge is Dr. Sukhminder Bajwa. Okay, Dr. Sukhminder Bajwa, he is a professor and head anesthesiology and intensive care, Gyan Ganga Medical College and Hospital, Banpur, Patiala. He is having 20 years of teaching experience, 13 years of editing and reviewing experience, research methodology, obstetric and neuroanesthesia, emerging medicine. He is a governing council member, ISA National, 5 national awards, including KPR Best Young Anesthesiologist, Best Research Paper, 400 plus national and international publications, Associate Editor-in-Chief of Indian Journal Anesthesia and Journal of Anesthesiology Clinical. Now, I just want to give a recap of all the guidelines to be followed by the students. Your presentation will be of 7 minutes and 2 minutes will be a question and answer session. You have to wrap up in within 7 minutes only, otherwise the marks will be deducted. Your judges will be giving you marks according to that only. And only the speaker, which I'll call the name, will have to unmute and start your video and start the presentation. Rest of you, please keep your video and please unmute your session. Okay, the first candidate is Dr. Radhika Khare. Dr. Radhika, are you there? Please unmute.
Yes, ma'am. Good afternoon, ma'am.
Yes. You can start your presentation, Radhika.
Yes, ma'am.
Please share your screen.
Doing that. Are you able to see the screen, ma'am?
Yes, yes. Yes, Radhika.
Should I start?
Yes, yes, start, Radhika.
An interventional study on knowledge, attitude, and practices of hand hygiene among housekeeping staff, technicians, and attendants in COVID-19 tertiary healthcare center. Amid this escalating pandemic crisis, adequate awareness about spread, control, and prevention of COVID-19 is of utmost importance. As there is emerging evidence on the presence of viable viral particles in the secretion and excreta of patients, untreated sewage surfaces, it has become indispensable concern for the healthcare providers to be aware about the wash, that is water, sanitization, and hygiene risks and practices. Hand hygiene is the leading measure for reducing healthcare-associated infections and preventing the spread of antimicrobial resistance. The aim of this study was to evaluate knowledge, attitude, and practices of hand hygiene among housekeeping staff, technicians, and attendants working in COVID-19 tertiary healthcare center, and to find an association between age, gender, education level, and department of work on the participants' knowledge, attitude, and practice of hand hygiene protocol. A survey was conducted in the hospital staff of JK Hospital COVID Center in the month of July 2020 after review from the Institutional Committee of LNMC Bhopal. A standard recording form for the data was made. Housekeeping staff, technicians, and attendants from various clinical wards were involved. Tools for the data collection were questionnaires including multiple choices, yes and no answers. A prior orientation was provided to the respondents regarding how to fill the questionnaire. It was a self-administered questionnaire and had to be filled individually without multiple considerations. Staff's refusal, staff with hearing problems, staff with speech difficulty, and those who were absent at the time of study were excluded from the criteria. Total 83 participants from both the genders participated in this study. A verbal consent was obtained from them. The questionnaire contested had 23 questions divided in 3 sets. Set 1 included personal and socio-demographic data. Set 2 had questions on knowledge about infection control in perspective of COVID-19. And set 3 had questions on knowledge about hand hygiene, attitude about cross-infection, and practice of 5 moments of hand hygiene. The third set being the main questions of the study and their responses were sought. Post this, the study participants were trained about hand hygiene practices with the help of lectures and demonstrations by the infection control team of JK Hospital, and the same set of questionnaire was provided to them after training. The pre and the post-training data were analyzed. We hypothesized that post-training there should be 85% improvement in the patient's CAP score. P-values less than 0.05% were considered to be significant. Statistical analysis of the data was done and it was found to be statistically significant for all the parameters. Coming to the demographic details, almost 66% of the participants in this study were females, and most of them were in the age groups of 18 to 39 years. Almost half, that is 48%, were the housekeeping staff, and 80% of them approximately had some sort of education in past. Coming to the knowledge, 70%, that is 69.88% of them had received knowledge about infection control in COVID through hospital. Approximately 75% of them were trained in past 6 months about the hand hygiene. Their responses about effectiveness of habit change and want for such demonstrations in future were 84.34%, 60.24%, and 75.9% respectively. Comparing the pre-training and post-training data, it was observed that there was a significant improvement of around 90 to 97% in the knowledge about duration of hand hygiene, the role of hand washing over hand rubs for soiled hands, about cross-infection and effectiveness of hand rubs. Regarding the attitude towards the use of PPE, it improved significantly from an average of 55% to 96% after training. The practice element of 5 moments of hand hygiene improved from 55 to 90% approximately. And the age groups which showed improvement specifically were the ages from 50 to 59 years. 37% of women showed improvement in their habits after training as compared to men. People who had received secondary education showed an improvement of 43% in their CAP as compared to others. Technicians and attendants showed a significant improvement in their habits, while there was a decrement in the housekeeping staff from 67 to 36%. So that's my conclusion. Most of the participants had training in the past, and after training they had improvement in their habits. Hello. In our study, the healthcare workers had a moderate level of knowledge regarding many aspects of hand hygiene, which was a positive finding, although knowledge in some areas regarding the use and efficacy of hand grips was poor, which significantly improved to more than 90% after training. Hand hygiene is considered to be the main measure to prevent cross-spread of microorganisms and reduce the incidence of healthcare-associated infections. A review completed by Nair et al. Revealed that the nursing students rehearsed hand hygiene better as compared to medical students. However, the information part was better among the medical students. Kavji et al. In a study stated improved compliance in hand hygiene was the standard alcohol-based drug can reduce the rate of nosocomial infection by as much as 40%. Hence, their knowledge needs to be strengthened in regard to the importance of hand hygiene. Caddy et al. Reported 56% of medical students accurately identified indications for hand hygiene outlined in the questionnaire, and 44% were either non-cognizant or unsure about these moments. Our study showcases the pivotal role that education and training of healthcare workers regarding the hand hygiene practices plays in reducing the cross-infection and preventing HCIs. Majority of our healthcare workers had an uplifting outlook towards the hand hygiene in the wake of preparing and began rehearsing the 5 moments of hand hygiene, and increment adherence was seen towards rehearsing other parameters.
Radhika, your time is up now.
Yes, ma'am, I'm done. These are my references.
Okay. Thank you, Radhika. It was a nice presentation. Over to you, judges.
Thank you, ma'am.
Hello, it's a nice presentation, Radhika, and it is an important topic for creating awareness amongst the healthcare workers in these pandemics time and to prevent the such spread of infection in such pandemic times. But I just want to know what are the limitations of your study?
Ma'am, the first limitation was that study was done only for the housekeeping attendants and technicians. It could have been involved nursing staff and medical students as well, and the postgraduate residents who were working constantly in the healthcare setting in per se COVID. Then second was there was no follow-up after the training. Like we took the questionnaire pre-training, after training we took the questionnaire, but at least 3 months after there should have been some sort of follow-up again for this.
So there is a gender also like, and the level of education is also impacting the study. So the group should be like, should be limited to one gender ideally, or to a education class should be, standard should be the same for the study group.
So that is what I was to come.
We can say.
Hello, Radhika.
We can, yes, ma'am.
Nice
Good
presentation.
afternoon.
Good
Thank you,
afternoon.
ma'am.
I also wanted to specify the same thing, that you should have kept the education level of housekeeping staff as well. That point is missing over there, the education level of the staff. And the age limit is vast basically, that is from 18 to 50 almost, that is there.
Yes,
anyways,
18 to 59,
good
yes.
study design, yes, that's a good study design, but it is the number of sample is less than for that age group, vast age group.
That's true, ma'am. But in COVID pandemic crisis, most of the staff also left.
Yeah,
because
that's
of
true. That's
being...
true. I agree with that. Okay.
Yes.
Dr. Satwinder.
First of all,
yes, sir. Good afternoon.
Good afternoon to my senior colleague judges, Madam Shikha and Madam Sadhana. I'm thankful to Dr. Sarvesh Jain and team in the organizing team for giving me the opportunity to become a judge in this very prestigious TN judge from ISA. Dr. Radhika, they have asked a very pertinent question that about the intellectual level as well as the gender bias in this study. Your study contained
Yes.
almost 37% male and 65% female population. If
Yes,
you
sir.
go to the statistical part, I think getting the female gender getting more trained, I think it's more of a, something not acceptable in the terms of result, because already
That's
your
true.
study has 2/3 majority in the female section. So whatever the, training imparts a better teaching method, definitely the number will be higher on the female side.
Yes, sir.
Second point of this study was the limitation. You didn't choose the sample size appropriately before deciding about the, depending on the primary objective. You should have at least done a pilot study or should have taken some, the percentage of improvement in regarding the existing practices, already existing practice in your institution, then giving
Yes.
training above that or those practices. Since was a national disaster, national disease still continuing, there are national program also going on through multimedia and social media. People are getting trained through that also, especially the hand rubs. The
Yes, sir.
mask and
Yes.
hand rub going on. So it's very difficult to ascertain whether whatever the training they got because of the training method you imparted or because of the national program or the social site from where they, I think, got the messages. So these are
Yes,
few
sir.
limitations. You should have addressed them completely in your this study design. So whenever
Yes,
you're
sir.
going to send it for some publication, you take care of these limitations.
Yes, sir, certainly.
Okay.
Thank you so much, sir. Thank you, ma'am.
Thank you, Radhika.
Thank you, ma'am.
Thank you, Radhika. Our next candidate is Dr. Sakshi Jain. Dr. Sakshi, are you there?
Good afternoon, sir, ma'am.
Yes. You can start your presentation now.
Yes, ma'am.
Please share your screen. Nivita, please unmute your video and please stop your video.
Is it Yes, ma'am.
Sakshi, from the first slide.
Can you hear me?
Yes, yes, you're audible.
Yes, you're audible.
Okay. I
We
can't
start
see.
from the beginning, actually.
Actually, I can't see my slide.
You can't see. We can see your
You're
slide.
from your 6th slide. Go back to 1.
Ma'am, give me 1 second.
Yeah.
Yeah.
Calm down. Don't get anxious.
Yes, sir. Yes, sir.
Aram se. Close and start again so that you can reach your first slide. Sakshi,
Yes, ma'am.
please close down first and come back again.
Yes, ma'am. I started again.
Yeah. Again, the same thing.
Yes, ma'am.
Sakshi, go to
Slide up.
Yes,
yes.
Yeah.
Yes, yes.
Yeah,
Yes.
it's okay.
Yes, got it.
Good afternoon, everyone. My topic of paper presentation is role of ultrasound in the prediction of cervical airway and its correlation with Cormack-Lehane gradient. Securing airway during the general anesthesia is the utmost priority of the anesthesiologist, failure of which can lead to hypoxic brain injury and death in 2 minutes. A combination of airway assessment tests such as modified Mallampati classification, interstitial gap, stenomental distance, hyomental distance are often used to overcome their limited sensitivity to assess the typical laryngoscopy. Even after using the multiple clinical screening tests, a significant incidence of unanticipated difficult laryngoscopy has been observed. Portable, non-invasive, and the point of care characteristic of ultrasonography can aid in the airway assessment and prediction of difficult laryngoscopy. Various ultrasound-derived measurement of airway has been used to predict the difficult laryngoscopy. The aim of our study is to ascertain the role of ultrasonography in the prediction of difficult airway and to correlate ultrasonography parameter of ANS high or ANS vocal cord, pre-epiglottic space, and the ratio of pre-epiglottic distance and the midpoints of the distance between the vocal cord pre-operatively and with the Cormack-Lehane grading vocal endoscopy. Our study was a prospective observational study was conducted from January 2020 to December 2020 in the Department of Anesthesiology, Shamsha Medical College and Associate Sanjay Gandhi Hospital and Gandhi Memorial Hospital, Viva MP. All the adult patients requiring general anesthesia via endotracheal intubation for the elective procedure was included on the study. The patient who refused the refusal and the patient with cervical spine pathology, pregnant female, patient with any feature of physical airways such as a maxillofacial anomaly, restricted neck movements and limited mouth opening were excluded from our study. After getting clearance from the Institutional Ethics Committee, 100 patients of undergoing elective surgery under the general anesthesia were included after the informed consent. The study was conducted in 2 phases. First, during the anesthesia pre-anesthetic checkup, the ultrasound of the neck was performed and the following parameters were noted. That is ANS hyoid, ANS vocal cord, pre-epiglottis space and the distance from the epiglottis to the midpoint between the vocal cord and the ratio of both. The study of second phase was done during the laryngoscopy and intubation in operation theatre on the day of the surgery. During the pre-anesthetic checkup, the ultrasonography measurement of the USG parameter was done with the patient in the head extension position. The anterior neck soft tissue thickness was measured at the level of hyoid and at the level of the vocal cord and with the help of high frequency laser probe. The picture is showing the measurement of the ANS hyoid at the level of the hyoid bone, and the second picture is showing the measurement of the ANS vocal cord at the level of the through the thyroid cartilage. For measurement of the ratio of the pre-epiglottis space and the EBL, the ultrasonographic probe was placed in the submandibular area, that is the coronal plane, to see the mouth opening. Without changing the probe position of the plane, the US probe was rotated in the transverse plane from A to plane C to plane E to plane G. The plane G, which is an oblique transverse plane bisecting the epiglottis and the posterior most part of the vocal cord with arytenoid in a 2-dimensional. Further rotation of US probe was seen at this point Z. In the plane G, the epiglottis is visible as a hyperechoic curvilinear structure, and its anterior border is demarcated by the hyperechoic pre-epiglottis space and the posterior border by a bright linear air mucosal surface. The posterior part of the vocal cord skull with arytenoid appears as a hyperechoic lateral V-shaped structure facing away from the each other. The distance from the epiglottis to the midpoint of the distance between the vocal cord was noted, and the ratio between the pre-epiglottis space and EVL was taken. During the second phase, on the day of the surgery, a patient was shifted to operation theatre. Monitor were attached and the baseline parameters, namely heart rate, systolic, diastolic blood pressure, mean arterial pressure, SpO2, ECG tracing were recorded and continuously monitored. IV line was secured and the full resuscitation equipment were kept ready. In the operating room, after the routine monitoring the pre-oxygenation, the patient was given IV fentanyl 2 micron per kg as a pre-medication. Induction was done with IV propofol 2 mg per kg and succinylcholine 2 mg per kg after the adequate respiration has been achieved. Tracheal intubation was attempted by the direct laryngoscopy using an appropriate size Macintosh blade. Tracheal intubation was perfect by an experienced anesthesiologist. He was blinded with the finding of the pre-operative assessment. And the intubation was classified as the CL grading 1, 2, 3, and 4. Appropriate size endotracheal tube was inserted, anesthesia was maintained, and at the time of the surgery, the patient was reversed and activated. The number of attempts at the intubation, the need of alternative difficult intubation approach, and the invasive airway access or the cancellation of the procedure due to the inability to secure the airway was noted. Statistical analysis, all the measurement data were presented as a mean plus minus standard deviation, and the statistical processing was performed by SPSS. The category data analyzed by using the chi-square test, while the quantitative data was measured by the 1-day ANOVA test. The data with p-value less than 0.045 was considered as a statistically significant. Observation, in our study, we found that the 40% patient had Cormack Lehane grade 1, the 45% patient has Cormack Lehane grade 2, and the 15% patient had Cormack Lehane grade. In our study, we didn't find any patient with Cormack Lehane grade 4. These are the data showing the comparison of ultrasonographic parameter with the Cormack Lehane grading. As in table, as we can say, the only ANS vocal cord has a p-value less than 0.001, which is highly significant, while the other parameter like ANS hyoid, pre-epiglottis space, and the ratio of both did not show any significant p-value. The table is showing the sensitivity and specificity of ultrasonographic parameter for the predicted difficult intubation. As we can see in the table, the ANS vocal cord has sensitivity of 93.3 and the specificity 95.3, and has area under curve 0.85. The area under the receiver operative characteristic curve for ANS vocal cord has a 0.847, which is highly significant, and we show the relationship between the ANS vocal cord with the Cormack Lehane grade. In our study, we found that the ANS vocal cord more than 0.23 has a p-value less than 0.001, which was highly statistically significant for the prediction of difficult airway with a sensitivity of 93.3 and a specificity of 75.3. There are so many studies supporting our study. Reddy et al. In 2016 conducted a similar study in the 100 patients, and he found that ANS frequency more than 0.23 has sensitivity of 85.7 and prediction of difficult airway. Similarly, the Imran et al. 2018 and the Mehran et al. In 2021 also conducted a similar study, and they found the Imran et al. Found that the anterior soft tissue thickness at the vocal cord was associated with the prediction of difficult airway, and the Mehran et al. Conducted a systemic review and meta-analysis, and he found that the thickness of anterior neck soft tissue thickness at the lateral vocal cord was highly useful in the prediction of difficult airway. Similarly, T. Ezri et al. In Jinhong et al. Shows the same result to our study. Summary. Prediction of typical airway while the ultrasonography measurement can help in the better airway management during the general anesthesia. ANS vocal cord was found to be more sensitive and specific parameter than other parameters. Prediction of typical airway can help us in being better prepared with the alternative option for the better management of airway. So we conclude that the ultrasound is useful tool in the airway assessment for the prediction of difficult airway. And out of all studied parameters, ANS vocal cord has the most sensitivity and specificity than the other parameter. These are my references. Thank you.
Thank you, Sakshi. Over to you, judges.
So, Sakshi, what was the BMI range in your study group?
Ma'am, we didn't take any particular BMI criteria. We just take we didn't choose a specific BMI criteria.
There was no. So this is a limitation of your study then?
Yes, ma'am, this is a limitation. We didn't choose a particular BMI.
And did you visualize the tongue and mandible and all with the this ultrasonography?
No, ma'am. Only we just saw the mouth opening that in a plain way, but we just mainly focused on the parameter that is ANS thyroid vocal cord and ratio of PS and AVL only.
So any higher mental ratio?
Yes, ma'am. Higher mental distance we have taken in our study, and we found that it was sensitive but not specific. It was specific but not as much as sensitive than ANS vocal cord.
Dr. Sakshi, good presentation. But as you said, BMI is a very good criteria for deciding the difficult airway, basically. And when you are studying the ultrasonographic airway, you should have kept that in your mind and compared both the things together. Right?
Yes, ma'am. Initially, we thought to take BMI more than, but due to COVID, there was no such patients enough. So we reduced our criteria. We removed that criteria of BMI.
Okay. And at the same time, you took all the patients, or particularly head and neck surgery patients for your study, or all patients coming
all
for general anesthesia?
We took all patients undergoing general anesthesia.
Okay, fine. Thank you.
Thank you, ma'am.
Dr. Sakshi, what was the power of your study?
Sir, 80%.
How you arrived at that power?
Sir, from the Reddy et al. Study, from the various studies, we took the parameter and the relevant data was put in the sample size. From there, we got that power, sir.
There should be at least one primary objective from which you arrived at that power of study. No? What was that?
Sir, ANS, to measure the ANS vocal cord to comparison the Cormack-Lehane grading, sir.
So what difference were you expecting from the previous studies also, if you were thinking that you imbibed your power from the previous study? How much difference?
Yes, in previous studies, sir, ANS thyroid was also having the significant correlation with Cormack-Lehane grading. Both ANS thyroid and vocal cords had significant correlation, but in our study, we found that ANS vocal cord had more significant correlations.
No, you didn't understand. I say whenever you take a power of study, there is a comparison of parameters that was in percentage. It has to be objectively specified. That's what I was asking. How that power was arrived at? How much percentage difference was there from the previous studies and what you were evaluating with the ultrasonographic study of the anterior soft tissue neck and the vocal cords distance?
Sir, 80% of the power was taken actually. That we was expecting 10% differentiation from the standard value from the previous studies.
See, that is more important. Say 10% difference we were expecting.
Yes.
whenever you present these things, always be specific in writing as well as presenting to these things.
Yes.
Presentation was good. Don't think about the presentation, but these are the things when you go for the national or international journals, these things have to be specified properly.
Yes,
Okay?
sir. Thank you, sir.
Thank you. Thank you.
Thank you, Sakshi.
I just want to ask one thing, Sakshi. The
ma'am.
difficult, how did you correlated difficult laryngoscopy with the difficult intubation?
Yes, ma'am. Cormac-Lehane grading 1-2 was easy intubation in our study, and the Cormac-Lehane grade 3 and 4 was classified as difficult intubation. So all the patient who has CL grade 1 and 2 was classified as the easy, and the patient having CL grade 3 and 4 was classified as the difficult intubation. So the p-value was taken between the difference of CL grade 1, 2 and CL grade 3 and 4, ma'am.
But did you find any difficult intubation in such cases where there was a difficult laryngoscopy?
Yes, ma'am. Definitely we find it.
Because this is very much needed in this study.
Yes, ma'am.
Like,
Mainly the patient who had the ANS vocal cord almost around 0.3 or 0.32, they really had the CL grade 3, ma'am.
Okay, thank you, Sakshi.
Thank you, ma'am. Good day, ma'am.
Thank you, Sakshi. Next will be Dr. Suruchi Patel. Suruchi, are you there?
Good evening, ma'am.
Suruchi?
Yes, ma'am.
Yes,
Can you hear me?
Yes, yes. Please start your presentation.
Yes, ma'am.
Order has changed, Dr. Nisha. Neha?
Yeah, it is 13th number.
Ma'am, this girl requested, ma'am, for an early because she has train or something.
It's okay.
Yes.
It's okay. It's okay.
Thank you.
Good afternoon, everyone. Ma'am, can I start my presentation?
Yes, please. Yes, please.
Good afternoon, everyone. My topic for paper presentation is a comparative study on effectiveness of parental presence versus sedative pre-medication for reducing anxiety in children undergoing general anesthesia. Millions of children undergo anesthesia and surgery around the world every day. Parents and children wait in a preoperative holding area on the day of surgery. And during this time period, the children are fearful of parental separation and introduction to unfamiliar environment, hospital exposure, and surgical instruments. In young children, anxiety may be expressed in many forms. Some children verbalize their fears, whereas for others, anxiety is expressed only behaviorally. Anxiety increases when the children enter the operating room where the monitors are applied, a mask is held over the child's face, and a volatile anesthetics are administered. Preoperative anxiety is an important and undermined problem in children. Highly anxious children before surgery have significant higher postoperative pain, delay in hospital discharge, higher incidence of sleep disturbances, emergence delirium, and other maladaptive behavioral changes. In the past of medical field, the only real or important outcomes are those which directly affect morbidity and mortality rates of the patients. But now, outcome like satisfaction of patients and quality of life are given equal importance as morbidity. Routine use of sedative pre-medication and parental presence during the induction of anesthesia is done to treat anxiety in children undergoing surgery. Behavioral intervention is always better than a pharmacological intervention. So the purpose of my study was to see the effectiveness of behavioral intervention and a pharmacological intervention. The primary objective of my study was to assess the anxiety in children aged 4 to 12 years during the preoperative period using modified Yale preoperative anxiety scale in two groups, that is the parental presence group and in the midazolam group, and to compare the anxiety level in the above two groups and compare the effectiveness in the between the two interventions. My secondary objective was to assess the anxiety in parents using state rate anxiety inventory tool in both the groups and to compare the anxiety of parents in both the groups, and also to assess and compare the duration of induction of anesthesia in the two groups. My inclusion criteria were children aged 4 to 12 years belonging to either sex classified as ASA grade 1 or 2, undergoing elective surgery and requiring general anesthesia. My exclusion criteria included parents who were not willing, developmental delay, psychomotor illness, cardiopulmonary diseases, hepatic and renal encephalopathies. After obtaining valid written informed consent, eligible parents were randomly assigned to one of the two study groups using random numbers table. Parents in two groups, parental presence group or a midazolam group. In parental presence group, the parent were were given detailed instructions and counseled properly about what to expect and how to behave inside operation theatre and how to interact with their child during the induction. Parent was asked to talk, touch, and maintain eye contact with their children. As soon as the general anesthesia was induced, the parents in the parental presence group were escorted to the waiting area and asked to rate their own anxiety. In the midazolam group, the children in this group were received intravenous midazolam at the dose 0.03 to 0.05 milligram per kg, and the child was separated after 5 minutes after the administration of midazolam. So a modified Yale preoperative anxiety score was measured at 2 points in the parental presence group, that is at the pre-op room and during the introduction of anesthesia mask. In the midazolam group, it was measured at 3 points, pre-op room and during the separation from parents and during introduction of anesthesia mask. My observations were for child temperament at the preoperative room, the anxiety level was same in both the groups. They were comparable. During when the child was separated from the parents, the mean value was 34.51 for MYPS score in midazolam group, and it was not applicable for the group in the parental presence group. In the group parental presence, during the introduction of anesthesia mask, there was difference found, and it was statistically significant, showing a significantly lower mean MYPS score in midazolam group in comparison to the parental presence group. Midazolam was very effective in reducing the anxiety of the patient while introducing the anesthesia mask. While comparing the parents' temperament, comparison of state trait anxiety score was done at the pre-op room. It was similar in both the group and comparable. At the waiting room, the difference was found to be statistically significant, showing a significant lower STAI score in parental presence group in comparison to the midazolam group at the waiting room. And when duration of induction of anesthesia was compared in both the groups, the difference was found to be statistically significant, showing a significantly longer duration of induction of anesthesia in patients of group parental presence group in comparison to the midazolam group. So coming to the conclusion, both interventions, intravenous midazolam and the parental presence intervention, was successful in reducing pre-op anxiety in children aged 4 to 12 years undergoing general anesthesia. But intravenous midazolam was more effective in reducing pre-op anxiety in children, and parents were less anxious in waiting room when they accompanied the child to the operation theatre. Duration of induction was comparatively higher in parental presence group than in the midazolam group, because pre-medicated children were more compliant during the induction of anesthesia. These are my references. Thank you.
Thank you, Suruchi. It was a nice presentation. Now over to judges.
It's a good topic. But I just want to know, have you seen any adverse outcomes post-operatively also in such patients? And your study group is too wide, like for pediatric children, 3 to 6 years should be taken for such studies when you involve the parents. The older children, like 7 to 11 years, they can be kept occupied by behavioral interventions and other things also.
Yes, ma'am. Ma'am, this is what I observed in my study as well. Ma'am, I have there is this result which is pertaining to the age of the patient. So the anxiety which was seen, pre-op anxiety which was seen between 4 to 8 years was far higher than the which was seen between 8 to 12 years. So yes, ma'am, it is a wide group, and there was the differences in both the group, because in 8 to 12 years, the pre-op anxiety was not that much.
Suruchi, have you observed the behavioral problem in parents of the younger age group children than the older age group children?
Ma'am, actually, it does not depend on the age of the patient, child. It depends on how their own education status and other factors, ma'am. Mostly what I observed. And in my hospital, most of the parents were uneducated or maybe just primary school education.
Okay, but the the older children, they cooperate themselves also many a times, isn't it?
Yes, ma'am. Yes, ma'am.
Right.
Dr. Suchi, I agree with both the judges. The age group actually it is quite, I think, wide. The
Yes, sir.
separation anxiety is much higher in the lower group. The other question was also pertinent because it's a very subjective type of study.
Yes, sir.
Taking care of parents, that's a very right question because different families have different, their behavioral problems and
Yes, sir.
their bonding, their, how much separation really kids want to have. Sometimes the parents are, fighting with each other. Kids want to have away
Right.
from them, and you just see even the parents get very much afraid when they are exposed to the OTE atmosphere, and their fears can be transported to the patients also.
Yes,
That
sir.
that things have to be taken into account while developing these studies, because when you're comparing a drug with the behavioral pattern of the parents, the
Yes, sir.
comparison is somehow scientifically go haywire. You have to have done the economic background. I'm thinking if many of the parents of the age group of I think 5 to 12 must be working parents, how much time they really spend with their kids, that the bonding is so strong that they don't want to get separate from the parent. So similarly with I think the patients, parents, the rich parents and the poor parents, it's very difficult to comment upon how much the
So I would
separation.
like to add the point here, sir. So actually, I am working in a government hospital. So the education status and the economical status is approximately same for everyone. So it's there is not a very huge difference between the education status or the economical status of the patient or the parents. So that was not an issue.
But
But
again,
I
like
have taken.
that you already told. That's what I want to say. The
Yes.
neutralizing, there should be some neutralizing parameters when you develop such studies that should have taken into account the real results, whatever you produce. I'm not going to ask you the scientific,
Yes, sir.
the numbers and everything about this study. But comparing a drug with the parental behavior is somewhat, it doesn't look scientific also from some angle. That's what I
So
want to say.
many studies have already been done on this subject, sir.
When it comes to the emotional attachment, Suruchi,
Yes,
the
ma'am.
educational status and the economy does not come in between, basically.
Yes, ma'am. That is not coming in the way of my study, and it also depends on the family dynamics, also, ma'am. So there's a very subjective thing, but ma'am, even the tools are very subjective, and it is not objective. So, ma'am, that is what, ma'am, it is very complex tool. First of all, ma'am, it is very hard to implement it in a busy OT. So that is the limitation, one of my very big limitation of my study. So all these things, ma'am, actually tools are also very subjective.
Sorry, Dr. Sukhvinder, to interrupt in
No,
between.
it's okay, ma'am. I'm feeling very pleased to listen to all these studies. Is that these kids are actually they are just appearing for the I think final examination very soon. But I think they should develop some. Tomorrow they are going to do more research. They should be at least know, because I don't want to pinpoint every critical remarks in every study. This is the beginning for the life. It's important that in each and every study we will try to bring out some points that should be necessary for every participant here to note those points whenever the future they are going to do any research design or study.
Right.
That's what it is.
Right.
Okay.
Any more questions? Thank you, Dr. Suruchi.
Thank you, ma'am.
Thank you, Suruchi. Our next candidate is Dr. Nishita Divakar.
Okay.
Nishita.
Nishita, please share your screen.
Yes. Next is Priyal, no?
Hey,
No, ma'am.
actually, the order has changed somewhere.
No, ma'am.
Yeah, okay.
Ma'am, Nishita after that Priyal.
Actually, she was third, but Suruchi came in between.
Audible to everyone?
Okay.
Yes, Nishita.
Okay, begin.
You can start.
Yes, very good afternoon to all. I'm Dr. Nishita Divakar from NSCB Medical College, Jabalpur, and I'll be presenting my paper, which is low-dose intravenous ketamine infusion for post-operative analgesia. So as a part of the effort to develop opioid-free pain therapy, renewed interest is being focused on the use of ketamine for treatment of acute and chronic pain. Ketamine, as we all know, is a phencyclidine derivative, competitively antagonizes the NMDA, N-methyl D-aspartate receptor, and thereby it blunts the central pain sensitization. So by using ketamine, we can actually reduce the opioid consumption and thereby reduce its side effects like hyperalgesia, constipation, and respiratory depression. So though the effect of ketamine in providing analgesia has been extensively studied, its optimal dosing and duration of administration for postoperative analgesia still is unclear. That's why we took up this study to demonstrate that ketamine at a dose of 0.2 milligrams per kg per hour is adequate enough to decrease pain and at the same time low enough to avoid its psychomimetic effects. Our aim was to study the effectiveness of the low-dose ketamine infusion, as I mentioned, 0.2 milligrams per kg per hour for post-operative analgesia in patients undergoing any upper abdominal surgery under general anesthesia. So these upper abdominal surgeries included cholecystectomy, feeding jejunostomy, a gastric or duodenal perforation repair. The primary objective of this study was to evaluate the efficacy of low-dose ketamine infusion in reducing the post-operative pain over a period of 48 hours. Whereas the secondary objective was to see if it could reduce the total dose of opioid analgesics required. The sample size was calculated based on a study of Leonid Droitsvet et al., who in 1993 conducted a study where he saw that ketamine could reduce the total dose of opioid consumed in the first 24 hours. Based on that study, we have taken into consideration a probability of 60% with 10% absolute precision and using the formula n is equal to z squared tq by d squared mentioned here. We plan to enroll 90 subjects in this study. Now, after obtaining approval from the Institutional Ethics Committee, the study was conducted at NSCB Medical College, Jabalpur, and the patients of age between 18 years to 70 years of ASA physical status 1 and 2 undergoing any upper abdominal surgery under general anesthesia were included, whereas the exclusion criteria had patients who ever had heart failure, dysrhythmias, diabetes, patients with bronchial asthma, GCS less than 12, raised intracranial pressure, or epileptic patients. Methodology, this was a prospective randomized comparative study, and in this 90 patients posted for abdominal surgery were taken, and they were divided into two groups using a sealed envelope technique, which was based on a computer generated list. Both these groups had the same protocol for general anesthesia. We used based drug dosages. The variable compartment was the post-operative analgesia, which is in group 1, it was administered as prescribed by the surgeon. And the surgical team in our study routinely prescribed IV tramadol 100 milligram TDS. Whereas in group 2, an IV bolus of 0.2 milligram per kg of ketamine was given at the time of induction, which was followed by an infusion of 0.2 milligram per kg per hour of ketamine for 48 hours post-operatively. So what we observed was VAS scores for both the groups at an interval of 4 hours, 6 hours, 12, 24, and 48 hours. And the total dose of opioid, here it being tramadol, consumed in both groups were noted. In group 2, the time taken by the patient to request for the first dose of analgesia was also noted. And if the VAS score was more than 4 in this patient, then we would administer a opioid analgesic, it being tramadol. Any side effects of ketamine infusion was also recorded, and all of this was done for a period of 48 hours. The statistical analysis, the data was recorded, fed into computers, analyzed with the help of Stata 14.0 software, and all the means were expressed as mean plus standard deviation and proportion as in percentage. The critical value for the significance of the results, the p-value, was considered at 0.05. The results, the groups were similar in age, sex, and type of surgery. Group 1 had a mean age of 54, whereas group 2, 51. The male to female ratio in group 1 was 29 to 15, whereas group 2, 30 to 15. And the type of surgeries, the surgeries included cholecystectomy, feeding, jejunostomy, gastric and duodenal perforation repair, all were in similar numbers. Now, as you can see, the visual analog score, the mean visual analog scores were lesser in group 2, that is the ketamine infusion group, when compared to the group 1. At the same time, the total dose of opioid that was consumed in group 2, which was around 190 milligrams, was lesser when compared to group 1, which is 620 milligrams. So the side effects that I observed were double vision and nystagmus, which was 2 of them had double vision and 5 had nystagmus. The rest, 38 of them, did not have any side effects. A discussion part. So any noxious stimuli can cause central sensitization, which results in transition of an acute time-limited pain into chronic pathological pain. Though opioids also act on NMDA receptors, it only delays the process, unlike ketamine, which completely abolishes it. Here we have a study. See, one controversial issue is the timing of ketamine administration, like when should we administer ketamine? So that was cleared by Himelser and Burek, who concluded that an intraoperative bolus of ketamine should be followed by a prolonged infusion or serial boluses of ketamine, which works by blocking the central sensitization, because we have to maintain the plasma and the central nervous system tissue levels of ketamine. The question is the ideal duration of post-operative infusion. Stierberg et al. Demonstrated clinically insignificant accumulation of ketamine and norketamine after 72 hours of infusion. So it was safe to give a ketamine infusion at least up to 72 hours. In a meta-analysis, Nicol et al. Combined data from 14 studies and compared the perioperative ketamine and placebo, and found that at 3 months and 6 months respectively, the ketamine group had 55% and 30% reduction in risk of persistent post-surgical pain. So this would prove that ketamine also helps in treating the chronic pain. There is less support in the literature for the use of ketamine for pediatric patients.
Nishita, your time is up. Please come to the conclusion or result.
Yeah. So this has come to the conclusion. Therefore, can be concluded that a post-operative ketamine infusion of dose 0.2 milligram per kg per hour for 48 hours provided good analgesia by improving pain scores and also significantly reduced the dose of opioid consumed. My references.
Thank you, Nishita. Over to you, judges now.
I just want to ask whether it has increased the time for giving the rescue analgesic.
Yes, ma'am.
You haven't mentioned here about the first rescue analgesic.
Yes, ma'am, should have. 29 hours was the time recorded, mean time recorded for the rescue analgesic.
And can you tell me what is the dose range for the low dose ketamine?
The range was 0.3 to 1.5. I've taken a dose of 0.2.
Why you have taken this dose? This is my main question, actually. The low dose varies from 0.1 to 0.5 milligram per kg. So I just want to ask why you have taken this 0.2 milligram per kg.
It was just a random selection.
Hello.
Yes, ma'am.
Should we move on? Dr. Shikha?
Yeah.
I just wanted to know the patient's hemodynamic stability, because there's a varied age group of these patients, right from the younger to the elder age group, basically, isn't it?
Yes.
So the hemodynamically, were all these patients stable? Was there any emergence reaction to these patients, or you sedated these patients along with the ketamine low dose?
So you're asking me just after extubation?
You started with the infusions, isn't it? Post-operatively,
that was started
intraoperative to post-operative period for 48 hours.
Intraoperative,
right?
just a bolus of 0.2 milligram was given per kg was given, whereas the infusion was started post-operatively only.
And these patients were kept totally opioid-free, right?
Yes, ma'am.
Even not even intraoperatively, you gave any opioid.
No opioid. The analgesic that was used was paracetamol.
And the surgeries you used, duodenal perforation and all, they were carried out under as elective surgeries, or even you used the patients, you took the patients for emergency surgeries as well?
Emergency surgeries.
Okay, fine. So where they've been properly been, of course, you might have optimated the patients, optimized the patients.
Yes, ma'am.
And ketamine, they did not have any emergency reactions after, except the nystagmus and dual.
The time only, yeah.
And
exactly,
tachycardia and hypertension, there was no hypertension, tachycardia with ketamine.
That was not included in my study, ma'am. But what I had had as a tertiary objective, there was not much difference. There was only a 5 to 10% increase from the mean basic value.
Because ketamine is known to do that, isn't it?
Yes, ma'am. Yes.
So you should have included that thing also in your study, right? Okay. Sir.
Nothing much actually. Already you have asked those questions. I was just a little bit skeptical about the type of incisions, where the incision was given, at which level incisions were given, because the comparison of pain at different level of the body, it has to be quantified. That is the more important. And that slide of yours where the different surgeries have been displayed, you should have conveyed that part also. That's a limitation, you can say, in this type. Emergency surgery and elective surgery, the pain threshold is also different for those people. Anyway, fine, because the time is very short. Somebody has asked from.
Yeah, right.
Okay.
Okay. Thank you, Nishita.
Thank you.
We can move on to the next.
Thank you, Nishita. The next candidate is Dr. Priyal Srivastava. Priyal, are you there?
Yes, ma'am. Good evening, ma'am. Good evening, judges.
Good evening.
Priyal, please share your screen.
Okay.
Priyal, go to slide.
You can start, please.
Priyal, are you there?
Yes, ma'am. Yes, ma'am. Just a second.
Yes.
Slideshow.
Come to the slides now.
Just next to animations, it's slideshow. Click to that. Yes. From beginning, yes.
Okay.
Good evening, respected judges. This is Dr. Priyal Srivastava, RMO Anesthesia from Gandhi Medical College, Bhopal, and my moderators are Dr. Shikha Malhotra, ma'am, Professor and Head of Department of Anesthesiology, Gandhi Medical College, Bhopal, and Dr. Tripti Vatsalya, ma'am, Associate Professor, Department of Anesthesiology, Gandhi Medical College, Bhopal. My topic for presentation is comparison of the effects of propofol and sevoflurane on post-operative cognitive functions and memory in patients undergoing general anesthesia. Post-operative cognitive dysfunction is a recognized clinical phenomenon after anesthesia and surgery. Patients with POCD experience impairment of cognitive abilities, concentration, memory, processing, and psychomotor speed. Therefore, it seriously affects the lives of patients, prolongs the length of hospitalization, and increases medical expenses. The primary aim of the study was to compare the effect of propofol and sevoflurane on cognitive functions and memory in patients undergoing general anesthesia. Thereby, the secondary aim was to compare the effects on post-operative recovery profile in these patients. It was an observational hospital-based study conducted on 60 patients of age group 20 to 40 years and ASA grade 1 and 2, scheduled for elective surgery and requiring general anesthesia. The pregnant and lactating mothers, uneducated patients, the patients whose MMSE score was less than 23 pre-operatively, and patients with history of alcohol and drug abuse were excluded from the study. After the written and informed consent, the thorough pre-anesthetic evaluation of the patients was done, and they were kept nail by mouth for a minimum of 6 hours. Assessment of cognitive function and memory was done preoperatively by 5 tests. First is MMSE score, that is mini mental state examination, which is a 30-point questionnaire. Second is CBLD, that is California verbal learning test, in which we ask the name of 5 truths from the patients preoperatively, and the same is asked postoperatively. Digit span test, in which we ask the phone number as well as the vehicle number from the patients preoperatively, and same is asked postoperatively. Fourth is Rivermet behavioral memory test, in which the patients were shown a picture of an animal and asked about the animal, like what is that animal and what is the location of the animal, along with date of birth of the patients, and same was asked postoperatively. And recall test, in which the patients were asked to recall the names of surgeon as well as anesthetist. Pre-operatively, baseline vitals were noted before the administration of study drug. All the patients were induced with propofol, and then for the maintenance part, they were given either injection propofol infusion or the sevoflurane, along with oxygen, 50% oxygen, 50% nitrous, and appropriate muscle relaxant. Intraoperatively, the depth of anesthesia was monitored by clinical assessment. Post-extubation, the assessment of cognitive functions and memory was done by, again, all the 5 tests, like MMSE, CBLT, DST, RPMT, and recall test at 5-minute interval, 30 minutes interval, 60 minutes interval, and 120 minutes interval. Pain, then the recovery profile was assessed by Aldred recovery score and visual analog scale. The data was entered in Microsoft Excel and analyzed using SPSS version 26. Categorical variables were expressed in terms of frequency in percentage, and chi-square test was applied, and continuous variables were expressed as mean and SD, and student t-test was applied. P less than 0.05 was considered as statistically significant. Now the results, in both the groups, group S and group P, 50% male patients and 50% female patients were taken, and the mean age group for group S was 26.93 and for group P was 28.73. Now the recovery profile for the Aldred recovery score was applied, and the difference was highly significant at 10-minute interval, 15 minutes, 30 minutes, and 60 minutes post-extubation. So early recovery was observed with sevoflurane as compared to propofol. For the visual analog scale, in both the groups, the result was comparable, so it was statistically insignificant in both the groups. For mini-mental state examination, there was less cognitive impairment observed in group S as compared to group P. So the difference was statistically highly significant. For the CBLD, that is California verbal learning test, there were more number of routes remembered by patients in group S as compared to group P. So the result was highly significant for a whole 2-hour period. The recovery was better with group S. For digit span test, there were more number of patients who remembered their own mobile number and vehicle number in group S as compared to group P. And also the this effect of sevoflurane on numerical memory was less effective than propofol up to 30 minutes. After 30 minutes, in both the groups, the results were comparable. In RBMP, that is Rivermet behavioral memory test, the effect of sevoflurane on semantic memory was less effective than propofol up to 5 minutes. After 5 minutes, there was no effect on semantic memory both with propofol as well as sevoflurane. Now, the recall test, post-operatively, maximum patients remember the names of surgeon as well as anesthetist. So there was no effect on recall memory both with sevoflurane and propofol. Sevoflurane, an inhalational anesthetic agent, has been found to have cognitive impairment, less cognitive impairment than propofol as per our study. One such study by Terry also offered the same evidence that commonly inhaled anesthetic agents do not increase the incidence of cognitive problems such as delirium in the early post-operative period. One such reason for this could be sevoflurane has a blood gas partition coefficient of 0.65. Thereby has low solubility in blood and body tissue characterized by rapid induction and recovery. Therefore, sevoflurane could be a better option in daycare surgeries. In conclusion, I would like to say sevoflurane is more favorable than propofol for a faster recovery and emergence from anesthesia, where rapid recovery of cognitive function and memory is desired. And the only limitation of the study was intraoperative depth of anesthesia was monitored by clinical assessment rather than the standard monitoring criteria. Thank you, ma'am.
Good presentation, Priyal, I must say.
Thank you, ma'am.
Within time.
Thank you, Priyal.
Thank you, ma'am.
Over to you, judges.
So the judges, you come forward because
yes, Shikha, that is what I was to tell you. Okay. Anyways, your limitation was only the monitoring, or anything else you had limitation in your studies, Dr. Priyal?
Ma'am, apart from the patients who were uneducated, ma'am, like the illiterate patients, they were. We didn't include them in the study because obviously they were unable to answer the questions pre-operatively only. Like the MMSE score was less than 23, and whatever cognitive test we were to perform on them, so they were unable to give answers to those questions. So we didn't include them in the study. study, ma'am. And also interoperatively, the depth of anesthesia and also the dosage of propofol as well as sevoflurane, which we are administering to the patient. So that was the thing that like we had to like look for the duration of the surgery and all that. For like the patients, the dose which was administered to the patients, so that was actually different according to the duration of the study. So that was also one.
So the duration of surgery was also not fixed.
Yeah.
That is why the dosage were not fixed, right? Oh, okay.
Shall I?
Dr. Smith, yes.
Dr. Priyal, na?
Ji, ma'am. Ji, sir.
First, tell me how you arrived at the dose equivalence of comparison between propofol and sevoflurane. The dose equivalence, how you calculated that?
So actually, there was a thing that for the propofol part, we took like it's for the total dosage thing. So 125 to 200 microgram per kg. That was administered, and sevoflurane, the 1.2 to 1.5% MAC value we administered to the patient. Like we look for the according to the hemodynamics and all of that, we took like we fixed this range. The total dosage should be this much only, so that there is not much variation among patients.
That's actually not exactly the same way. Whenever you're doing the dose comparison or a dose equivalence, you have to arrive at either you see how that been mentioned in the books that this much of propofol can be equivalent to this much of sevoflurane, or there are many studies. You could have easily cited those studies that in those studies this much of propofol almost have the similar hemodynamic effects as much as that much dose of sevoflurane. Okay, that is the one question. The next part of question is, it was a very good first time I've seen that in any study, the name of the anesthetist has been told to the patient,
Right.
and then post-operatively they remember the name also. A surgeon may have forgotten the name, but the patient is remembering that. Okay. The third, the most important, last concluding slide you put, you wanted to, this study will be helpful in those areas where early recovery for the cognitive function or the memory is required. Just tell me which are those areas.
So the daycare surgeries mostly because
Which type of patient you require early? I think any person who is undergoing surgery or operation, he wants to lie down calm and compose for the next 24 to 48 hours. So how, if I am going, my bank balance is there, something I have to sign signature, something like that's okay. But that line was a little bit confusing to me, where early return to memory and cognitive function is required. What are those areas? What are those
actually
patients?
it was basically for the people like same day discharge could be done, or like not at any of the major surgeries, but yeah, the daycare surgeries we can like administer sevoflurane to them. So there is early recovery, and the patient could be discharged in 1 or 2 days.
Give me one profession where early this one is cognitive dysfunction and cognitive function and memory is required. Any particular one example? It's out of the syllabus question actually. Just give me that. It's okay. It's okay. Fine. Go ahead. Fine from my side.
Thank you so much. Thank you. Thank you,
Thank you. Thank you, Dr. Pierre.
Thank you.
Thank you, Priya. It was a nice presentation. Now, next we move on to Dr. Tulasi Ram Sundar.
Yes, ma'am. Good afternoon, ma'am. Am I audible?
Yes, yes.
Yeah.
Yes, ma'am. I'll share my screen right now.
Yes.
Is it visible, ma'am?
Yes.
Yes. Please make it a little bigger from slideshow.
Yes, ma'am. 1 second. Yes, ma'am. Yes, ma'am. Is it okay now?
Okay. Yes. Start now.
Yes, ma'am. I'm starting right now. Good afternoon, respected judges, to one and all. Happy Anesthesia Day to one and all, primarily. So my name is Dr. Tulsi Ram Sundar from Netaji Subhash Chandra Bose Medical College, Jabalpur. I'm a third-year resident, and I'm here to present the paper on the topic, comparison of effect of crystalloid preload versus crystalloid co-load on postspinal hypotension in cesarean deliveries. So we know that cesarean section is one of the most commonly performed surgical procedures worldwide, and most of them are being performed under spinal anesthesia. Spinal anesthesia is a very simple, rapid, and reliable technique of anesthesia, but in spite of its advantages, there is a high incidence of hypotension which has been reported always. The hypotension is mainly caused by an increase in venous capacitance and reduction in systemic vascular resistance following the sympathetic blockade due to spinal anesthesia. The sustained maternal hypotension leads to fetal hypoxia and acidosis as a result of placental hypoperfusion. So there are various modalities to prevent the maternal hypotension following spinal anesthesia. It includes mechanical means, positioning the patient, administration of crystalloid and colloid, and using vasopressors. The fluid administration before spinal anesthesia has been a common and traditional practice, but preloading of crystalloid is rapidly distributed and may induce the secretion of atrial natriuretic peptide, resulting in peripheral vasodilation, followed by increased excretion of that preloading fluid. A more rational approach will be to administer the fluid after spinal anesthesia, and this might maximize the intravascular volume during vasodilation from the sympathetic blockade and limit the fluid distribution and excretion. Our primary aim is to evaluate and compare the effectiveness of preloading and co-loading of crystalloids in prevention of post-spinal hypotension and cesarean deliveries. And the primary objective was to observe the influence of preloading and co-loading of crystalloids on the incidence of post-spinal hypotension, to evaluate the required dose of vasopressor use, and to observe the intraoperative heart rate, systolic BP, diastolic BP, and mean arterial pressure. Coming to the materials and methods, this study design it's basically a comparative prospective randomized study conducted in NSCB Medical College, Jabalpur, from the period of 1st March 2020 to 31st August 2021, after obtaining the Institutional Ethical Committee clearance. The sample size was calculated as 100 based on the study of A.O. Eng et al. With the power of 80%, marginal error of 9%, and the z-score of 1.96. The inclusion criteria included all pregnant women of ASA grade 2 who are scheduled for cesarean section under spinal anesthesia. The exclusion criteria included patients with significant cardiovascular diseases, renal, hepatic, and thyroid disorders who were diagnosed with diabetes mellitus, preeclampsia, eclampsia, uteroplacental insufficiencies, patients with raised body temperature who are dehydrated who had already existing hypovolemia, and patients with severe anemia, patient with short stature, and patient already on medications such as beta blockers, antithyroid drugs, and antihypertensives. The statistical plan was to present the data in percentage and frequency tables, and continuous variables were summarized in mean and standard deviation or median with interquartile range. Chi-square test was applied to test the statistical difference between different categories, and student t-test was applied to test the difference between two independent means. Coming to the pre-op preparation, all patients were explained in detail about the anesthetic procedure and written informed consent were obtained. All patients after arrival at the OT, the standard monitors were connected, including ECG, non-invasive BP, heart rate, and SpO2, and the baseline values were recorded. All patients were catheterized, and precautions were taken for the whole intraoperative period to prevent hypothermia. An 18-gauge intravenous cannula was secured, and pre-medication of injection ranitidine 50 mg and injection metoclopramide 10 mg were given intravenously. The total study population of 100 parturients were randomized divided into two groups by lottery method, including 50 patients in group P, which is the preload group, who received 15 ml per kg of crystalloid 20 minutes before spinal anesthesia, and group C, which is the co-load group, receiving 15 ml per kg of crystalloid immediately after spinal anesthesia. The patients were placed in the left lateral position. Dural puncture performed at L3, L4 space with the 25 gauge needle. Hyperbaric bupivacaine of 0.5% 10 mg was given. Patient was made to lie down with the wedge under the right buttock. BP, heart rate, mean arterial pressure, SpO2 measurements were made. And after delivery of the baby, injection oxytocin 20 international units in 250 ml RL was given. Intraoperatively, blood pressure measurement, heart rate, and mean arterial pressure and SpO2 were recorded every 3 minutes in the first 30 minutes and then cycled to every 5 minutes till the end of the surgery. Patients developing with a 20% drop in the mean arterial pressure were noted and treated with parenteral mephentermine of 3 mg bolus each time. And the amount of vasopressors administered till the end of the surgery after spinal anesthesia was used to calculate the mephentermine requirements. Nausea, vomiting, and other complications like bradycardia were also monitored till the end of the surgery. Now, coming to the observation and results, in terms of demography, there was no significant correlation between the age, weight, and height of the study population. Coming to the mean arterial pressure, there was a significant fall in mean arterial pressure in the preload group compared to the co-load group from the beginning to the 6th minute and from 30 minutes till the end of the surgery. And coming to the heart rate was significantly raised in the preload group compared to the co-load group almost throughout the surgery. And coming to the total dose of mephentermine used, there was significant increase in dosage of mephentermine in the preload group with a mean of 5.73 compared to the co-load group with a mean of 4.05. And coming to the number of doses of mephentermine given, that was also significantly higher. That is the maximum dose of 3 doses given for 18% of the preload population, and the least doses given, that is nil doses, was given maximum 64% in the co-load population. And coming to the incidence of nausea, positive incidence was noted higher in the preload group, that is 24%, and very less in the co-load group, that is 4%. So coming to the discussion part, the pre-delivery period is when the parturient is most at risk for hypotension after spinal anesthesia. Sympathetic nerve blockade is completed within 10 minutes after administration of bupivacaine in the subarachnoid space, and this leads to high chances of hemodynamic changes like hypotension and bradycardia. So there have been various studies to find out the efficacy of co-loading in curtailing these hemodynamic changes. And in this particular study, there was a significant difference between both the groups. That is, the patient who received a rapid crystalloid infusion after induction of spinal anesthesia, that is the co-load group, had significantly lesser fall in mean arterial pressure and lesser raise in heart rate than the co-load group, than the preload group. So this is in concordance with the study of Ah Eng et al., Mojica JL et al., and Kamenik et al., who have also suggested that incidence of hypotension was lower in the co-load group compared to the preload group. So in our study, the patients belonging to the co-load group also required less cumulative doses of mefentramin, and less number of doses were also instituted compared to the preload group. And there was also less incidence of nausea in the co-load group compared to the preload group. All these inferences were somewhat different from the previous studies of Siddiq Syed et al. And Nishikawa et al., which showed that there was no superiority of either methods over the other, which was the primary null hypothesis. So coming to the conclusion, an equivalent volume of crystalloid administered rapidly immediately after administration of spinal anesthesia for cesarean deliveries is associated with lower incidence of hypotension, lesser requirement of vasopressors, and lesser incidence of adverse effects than the conventional preloading method. These are my references. Thank you.
Good presentation, Sundar. I
Thank
just
you,
want
ma'am.
to ask only one question. Like, any extra
Yes, ma'am.
monitoring would have helped you in this, conducting in this study?
Extra monitoring in the sense of vitals, ma'am, or
like when you are giving fluids to the patient?
Yes, ma'am. When we are giving fluids, regarding the duration of the infusion
have
of the
given
fluid,
you a
ma'am?
better guidance about your hemodynamic parameters and intravascular expansion.
Ma'am, CVP, but measurement could have been done for volume, this thing, but for a LSCS case, practically it was impossible, ma'am. So,
but when you are conducting a study and you just want to prove that this is better than this, co-loading is better than your preloading, then some authentic test should be done to see it also. Like,
yes, ma'am, I agree. I agree, ma'am. CVP monitoring would have been a much better option. I agree.
Secondly, I would like to add that the volume of fluid which was been given, if that would have been kept fixed, or
Yes,
a
ma'am.
rate of giving the fluid, that could be that should have been monitored well, I think. So comparing that 20 minutes prior giving prior and then co-loading fast fluid giving, so one should monitor the rate of fluid administration as well. That would also
Yes,
help
ma'am.
you
Yes,
out, because you said we gave fast fluid as soon as we gave the spinal.
Yes, ma'am.
But you should have monitored the rate
Yes,
of
ma'am. Yes, ma'am.
administration of fluid as well when you were giving crystalloids or colloids to the patient, either ways. Right, that would have also helped.
Yes, ma'am.
At the same time, the level of your subarachnoid block, that would have also, that is also another major issue in these patients, basically, and the amount of
Yes,
drug which
ma'am.
was been given for the subarachnoid block. Right?
Yes, ma'am. But the level and the dosage was fixed for all
fixed
patients,
for all
ma'am,
the
to
patients.
avoid discrepancy and confounding, and it was derived from the previous parent literature. So it was fixed for all patients, ma'am.
Okay, Dr. Sundar, I just want to ask.
Yes, sir.
I want to ask you one question only. When you are giving the very fast fluid in the first 10 minutes, I have already told that it takes around 10 minutes for the drug to get properly fixed. During that time,
Yes, sir.
the judges are correct that the rate of administration has to be controlled for the safety of patients also. The next part is because in all the sections, these are elective sections, no? Elective sections or emergency?
All sections he took, all.
Elective and
as well as
emergency.
emergency.
Everything was elective. Yeah.
There
Sir, most of the surgeries were
elective,
ma'am.
Okay. One thing you must have mentioned in this study about the life of the fetus the position of the fetus, the size of the fetus, how much compression of
Yes,
the
sir.
IVC have been there,
Yes,
would
sir.
have been there.
IVC was there. Yes, sir. I agree.
Because those factors you cannot describe in this study. Those have to have something more of ultrasound, size of the baby, the compression of the IVC. Those are very important in determining and getting the study biased or unbiased towards the rate of administration of fluids. That you should have added your limitation
Yes, sir.
when you publish or when you send it for somewhere else. Okay. That's
sure, sir. Sure, sir.
Thank you, Dr. Sundar.
Thank you.
Thank you, Dr. Sundar.
Thank you, ma'am. Thank you very much.
Let's move on to our next candidate, Dr. Koti Prem.
Good evening, everyone. I'm going to present.
Please share your screen.
Yes, yes. Mom, are you able to see the screen now?
Yes, yes, yes.
Hello.
Yeah.
Am I audible? Can I good to go?
Yeah.
The आवाज कट-कट के आ रही है, Dr. Koti.
Ma'am, right now it's
clear.
Ma'am, is it okay right now, ma'am?
Yeah.
Yeah. Super.
Yes, ma'am. Yeah. The topic that I have taken for the presentation today is the comparison of dexmedetomidine and fentanyl as a co-induction agents to propofol for the insertion of laryngeal mask airway. For many years, the airway management have emphasized largely on the successful tracheal intubation. But in 1981, the invention of this laryngeal mask airway, the focus has been changed from the intubation to oxygen and ventilation. The main advantages of this laryngeal mask airway is that they're less invasive, better tolerated, improved hemodynamic stability, less sore throat, and less coughing and hands-free airway. In general anesthesia, basically, there is a loss of protective airway reflexes, and obstruction of the upper airway can be life-threatening. In such conditions, supraglottic airway devices such as ProSeal laryngeal mask airway could provide a relative secured airway. The aim of my study is to evaluate and compare the dexmedetomidine and fentanyl as co-induction agents to propofol for this ProSeal laryngeal mask airway insertion, and the total propofol required for this insertion. And my primary objective is to investigate the induction time, ease of insertion, and the insertion time, and the hemodynamics with the ProSeal laryngeal mask airway. And my secondary objective is to investigate the number of attempts of the LMA and the additional propofol requirement if the jaw relaxation is not there, and to find out any adverse effects. And the criteria that I've taken is the ASA grade 1 and 2, and the age between 20 to 60 years, and either of the six are my inclusion criteria, and other I have excluded the patient refusal and pre-existing diseases, or if any having a patient requiring the post-op ventilation, or if there is an allergy to the drug, or the BMI of the patient being more than 30, if the patient has reduced mouth opening and the patient is on beta blocker therapy, the base heart is less than 60, or the patients at the risk of aspiration has been excluded. So material that I have required for the study is the Boyle apparatus with oxygen supply and suction apparatus, laryngoscopes and multipara monitor, and endotracheal tubes for an emergency patient if insert the ProSeal laryngeal mask, and also the ProSeal LMA, the drugs for the general anesthesia, BIS monitoring, and the injection dexmedetomidine, injection fentanyl, and sterile syringes and IV fluids. The methodology is that the study has been conducted in the Department of Anesthesiology in MGM Medical College, and the study is a prospective and randomized. This is a comparative study. The samples that I have taken is 60 patients and randomly allocated into 2 groups, and I have randomly allocated by the closed envelope method, and I have divided it into 2 groups by P plus D, where the patient has received propofol and dexmedetomidine at 1 mic per kg, and propofol and fentanyl and at 1 mic per kg fentanyl. And the methodology of all the patient has been explained, the anesthesia technique and the perioperative course, and the laboratory investigations preoperatively we have taken. In the preoperative room, IV line is secured, and patient age, IP number, body weight, and basal vital have been recorded. And all the patient has been fast for 6 hours in the preoperative room, and in the preoperative routine monitors, including the ECG, pulse oximetry, BP, and entitled carbon dioxide and BIS monitor has been applied. The injection glycopyrrolate 0.004 mg per kg given IM 30 minutes before the procedure, and the study has been conducted in the OT with the administration of the study drug over 10 minutes with a syringe. The 30 seconds after the administration of the study drug, propofol has been titrated at a dose of 2.5 mg per kg for the induction of anesthesia till the patient has achieved the BIS value of between 50 to 45. After 90 seconds, the lubricated procedural laryngeal mask airway, according to the patient weight, has been inserted in the sniffing the morning air position. If the mouth opening is not adequate, if the patient is having any cough, excess cough or gag reflex, the further anesthetic depth has been maintained by giving bolus of propofol 0.5 mg per kg. Even if the failed second attempt, that case has been excluded. So the vitals like heart rate, systolic BP, diastolic BP, mean heart pressure, SpO2, EtCO2, and respiratory rate has been recorded in the baseline and the pre-induction time and 1, 3, 5, 10, 15 minutes after the LMA insertion. The induction time, insertion time, and the ease of insertion and additional doses of propofol and number of attempts has been taken into consideration. So I want to define this, what is this induction time and what is this insertion time. I have defined this induction time is the time interval between the administration of the induction agent and the loss of consciousness to the reach of the BIS value between 50 to 45, which is actually the appropriate level for the general anesthesia. This is considered as the induction time, and the insertion time is defined as the time interval between the tip of the procelaryngeal mask airway crossing the incisors to the confirmation of displacement by the waveform capnography. So in this methodology, the different criteria has been taken from a previous study. So these are the scoring levels that I have taken, and the combined score of these two with less than or equal to 2 has been considered as the optimal level of the procelaryngeal mask insertion. In my observation, I have completed the study in these two groups, and in terms of age, sex, and weight and ASA grading, I have observed that there's significant reduction of the heart rate after administration of the study drug in dexmedetomidine group and remains significant at first minute after the insertion of the laryngeal mask airway. And hemodynamically, I couldn't find any statistical significance between these two groups. And there is a statistical reduction of the respiratory rate in either of the groups after induction of the with the propofol with the study drug, but the statistical significance has been seen only after 5 minutes after the insertion of the LMA. Although SpO2 and EtCO2 are not so significant. So these are the charts that I have showing you. Then I have in the bar diagram of the induction time, I've compared these two drugs, and the induction time has been relatively less with the dexmed group than in fentanyl group. And the ease of insertion also, that I've seen only one patient has got a cough reflex and with the dexmedetomidine, and 3 patients with the fentanyl group. So in this observation charts and the result chart have included the induction mean time and at 8.1 seconds, 8.1 minute with a standard deviation of 0.6, and the PF group is 9.6 seconds, 9 minutes plus or minus 2.1 minute. And these are the things. And in the discussion part, I will want to discuss this before the era, the LMS have been introduced with the thiopental sodium, sevoflurane, and propofol for this smooth insertion. And propofol having a short duration of action and adequately suppress this pharyngeal and laryngeal reflexes, they cause in a dose-dependent cardiac respiratory depression when they are used alone. So different co-inductions have been used so far, like low-dose muscle relaxants, opioids, and benzodiazepines have been used with the propofol to decrease these unwanted events while inserting this PLMA. However, opioids on the other hand may increase the respiratory depression and also increase the hemodynamic instability that caused by propofol. So this novel drug, the selective alpha-2 agonist such as dexmedetomidine, has been used for the co-induction with the propofol to evaluate the insertion conditions. To our surprise, we have significantly seen that the lower mean induction.
Dr. Koti, your time is up now, so you can get to conclusion. Yeah.
In the conclusion, I would conclude that dexmedetomidine significantly reduced the induction time and provided the ease of induction with the Procil LMA as compared to fentanyl, and the number of attempts and additional propofol requirement and adverse effects such as apnea, breath holding, expiratory stridor, tearing are less with the dexmedetomidine when compared to fentanyl when they are used as a co-induction, maintaining the stable hemodynamics. These are the references that I produced.
Thank you, Dr. Koti. Now over to you, Jagdish.
So, Dr. Gothi, have you calculated the emergence time with the two drugs?
Ma'am, my study has been conducted to know the ease of induction. Yes, ma'am. Induction, how ease LMA has been introduced by comparing these two drugs, ma'am, and also compared the propofol that is required by the patient. How much propofol is required for the patient for the
or hemodynamic and respiratory parameters?
Yes, ma'am. I could observe that the respiratory rate has been eventually decreased in these two groups, but it is significant only after 5 minutes of after the insertion of PLMA, and the respiratory depression part is already patient has been. It's not the significant between these two groups, ma'am.
Dr. Koti, it was the one person who conducted all the cases for you?
Yes, ma'am. It was me
because
who conducted.
the results are definitely going to change with each person when you are giving
No, ma'am. To exclude that bias, I am the one who conducted all this,
ma'am. Okay. Did you find any bradycardia or hypotension in any of the groups?
Ma'am, yes, ma'am. Bradycardia and hypotension are actually the pharmacological aspect of these two drugs to produce the bradycardia, and the heart rate decrease has been significantly seen in the dexmedetomidine group when it is given in a faster rate. Ma'am, but if that doesn't give that much clinical significance between these two groups, ma'am.
Okay. And did you find any because you had to give the dexmedetomidine slowly, so the induction time definitely goes increases with this, isn't it?
Ma'am, these two study drugs have been given in over 10 minutes, ma'am. So my so the propofol giving time to reach the BIS value of between 50 to 45 is my induction time.
Okay.
So to my surprise, I have seen that, ma'am, 2.5 mg per kg is the propofol that I have predefined. But I have observed in the dexmedetomidine group that the patient has relatively required less than the predefined propofol, ma'am. The patient has been sometimes, some patients have been reached the BIS value between 50 to 45 at 2 mg per kg. Some patients have been required at 1.8 mg per kg. So in this way, I could say that dexmedetomidine is really a good alternative for insertion condition of this post-ileal arrangement of PLMA.
But as Dr. Shikha said, you should have also observed the emergence time as well between the two drugs. I agree with her.
Yeah.
Okay.
With hemodynamic and respiratory monitoring is very important in such cases, actually, which you have mentioned nicely.
Dr. Koti?
Yes, sir.
Your age range is quite wide, 20 to 60 years. And
sir, actually, yes, sir. I have relatively taken that as a specific part because I excluded the children and the old age group, sir, because the drugs that I'm using are actually in the process laryngeal airway. The sizes are not that easily available for the children. At the same time, the drug that I'm using is dexmedetomidine, which actually has quite destabilizing in old age group where patient has already have inbuilt like cardiovascular. So I have excluded the age groups in such a way that I have fixed this as 20 to 60, sir.
That's what I want to say. There are 2-3 limitations there of taking that with larger group. First
yes,
of
sir,
all,
I do agree. I have excluded the pregnancy part. I have excluded children, and also
I haven't said anything. You are agreeing to that. I'm saying that in that large age, from 20 to 60 years, the ease of insertion for the procedure always the difficulty gets increases because of the structural changes in the jaws and the neck, soft tissue neck, and with the comorbidities also there, the ease of insertion, it always increases. Second part is with the old age, the conduction fibers of cardiac tissue, the dexmedetomidine has more profound effect in the older age group as compared to the younger group. There are many studies about that. The third part is that suppose if you would have got a very, dangerous bradycardia, what would have you been using to neutralize the effect of dexmedetomidine?
Sir, actually, dexmedetomidine has this effect that can be readily reversed by this alpha-2 antagonist like antipramizole. But unfortunately,
Is it available? Is it available?
No, sir, it is actually not a FDA-approved drug.
No, is it available? Anywhere?
No, sir.
Anywhere in the world?
No, sir.
So
no,
how
sir.
can that's what whenever such patients you are undertaking for study, it's always ethical committee gives the clearance that the bradycardia caused by dexmedetomidine should be reversed with some drug. Which drug you kept ready for the reversal of bradycardia in your cases?
Sir, I have kept my atropine as a...
Atropine, it does not respond to atropine at all. The bradycardia caused by dexmedetomidine is does not respond to atropine. They do not, does not respond to the routine drugs which are used for bradycardia.
Some other drug?
Ma'am, yeah, ma'am, dopamine and all these drugs, all the Vespersa that I have kept, but I haven't seen any that significant bradycardia in these patients.
No, it's
But-
not about it's not about whether you have seen or not.
Yes,
but
yes,
when,
correct.
When you are conducting a study, the safety of patient is the
You should be
priority.
prepared for the adverse reactions as well.
And it was you who were doing all the procedures, so it was a primary responsibility of yours to go through the literature thoroughly and prepare for any eventuality resulting on the table, isn't
Right.
it?
Thank you, Dr. Koti.
Thank you, ma'am. Thank you.
Thank you, Dr. Koti. Our next candidate is Dr. Krishnakant Goti.
Goti. No, it's Goti. It's
Goti,
not Goti
Goti.
now. It's Goti.
Sorry, ma'am.
Rather, it would have been me who will be pronouncing the names differently.
Goti.
In Punjabi accent, it becomes something different, basically.
Right.
Dr. Krishnakant?
Goti.
Goti.
Dr. Krishnakant, are you there?
Yes, ma'am.
Okay, he's there. Okay.
Good
Krishnakant,
afternoon, ma'am.
please share your screen.
Yes, ma'am. Hello.
Yes.
Hello, good afternoon,
Good.
ma'am.
Please share your screen.
Dr. Krishnakant, open your
Yes, ma'am.
PowerPoint presentation, no?
Yes, ma'am.
The background, and then share your screen, then it will come.
Now my screen is visible, ma'am.
Yes.
Yes.
Good
To make
afternoon,
it bigger,
everyone.
go to
Yes, ma'am.
slideshow.
Yes, ma'am.
Slideshow. Yeah.
Yes.
Yes, ma'am. Good afternoon. Myself, Krishnakant Goti. My study topic is comparative study of induction and recovery characteristics of propofol and sevoflurane in a daycare fibroadenoma surgery. And the introduction, the ambulatory anesthesia is the one administered for elective surgical procedure performed under selected patient, which is undertaken with all its constituents like admission, surgery, and discharge on the same day. It is also referred to as a day case and daycare for outpatient anesthesia, and more recently office bed anesthesia. This is related primarily to the cost saving and enhanced convenience for the patient. Daycare anesthesia is rapidly growing subspecialty now, although its history is as old as history of general anesthesia. And anesthetic agents today have been designed and marketed to meet specific criteria for ambulatory anesthesia. Among the agents available in India, propofol and sevoflurane have increased the ability to the anesthesiologist to provide a successful day case experience. The relatively new and less soluble inhaled anesthetic agent sevoflurane have added a new dimension to the patient care. In a theory, they allow fast recovery and early discharge than the more traditional inhaled anesthetic agent. Less soluble inhaled anesthetic agent sevoflurane help in fast tracking. However, the anesthetic are associated with the increased cost compared to older anesthetic agent. As a result of favorable recovery profile and low incidence of side effect, propofol has been drug of choice for induction of anesthesia and daycare surgery. Propofol infusion are also becoming increasingly popular for maintaining of daycare anesthesia. However, propofol is associated with pain on injection and cardiovascular respiratory depression also. Many anesthetic issues may delay hospital discharge, cognitive recovery, cardiovascular stability, and post-operative nausea, vomiting also there. Post-operative pain is the important factor. 30% of patients reporting the moderate to severe pain following ambulatory surgery. Aims and objective: the aim to compare the induction and recovery characteristic of propofol and sevoflurane and daycare fibroadenoma surgery. The objective first one is to compare the time to loss of consciousness, and second to recovery time and incidence of post-operative nausea, vomiting, and pain, and third to compare the induction complication. Material method, the study is a comparative hospital observational hospital-based study. Sample size was calculated to be 60 by using OpenAP software, where the sample size for comparing two means, where data of mean and standard deviation of two groups were entered from previous study. Now, inclusion criteria: ASA grade 1 and grade 2. Age group is 18 to 35. Inter-incision distance more than 3 finger. Undergoing daycare fibroadenoma surgery. Patient normally able to ambulate and educated attender. Exclusion criteria: ASA grade 3 and above. History of drug allergy. Anticipate difficult airway and history of severe adverse experience with anesthesia and history of motion sickness and hyperemesis. Procedure: the study is carried out in the major OT complex, Bundelkhand Medical College, Sagar. 60 patients undergoing fibroadenoma surgery were selected for the study. Age ranges from 18 to 35 age. All patients ASA grade 1 and grade 2 after PSC fitness were selected. An informed written consent was obtained from all the patients. Each patient was randomly allocated to either the propofol or sevoflurane group. Name was P for propofol and AS for sevoflurane. Both group pre-medication glycopyrrolate 5 microgram per kg and fentanyl 2 microgram per kg prior to the induction of anesthesia. Group P with propofol 2 induction with propofol 2 milligram per kg IV with nitrous oxide and oxygen to 4 liters to 2 liter ratio in a closed circuit after securing the airway, and maintaining 2:1 liter ratio. Continue propofol infusion 100 to 200 microgram per kg per minute IV. And group S induction with sevoflurane 4% in nitrous oxide and oxygen, same 4:2 liter ratio in closed circuit, and maintaining with sevoflurane 2.5% nitrous oxide and oxygen 2:1 liter ratio. And this is the chart from same thing. Statistical analysis plan. The quantitative variable were expressed as a mean and standard deviation, and qualitative variable were assessed as proportion and percentage. Appropriate statistical test was applied in which p-value is less than 0.05 was considered statistically significant. Student p-test for comparing the two means, and chi-square test for proportion. Parameter assessed studied time to loss of consciousness, induction complication, and time to discontinue sevoflurane and propofol phase 1 with LRAD score less than more than equal to 9, and phase 2 modified anesthesia discharge score system. Now comes to observational result. Table 1 showing the demographic, which was statistically not significant. P-value is more than 0.05. Table 2 is the comparing the groups and with loss of consciousness. The mean of time to LOC was observed to be lesser in the group P than the group S, and the difference was statistically significant. And table 3 showing the induction complication in group. This is also significant. The number of cases with induction complication was more among group S than group P. Then table 4 showing the recovery, which was statistically not significant in both groups. And table 5 showing the post-operative nausea and vomiting. Distribution of post-operative nausea and vomiting and pain is less in the group P, but not significant. Now come to the discussion. Intravenous agents are used commonly for the induction of anesthesia, followed by inhalation agents for maintenance. A problem with this technique is to transition phase from induction to maintenance. The rapid redistribution of the intravenous agent could lead to lightening of the anesthesia before an adequate depth is attained with inhalation agent. This is a rediscovery of single agent. In our study, we found that induction with sevoflurane is longer and associated with more complication. This is concurrent with the study done by W. Scott comparing the induction and maintenance of anesthesia in adult patients with sevoflurane and propofol. They found that induction of anesthesia is shorter with propofol, and side effects involving the airway excitement were more during mask induction with sevoflurane as compared to propofol. This explains the more incidence of bronchospasm observed in the sevoflurane group. The occurrence of bradycardia during induction of anesthesia in sevoflurane could be explained by direct sevoflurane-induced inhibition of beta-adrenergic receptor. Though statistically not significant, phase 1 recovery emergence from anesthesia is shorter. This is concurrent with the study done by S. Edmonds. In this study, we found that the phase 2 recovery time after induction and in maintenance of anesthesia with propofol and sevoflurane were comparable. The lower incidence post-operative nausea vomiting in the propofol group may be related to intrinsic antiemetic property of propofol. The shorter time required the post-operative analgesia in sevoflurane and group P reflects this rapid recovery. And now come to conclusion, phase 1 and phase 2 recovery comparable in both group. Sevoflurane induction is slower and more complications. So, and post-operative nausea vomiting with not significant in both group. So we conclude that smoother induction and less post-operative nausea vomiting, pain propofol make it more ideal for induction and maintenance of daycare fibroadenoma surgery. Thank you.
Thank you, Dr. Krishnakant. Now over to you, judges.
So what is your interpretation, Dr. Krishnakant? Actually, I couldn't get it.
Ma'am, for daycare fibroadenoma surgery, the induction and recovery is better with propofol as compared to sevoflurane.
And what other added advantages with propofol?
Post-operative nausea vomiting also less in propofol group, and
the type of recovery?
Type of recovery in both group are comparable with not significant.
And what happened if the MAP or HR was increased intraoperatively? What you have extra done in that case?
Yes, ma'am. I observed the both group. The heart rate is more in sevoflurane group, and the arterial pressure is not significant in both the group.
Hemodynamically, both the patients remain the same?
Statistically not significant, but propofol group is more fall in BP.
Did you study the requirement of both the drugs from induction to till end of surgery?
Sorry, ma'am?
Requirement of both the drugs, or calculated the amount of drug required in both the groups? Did you calculate that?
No, ma'am. Induction dose for propofol is 2 milligram per kg, and for maintenance, I didn't calculate, ma'am. Yes.
I think that you should have done, because you were maintaining the same drug.
Yes, ma'am. Same drug.
Maintaining the anesthesia with the same drug. So you should have at least calculated the amount of drug required. Because sevoflurane, when you induce the patient with sevoflurane, adult patient induction with sevoflurane directly.
Yes, ma'am.
So you should have calculated that as well.
Okay.
How you have seen the depth of anesthesia in such patients?
Ma'am, just after induction to the loss of ILSS reflex to
maintenance part and all. That's why I'm asking whether if any case you have seen increase in mean arterial pressure and
Yes,
heart rate.
Yes, ma'am.
And what extra added thing you have done for such cases?
Actually, I observed the
Because there are too many lacuna in your study. Like,
yes, ma'am. Mean arterial pressure and heart rate. I mentioned.
How you have seen the depth of anesthesia?
Didn't do that.
Do you have any BIS monitoring or something else there?
No, ma'am.
Some extra criteria are there for monitoring such patients?
No, BIS monitoring.
Dr. Gothi.
Only
two questions from my side. How you calculate the sample size, and what is the novelty in your study?
Sir, sample size calculated by OpenUP software, in which the data.
You have already described in your slides. I just wanted to how you arrived at how do you calculate it basically.
Sir, just
putting
on
the basis of primary objective, how you arrived at that sample size.
Yes, sir. Previous study loss
that
of
I also saw in your slide. That's what was you expecting something with your hypothesis, null hypothesis or alternate hypothesis. What was the basic thing was there which I think prompted you to arrive at this particular sample size? Because that would also create the novelty in the study also. It's fine. It's okay. Fine. It's okay.
Okay. Thank you.
Thank you, Dr. Krishnakant. Now we move on to our next candidate, Dr. Nivetha M. Nivetha, have you logged in? Yes. Nivetha, please share your screen.
Yes, excuse me. Stopped it. Ma'am, you stopped my video, ma'am, so I can't able to share my video.
It's coming.
It's there now.
Yeah.
Ma'am, let's start, ma'am.
Yes, please. Yes, please make it bigger by slideshow. Yeah. Start, Nivita.
Yes, ma'am. Can I start now, ma'am?
Yes.
Good afternoon, ma'am. My topic is comparative study of fascia iliaca compartment block and 3-in-1 nerve block for postoperative analgesia after hip hemiarthroplasty. Myself, Dr. Niveta M. My guide, Dr. Akhtar Singh Yadav, co-guide Rajiv Divedi, Dr. Sudhakar Divedi, Department of Anesthesiology, SSMC, Riva. Introduction: pain after hip hemiarthroplasty surgery may potentially hinder postoperative physiotherapy and early mobilization. Regional anesthesia of the lower limb appears to be effective for postoperative pain control in this setting, and it has been shown that lumbar plexus blockade provide high quality analgesia as the femoral nerve supplies the anterior hip joint capsule as well as the proximal femur, quadriceps, iliacus, and pectineus muscle. To avoid the complication and adverse effect of spinal anesthesia and intravenous opioid analgesia, multimodal analgesia with nerve block has been recommended in the perioperative period of lower extremity and joint arthroplasty. Among the various nerve block technique available, 3-in-1 nerve block and fascia iliaca compartment block are commonly used for anesthesia and analgesia in hip surgery. A prospective study demonstrated that 3-in-1 nerve block could achieve a success rate of 81% block of the femoral nerve, 96% of the lateral femoral cutaneous nerve, and 4% of the operator nerve. These nerves can also be blocked together by FICB because this fascia iliaca compartment contains these nerves within its potential space. The main objective of the current study was to compare the practicality, analgesic efficacy, complication of ultrasound guided 3-in-1 nerve block and FICB in elderly patient undergoing hip arthroplasty. Aims and objective: to compare the analgesic efficacy, to assess the duration of analgesia, to assess the additional analgesic requirement, to assess the incidence of any adverse effect. Study design: it is a prospective randomized control study. Material and method: after getting approval from Institutional Ethics Committee, present study was conducted in the Department of Anesthesiology, SSMC, Riva, from Jan 2020 to December 2020 on 90 patients posted for hip hemiarthroplasty under subarachnoid block. Inclusion criteria: patient age 50 to 75 years, of either sex, undergoing hip hemiarthroplasty of ASA grade 1 and 2. Exclusion criteria: significant disease like asthma, diabetes, hypertension, cardiovascular disease, contraindication to fascia iliaca compartment block and 3-in nerve block, patient refusal, allergic to local anesthetic, infection over injection site, coagulopathy, psychological disorder like mental illness and dementia. Patient fulfilling the selection criteria were randomized using a computer-based randomization software in 3 groups of each depending on the block given. Group 1 receive USG guided fascia iliaca compartment block with 30 ml of 0.25% ropivacaine at the end of the surgery. Group 2 receive USG guided 3-in-1 nerve block with 30 ml of 0.25% ropivacaine at the end of the surgery. Group C control not receive either of the block. A detailed history of all selected patient was taken. A thorough pre-anesthetic evaluation including the airway, back of the patient, and the site of the block given was performed. The patient were explained about the entire procedure. Informed consent and video consent were taken from them. They were educated about the visual analog score. Thereafter, they were shifted to the operation theatre. Intravenous line was secured. Monitors were attached, and baseline parameters like heart rate, systolic and diastolic blood pressure, mean arterial pressure, SpO2, and ECG traces were recorded. Subarachnoid block with injection bupivacaine 0.5%, bupivacaine 2.5 ml at L3 L4 interspinal space via 25 gauge Winky spinal needle in sitting position was given to all patients. Standard hemodynamic monitoring was done. Fascia iliaca compartment block or 3-in nerve block was performed under real-time USG guidance with high frequency ultrasound probe, main rate DC 30 at the end of the surgery in group 1 and group 2 respectively. Group FICB, here our goal is to give the block between the fascia iliaca and the iliacus. Our landmark is between the medial 2/3 and lateral 1/3 of anterior superior iliac spine and the pubic tubercle. As the needle passes through the fascia iliaca, fascia is first seen intended by the needle. As the needle eventually pierces the fascia, a pop may be filled and fascia may be seen to snap back on the US message. After negative aspiration, 30 ml of 0.25% ropivacaine was injected between the fascia and the iliopsoas muscle with the necessary needle reposition. Then 3-in-1 femoral nerve block. The inguinal ligament. This block is given by 2 cm below the inguinal ligament. Lateral to this structure, femoral nerve sheath is visualized and appears as hyperechoic triangular structure. A small skin wheel over the target site is made. Needle will be inserted 2 cm distal to the inguinal ligament in a lateral to medial direction at 30-degree angle. Once the needle comes into the view on the US monitor, the tip is positioned as close as possible to the femoral nerve, and aspiration can be done to ensure there is no infiltration into a vessel. After negative aspiration, 30 ml of 0.25% ropivacaine is injected with necessary needle deposition. After completion of the surgical procedure and block, patient were transferred to PACU. Pain severity was assessed using a visual analog scale, which was recorded at 0, 2, 4, 6, 8, 12, 18, and 24 hours after block. When VAS score equal to or more than 4, or the patient first demand for analgesia, injection tramadol 100 mg IV was given as rescue analgesic. The duration of the analgesia and total tramadol consumption the first 24 hours were noted. Patient satisfaction score was assessed using 5-point scale: highly satisfied, satisfied, neither satisfied, not dissatisfied, dissatisfied, highly dissatisfied. The study was completed 24 hours after block displacement. Statistical analgesic. All the measurement data were presented mean plus or minus standard deviation, and the statistical processing was performed using SPSS software. The categorical data analyzed using chi-square test, while quantitative data by one-way ANOVA and student t-test. The data with p-value less than 0.05 are considered as significantly significant. Demographic parameters. In our study, all 3 groups have similar demographic parameters and duration of surgery. Difference between 3 groups were statistically comparable, p-value more than 0.05. VAS score. The mean VAS score was more in controllable group compared to both the study group, which was statistically significant. And also among the study group, FICB has low VAS score compared to 3-in-1 femoral nerve block, which has significant p-value less than 0.05. Duration of analgesia. The time of first rescue analgesia was higher in FICB, about 11.87, and then compared to control group, which is about 4.67, which is also significant, p-value less than 0.05. Total tramadol requirement in the first 24 hours. The total analgesic requirement was lower in FICB. It is about 123.33, and in 3-in-1 nerve block, it is about 140, and in control, it is about 226. It is have a significant p-value of less than 0.05. Then patient statistic group. In a group FICB, 56.7%, and group 3-in-1 FNAB, it is 36.7% has highly satisfied, whereas patient in control group, none of them was highly satisfied, which is statistically significant. No adverse effects was found other than nausea and vomiting. It is treated with ondansetron. Discussion. In our study, group FICB was having better post-operative analgesia, longer duration to first rescue analgesia, and lower dose of total rescue analgesia consumption in 24 hours post-operatively compared to 3-in-1 femoral nerve block and control group. Similar results were found by L.T. Geral et al. 2012, Pandyan Jawar et al. 2014, Shukla et al. 2018. A summary and conclusion. Because of the aging of the population, the number of elderly patients accepting hip surgery were increasing by the year. Initial anesthesia cannot only decrease the stress response caused by surgery and pain, but can also shorten hospital stay, reduce medical bills, and allow yearly post-operative rehabilitation. Peripheral nerve using local anesthetic allow the patient to avoid the adverse effect of opioid analgesic, reduce the risk of post-operative chronic pain. With the low concentration of local anesthetic for post-operative analgesia, it is possible to selectively block the sensory nerve fibers. Preservation of motor function promotes yearly rehabilitation and decrease the risk of deep venous thrombosis. Peripheral nerve block is also less likely to cause post-operative cognitive dysfunction, decrease intraoperative blood loss, and improve blood circulation, reduce the incidence of post-operative delirium, complex regional pain syndrome, and cardiovascular complication. So we conclude that FICB and 3-in-1 nerve block both recommend for post-operative analgesia after hemiarthroplasty, while FICB technique better in terms of high degree of sensory blockade of LFC nerve and improve analgesia when continuous patient passive motion is initiated in early post-operative period. And FICB is easy to perform, reliable, and does not threaten any vital organ. These are my references. Thank you, ma'am.
Thank you, Nivedha. Over to you, judges now.
So what are the other advantages of fascia ilaka block, other than more consistent block and rapid block? Over
Yes, ma'am. There is no extra skill is needed. It is very easy to perform, and no intraneural injection. And we are doing the block with USG guided. So there is no intravascular injection, no intraneural injection. Anatomical accuracy is good, and anatomical accuracy is good, and a long duration of analgesia. Excuse me, ma'am, I can't able to start my video because the host has stopped it.
Don't worry.
Ji, ma'am.
So have you seen any lumbar plexus block extension in any of the cases?
Lumbar plexus block extension.
Yeah, when you are using USG, no?
Yes, ma'am.
So you have followed the infiltration of the drug also?
Yes, ma'am. I can see the spread of local anesthesia also. Ma'am, while giving block, we have to compress at the distal side to avoid the high level of the spread of the local anesthetics for 30 seconds.
In which block?
Ma'am, in both blocks, fascia iliaca and 3 nerve, 1 femoral nerve block.
Okay. So you gave the block post-operatively, isn't it?
Yes, ma'am. At the end of
All
the
the
surgery, ma'am.
patients
Yes,
at
ma'am.
at the end of the surgery.
Yes, ma'am.
Okay. The position was okay for the patients post-operatively?
Yes, ma'am.
Okay.
So what was the anesthetic given to the patients?
Ma'am,
When you have
ropivacaine.
opted, it was regional or general anesthesia?
Ma'am, regional anesthesia, ma'am, because hemiarthroplasty, one thing, and every patient is old age. I'm giving the block at the end of the surgery after regional anesthesia, subarachnoid block.
So it would have impacted the outcomes of these two blocks, the regional.
Ma'am, the duration of the surgery is 2.5 hours. I use only 2.5 ml of bupivacaine. I check till the spinal effect will decrease to T10 progression. Then only I give the block, and I follow up the patient till 24 hours. So I can able to find my result.
So the time of giving the two blocks was different. Till
No,
you waited till the block descends to the T10 level, no?
Yes, ma'am.
Okay.
Dr. Nivita,
Ji, sir.
I was feeling like that I am attending this one, the news channel of 100 Aaj Tak, sabse tej. You know that. And what is your breath holding time?
More than 45 seconds.
I think it must be more than 1 minute because the way you were speaking.
During this pandemic, she must be practicing like.
Yeah, that's why. I just have two things to say. Already 2 points have been covered by ma'am. It's for everybody present here in all the students. Whenever you present a paper in any conference or CME or anywhere, always use a past tense. Never use any future
Present
tense.
tense,
No?
right.
Present or future tense also. So that is very important. Secondly, all the participants who have presented or who will be presenting the scores, just you have shown the satisfaction score. All those scores should be either taken from a reference or they should be validated properly before you putting them into the presentation. You at the bottom of the every slide there should be some reference or there some be validated by this method or that method. That's all what I want to say.
Okay. Thank you. Thank you, Dr. Nivita.
Thank you, ma'am.
Thank you, Dr. Niveta. Now we move on to our next candidate, Dr. Priyanka Harle. Dr. Priyanka?
Yes.
Share your screen. Sorry.
Hello, can you hear me?
Yes.
Yes.
Doctor.
Good evening, respected judges.
Be slightly loud, Priyanka.
Yes. Good evening, respected judges. Myself, Dr. Priyanka. The topic of my presentation is a comparative study to evaluate the efficacy of intubating doses of atracurium and cisatracurium in patients under general anesthesia. Rapid and smooth and safe endotracheal intubation is a crucial component for induction of general anesthesia during surgical procedure. We are using depolarizing and non-depolarizing muscle relaxants routinely to facilitate the smooth endotracheal intubation and to maintain the adequate surgical relaxation. We are using various muscle relaxants which are having certain side effects like residual paralysis, hemodynamic instability, and contraindications for use in hepatic and renal disorders. So the atracurium and cisatracurium are intermediate acting non-depolarizing muscle relaxants belonging to the benzyl isoquinoline class, which both of which undergo metabolism by Hofmann's elimination, and atracurium additionally undergo metabolism by non-specific ester hydrolysis. This atracurium is associated with the histamine release leading to hypotension, anaphylaxis, and hemodynamic instability. Which atracurium also produces metabolite laudanosine, which can cause central nervous system excitation and even precipitate seizures. Aims and objective of my study were to compare the efficacy of intubating doses of atracurium and cisatracurium regarding the intubating conditions, as well as to compare the hemodynamic parameters. And the secondary objective was to observe the side effect profile of both the drugs. Inclusion criteria was the positive consent to participate in study. Age group was 20 to 65 years of both the genders. ASA class 1 and class 2 patients were included. Malapatti class 1 and 2 patients were included. Exclusion criteria was patients refusal, patients with neuromuscular diseases, pregnant and lactating women, patients with anticipated difficult airway, or any known allergy to any of the study drugs. After approval of ethics committee, we have conducted a prospective randomized double-blind comparative study, including 80 patients grouped into 2 categories, each including 40, and as groups A. Group A was A has given intubating dose of injection atracurium 0.5 mg per kg IV bolus. Group CA has given injection cisatracurium 0.15 mg per kg. After attaching all the ASA standard monitors and neuromuscular monitor, baseline parameters were noted. After pre-oxygenation for 3 minutes, pre-medication was done with injection midazolam, glycopyrrolate, pentazocine. Induction was done with injection propofol and 2 mg per kg, and then injection atracurium was given 0.5 mg per kg in group A, and in group B, group CA, injection cisatracurium 0.15 mg per kg was given over duration of 5 seconds, and intravenous line was flushed with normal saline over 15 seconds. Then top was elicited every 10 seconds, and trachea was intubated after 3 minutes with appropriate size endotracheal tube. Then monitoring of hemodynamic parameters were done at 1, 3, 5, 10, and 30 minutes after intubation and throughout the procedure. Any adverse reactions were noted, and maintenance of anesthesia was done as usual. We have studied the intubating conditions by 2 methods. First, by using clinical criteria by Cooper et al. Score, and second was with the TOF response. You can see in the tables. Statistical analysis was carried out with SPSS 25 statistical software. For qualitative data analysis, chi-square test was used. For quantitative analysis, student t-test was applied. P-value less than 0.05 was considered statistically significant. In others, the demographic profiles in terms of age, weight, sex, ASA status, Malambatti grade was comparable in both the groups. Intubation scores, first criteria was jaw relaxation. It was found out that in 35 patients in cisatracurium group, there was easy jaw opening as compared to 31 patients in atracurium group, while moderate jaw opening in was seen in 5 patients in cisatracurium group as compared to 8 patients in atracurium group. Second criteria was vocal cord position in the study subjects. Open vocal cords were seen in 30 patients in cisatracurium group as compared to only 15 patients. 15 patients in atracurium group. Then moving vocal cords were seen in 25 patients of atracurium group as compared to only 10 patients in cisatracurium group. Then third criteria was response to intubation. There was no movement, there is no diaphragmatic movement was seen in case of cisatracurium group. In 28 patients as compared to only 11 patients in atracurium group, and slight diaphragmatic movement was observed in 24 patients in atracurium group as compared to only 10 patients in cisatracurium group. So summing up this to the Cooper et al. Score, it was found that excellent intubating conditions were found in 29 patients in cisatracurium group as compared to only 14 patients in atracurium group, which was statistically significant. Second was assessment of intubating conditions by TOF score. TOF count 0, that is equivalent to the excellent intubating condition, was found in 28 patients in cisatracurium group as compared to only 7 patients in atracurium group. And good intubating conditions, that is TOF count 1, was found in 10 patients in group cisatracurium as compared to 26 patients in atracurium group. As you can see in the graphical representation, the excellent intubating conditions were seen in 70% patients of cis atracurium group as compared to only 17.5% patient in atracurium group, which is statistically significant. When hemodynamic parameters were noted, it was seen that there was no statistically significant difference in the hemodynamic parameters. As you can see in the systolic BP, diastolic blood pressure, and mean arterial pressure and heart rate. Discussion. Ideal neuromuscular blocking agent for intubation should have rapid onset, brief duration of action. It should be free from hemodynamic instability. It should be devoid of residual paralysis, and it should provide excellent intubating conditions, including fully relaxed jaw, widely open vocal cords, and absence of intubation response. Cis atracurium possesses most of these properties. Which is cis atracurium is 3 to 4 times more potent as compared to atracurium. It is not associated with dose-dependent release of histamine. Again, on metabolism, it produces 5 times less laudanocin as compared with that of the atracurium. The usual recommended dose of intubating dose is 3 ED95. In our study, we found superior intubating conditions with 3 D95 dose of cis atracurium as compared to atracurium, which was statistically significant using Cooper et al. Score and top score assessment at 3 minutes. We found, similar results were found in studies conducted by Rahul R. et al. And Mitali et al. But the study by Avishant G. et al. Found the comparable intubating conditions with the 2 ED95 dose of atracurium and 3 ED95 dose of cis atracurium, and both showed better results than 2 ED95 dose of cis atracurium. Similar study conducted by Rohit et al. Found both drugs provided excellent intubating conditions, which may be due to the higher dosage used. Then Alisha S.
Priyanka, your time is up, so wrap it fast.
Yes, and
go to
in our study, hemodynamic parameters were comparable. No adverse drug reactions were found, and no signs of histamine release were noted. Conclusion is that it can be concluded from a study that cis atracurium is better neuromuscular blocking drug in comparison to atracurium, and both drugs have comparable hemodynamic profile and safety profile.
Thank you, Dr. Priyanka. Over to you, judges.
Have you seen any side effects in either of the drugs, Dr. Priyanka?
No, ma'am.
No side effects. The intubating conditions were similar in both the groups?
No, we found better intubating conditions in cis atracurium group as compared to atracurium group, ma'am.
Okay. What was the duration of the block in both the cases?
We have observed the intubating conditions at 3 minutes in both the cases and noted the top response. It was found that in cis atracurium, there was blockade at 3 minutes. And in atracurium group, the top count was 1 or 2 at 3 minutes. And
Madam is asking about the intubating condition actually. Who did the laryngoscopy? You yourself has done the laryngoscopy?
Or somebody else?
Or somebody else? Because there is laryngeal adductors, they respond differently to both the drugs. They have a different response to cis atracurium and to the atracurium.
Yes, ma'am. I myself performed the laryngoscopy, ma'am. In cis atracurium, the conditions were better as compared to the atracurium. And
it's okay. We'll move ahead.
Okay. Priyanka, in your exclusion criteria, you haven't excluded the patient with the neurological disorders or with any history of epilepsy, isn't it? That is the one shortcoming. Then you have kept 2 primary objectives for a very small sample size of 80. That is not a good scientific idea, because whenever you choose a sample size of smaller thing, you can't have that many objectives. Okay. And the novelty part should have been, could have been expressed more in other parameters of comparison also. I think that you can do when you send this for publication to any place. That's all I want to say.
Thanks.
Thank you, Dr. Priyanka.
Thank you. Thank you, Dr. Priyanka. Now we move on to our next candidate, Dr. Sakshi Goel from Gandhi Medical College. Sakshi? Hello, Sakshi?
She has already put the screen.
Sakshi, you're not audible. Sakshi?
You're not audible, Dr. Sakshi. Are you there, Dr. Sakshi?
Hello, Ji ma'am.
Yes.
Am I audible
Dr.
now?
Sakshi? Yes, yes.
Ji ma'am. Good afternoon, respected judges. Myself, Dr. Sakshi Goel, RMO Anesthesia, Gandhi Medical College, Bhopal. My moderators are Dr. Shikha Mehrotra ma'am, Professor and HOD, Department of Anesthesiology, Gandhi Medical College, Bhopal, and Dr. Vikas Gupta sir, Associate Professor, Department of Anesthesia, Gandhi Medical College, Bhopal. My topic of study is a study to see the effect of pre-extubation IV fentanyl on hemodynamic and airway responses during emergence from general anesthesia. Introduction. Tracheal extubation is associated with wide fluctuations in the hemodynamics that can lead to tachycardia, hypertension, and arrhythmias. It is also associated with reflex increase in the airway reactivity, leading to stress response and airway irritation. Fentanyl is a short-acting opioid which has been used to attenuate the stress response during both intubation and extubation. The study was carried out to compare two different doses of IV fentanyl, that is 0.5 microgram per kg and 1 microgram per kg with normal saline to see the effect on hemodynamic response and quality of extubation. My primary aim was to evaluate the effect of pre-extubation administration of two different doses of fentanyl in controlling hemodynamic response and quality of extubation. And secondary aim was to assess the adverse effect of sedation or respiratory depression with its use. My study design was observational hospital-based study. Sample size was 60 of age group 18 to 65 of either sex belonging to ASA grade 1 and 2, scheduled for elective surgery and requiring general anesthesia with direct laryngoscopy and endotracheal intubation. Inclusion criteria was patients were taking informed consent, patients of ASA grade 1 and 2, and age group 18 to 65 of either sex, and all the patients were scheduled for elective surgery requiring general anesthesia. Exclusion criteria was patient refusal or not giving consent, and ASA grade 3, 4, 5, and E. Procedure. After obtaining the informed consent from all the patients were pre-medicated with IV ondansetron, glycopyrrolate, midazolam, fentanyl, along with pre-oxygenation with 100% oxygen for 3 minutes. Induction was done with IV propofol, scoline, and orotracheal intubation was done. Maintenance was done with 50% oxygen, 50% nitrous, and 0.2 to 2% isofluran. Along with IV atracurium, all the patients received 1 gram paracetamol for analgesia. Now, at the time of the start of the skin suturing, patients will receive either fentanyl at the dose 0.5 microgram per kg or fentanyl at the rate 1 microgram per kg or equal volume of NS, and their vitals were noted out, which will serve as a baseline parameters. Now, at the end of the surgery, oral suctioning was done before and immediately after extubation. Extubation was done when patient could follow verbal commands, generating an exhale tidal volume of at least 5 ml per kg and maintaining SpO2 to 92% in hemodynamically stable conditions. Vital parameters were noted down at the completion of surgery, 1 minute after extubation and 5 minutes after extubation. The airway reflex score during suctioning and extubation quality score was measured on 5-point scale immediately after extubation. Ramsay sedation score were also noted at the awakening after extubation. Statistical analysis plan. The sample size was calculated using software G-Power using effect size of 0.66, 80% power of the study, and alpha error of 0.05. Continuous data were expressed as mean and standard deviation, and categorical data were expressed as number of occurrence or frequency in percentage. The comparison analysis was performed using t-test for continuous data and chi-square for non-continuous variable. The level of statistical significance was p-value less than 0.05 and p-value less than 0.001 was considered to be statistically significant. Results. My baseline parameters in all the groups were comparable, they were almost similar. Comparison of hemodynamic data. hemodynamically, patients who received fentanyl were comparatively hemodynamically stable at the completion of surgery 1 minute after extubation and 5 minutes after extubation. Comparison of Ramsey sedation score, 75% of the patients who received normal saline were agitated or restless at the time of after extubation, while 65% of the patients were cooperative and oriented who received 0.5 microgram per kg of fentanyl, while 50% of the patients who received 1 microgram per kg of fentanyl were still drowsy. Then a comparison of extubation quality score. 75% of the patients who received normal saline were having moderate coughing, and 50% of the patients who received fentanyl at the rate of 0.5 microgram per kg having smooth extubation with minimal coughing. While patients who received 1 microgram per kg of fentanyl had no coughing. 30% of the patients who received 1 microgram of fentanyl had smooth extubation. Then comparison of airway reflex score, 65% of the patients who received normal saline were breathing well, and but they had coughing on attempting to suction, while 70% of the patients who received fentanyl at the rate of 0.5 microgram per kg were breathing well and only grimace response to the suctioning, while 65% of the patients who received fentanyl at the rate of 1 microgram per kg had were breathing well and there were no response to suctioning. Discussion. In the study, we evaluated the role of IV fentanyl to blunt the hemodynamic response to extubation and improve the quality of extubation. In our study, both the fentanyl group showed lower systolic blood pressure, diastolic blood pressure, and heart rate at 1 minute and 5 minutes after extubation compared to normal saline group. More control of heart rate, systolic blood pressure, diastolic blood pressure were with fentanyl, 1 microgram per kg, but with slight prolongation and recovery time compared to other groups. The outcomes of the sedation score suggest that the patients in the fentanyl group were comparatively cooperative and oriented during extubation, while patients with normal saline were awakened early and agitated while extubation. There were no significant complications related to fentanyl use. Conclusion, in the study, we found that the low dose of 0.5 microgram per kg of fentanyl at the end of the surgery is an effective way to achieve the smooth extubation, but IV fentanyl at the 1 microgram per kg provides better hemodynamic control with slight prolongation in the recovery time. These are my references. Thank you, ma'am. Thank you, judges.
Thank you, Dr. Sakshi. Over to you, judges.
Thank you, Dr. Sakshi. You had, so what would you say, better better hemodynamic control or a prolongation in recovery time? Which one would you say it is better one? 0.5 microgram or 1 mic?
Ma'am, 1 microgram group was better with hemodynamical stability, but there was a slight prolongation in recovery time compared with 0.5 group and normal saline group.
So recovery time you took in which way? Sedation, coughing and everything? Or
recovery time, ma'am, like fully conscious oriented and like patient could be shifted out of the OT.
Madam wants to know the take-home message from your study.
Right. So take-home message from the study is like fentanyl, a low-dose fentanyl could be used at 0.5 microgram per kg to achieve smooth extubation. But if we want a smooth extubation, but if there is a such patient who are more risk to hemodynamic instability, in patients we want more hemodynamic stability, we can give fentanyl at the dose 1 microgram per kg.
To identify the patient, you have to put them in 2 groups. So in your study also, you put one in the hemodynamically unstable patients, or vulnerable patients, and the other side you put the hemodynamic stable patients, isn't that?
Right.
Okay. One more important thing for everybody here present, all the participants, whether it's an observational study or whatever it is, the blinding part has not been touched by anybody. And also, I'm concerned about the allocation of the groups. Nobody has touched till now. I'm listening, I'm looking, because now everybody must have prepared the slide. You must have got your number deducted for that. Because when you will be, whosoever will be going for the TN job further, right from the beginning, the allocation of the group that should be touched in every slide. Then there should be blinding, how you the blinding pattern was followed. That must be there with everything. Okay, that's all from my side.
Right. That is because this will give bias to the study basically.
Yes, ma'am.
Right. Okay. Thank you so much, Sakshi.
Ji, ma'am. Thank you, ma'am.
Thank you, Dr. Sakshi. Now we can move on to next candidate, Dr. Shubhangi Tiwari from People's Medical College. Dr. Shubhangi.
Yes, ma'am.
Shubhangi, please share your screen.
Are you there, Dr. Shubhangi?
Yes, ma'am. Yes, ma'am. Am I audible, ma'am?
Yes.
Yes.
How?
Share your screen, Shubhangi.
Yes, ma'am. Ma'am.
Full screen.
Full screen. Make it full screen.
Go to slideshow, Shubhangi.
Yes.
Go to slideshow and click from starting.
On the lower side, there will be a cup-like structure. You just press it.
Shubhangi, are you there?
Yes, ma'am.
Please make it a slideshow. You're not able to see your whole slide. Dr. Shubhangi?
Yes, ma'am. Now.
Okay, once again you do it, no?
Okay. Now.
Yes, in the upper row. No,
Okay,
not
ma'am.
that. Yes,
No?
yes, okay.
Door side, door side.
Click on slideshow and then start from beginning.
This is
There's
the
an
first slide,
option.
I think.
Oh, you were right.
Slideshow.
It's here somewhere down. You can see a cup-like structure there.
Once again, you try. Now we are unable to see your screen.
Ma'am, I am unable to share.
Why? What's the problem?
I don't know, ma'am.
You have opened your PowerPoint presentation now?
Yes, I was.
Please open it. Aram se, don't
Take
get
it
tensed.
easy.
Don't get tensed.
I could not find here, ma'am.
What couldn't you find?
A presentation.
Why?
Where it is lost. It was there, no, earlier.
It was
We
there,
could see
ma'am.
that.
No.
We could see that.
Shubhangi, or we can do this.
Let her relax for the next candidate to come. She will come after that.
Okay, Shubhangi, you'll come after this, no?
Okay.
Next is Dr. Shambaran. Dr. Shambaran.
Yes, ma'am.
Okay.
Are you there?
Share your presentation.
Yes, ma'am. Yes.
Shubhangi, please unmute mute
yes,
your video now. No?
Ask her to take help from someone if she is unable to wait.
Shubhangi, get help some.
Can you hear me?
Yeah.
Yes.
Yes. Good evening, respected sir and ma'am.
We cannot see your slide. Shambaran.
Yes, ma'am.
ये सब जब कॉल नहीं तो ये चादर उठा के उसमें चादर मशीन में डालना।
Yes. Yes. Yes, ma'am. Can you see my presentation?
We can't see. We can see your whole pen drive.
You click your topic and share with us.
Dr. Shambaram, are you listening?
Yes, ma'am. Yes, ma'am. Okay.
Please open your presentation. All the candidates, please open your presentation in the background. You couldn't find your presentation?
I think final synopsis PPT. The first one is your topic.
That is synopsis.
Hello, Shambaran, please reply.
I think here it is paper final.
अच्छा.
Sham paper final.
Sham paper final.
हाँ यही होगा. तुमको क्या दिख रहा है श्यामबरन? What you are seeing on your screen?
तुम क्या सोच रहे हो डॉक्टर श्यामबरन?
Hello, Shambaran, please respond.
श्यामबरन के बाद कौन है? सुरुचि.
Suruchi as ma'am.
Suruchi हो गया. We are done, already done.
Okay, so
अच्छा हाँ सुरुचि हो गया. स्वीटी साहू.
Sweetie Sahu. Sweetie, are you there?
श्यामबरन yes, पहले खोल के देख लेगा, फिर जब तक स्वीटी को बुला लो. ठीक है?
Dr. Sweetie?
Yes, ma'am, I'm there.
Okay. If you can share your presentation, please, you may start now, and we'll continue with the other two after you.
Later one, yeah.
Yes, ma'am. Ma'am, I am audible as well as visible, ma'am?
Yes, yes.
Yes, slides. Go to slide 1.
Go to slide 1, but.
Slideshow, ma'am?
Make it slideshow and go to slide 1.
Yes, ma'am.
Because this is 3rd or 4th slide. Yes. Yeah. Make it to slideshow now.
Yes, ma'am. Good evening, respected judges.
Okay.
Myself, Dr. Sweetie Sahu from Sri Aurobindo Medical College. My moderator is Dr. Deepthi ma'am. My topic is correlation between HbA1c and PONV in morbidly obese patient undergoing laparoscopic pediatric surgery. The prevalence of obesity and central obesity ranges from 18%. Just a second now.
Sweetie, you are audible. Your time is running.
Yes, ma'am.
Please.
Speaking.
Ma'am, I just want to hide this side. How can I do that, ma'am?
Need not to do that. Go ahead.
Go ahead. Your time
the prevalence of obesity and central obesity in India ranges from 18% and up to 36.3% respectively. The available evidence suggests that the intervention is the best hope for these obese patients, which helps in ranging weight, morbidity, and mortality. Pediatric surgery is the term used for any type of surgery that is performed with the aim of weight loss. These surgeries are performed in those individuals who does not respond to any surgical methods for their weight loss. When these surgeries are performed in laparoscopic instrument, it is known as laparoscopic pediatric surgery. Nausea and vomiting is the most distracting complications encountered, requires prompt management following pediatric surgery. Female sex, motion sickness, smoking, age more than 50 years, delayed gastric emptying are some of the factors which influence post-operative nausea, vomiting. We conducted the present study with the hypothesis that in diabetes patient, Mostly diabetes pain gastroparesis, the incidence of PNV is high. So in our study, HbA1c chosen because this is the only parameters in diabetes patients which is reliable. Most of the obese patients have some or other comorbidities also that can contribute, but HbA1c does not influence that. Till now, no study has been conducted which has been seen the relationship between HbA1c and PONV, and so that's why we have studied to find out the relationship between HbA1c and post-operative nausea, vomiting in patients undergoing laparoscopic pediatric surgery. My aim is to find out the relationship between HbA1c and PONV in morbidly obese patient undergoing laparoscopic pediatric surgery. Inclusion criteria are ASA grade 1 to 3 patients planned for elective laparoscopic pediatric surgery under general anesthesia, age group between 18 to 70 years, BMI more than 75 kg per meter squares, male and female sex. Exclusion criteria are ASA grade 4 patients, patient coming for emergency, that is converted to open surgeries, patient less than 18 years old and more than 70 years old, known hypertensive and diabetic patient not on regular medications, patients diagnosed on GIRD, patient on anti-emetic and any other known to cause nausea and vomiting, pregnant and lactating mothers, history of previous PONVs, and no informed consent. Methodology, the present study was conducted in the Department of Anesthesiology, Critical Care, Sri Aurobindo Medical College and Postgraduate Institute during a period of 2019 to 2020. We had included 200 patients undergoing laparoscopic pediatric surgeries whose BMI more than 40 kg per meter square with or without comorbidities belonging to ASA grade 1 to 3. Then written informed consent was taken from the patients by approving from ethical committee, but after the approval of institutional ethical committee, detailed pre-anesthetic evaluation during history of obstructive sleep apnea, previous cardiac respiratory disorder was taken, special investigation according to the protocols of pediatric surgery as in our institution, like pulmonary function test, serum lipid profile, HbA1c values and sleep apnea studies done, pre-optimize the patient. Overnight CPAP was given to the patient who have history of OSA, nil per oral for 6 hours, aspiration prophylaxis 30 minutes prior induction, and a peripheral IV line secured, preloading with IV ringalactate at the rate of 8 to 10 ml per kg per hour, and radial artery cannulation done. Pre-medication with IV glycopyrrolate 4 microgram per kg and IV fentanyl 1 microgram per kg. Induction with administration of IV propofol in a dose of 2 milligram per kg of ideal body weight. With 4 milligram and tracheal intubation facilitated with cisatracurium 2 milligram per kg, maintained with oxygen, air, desflurane at 4 to 7% of dial concentration, and maintained with atracurium 0.03 milligram per kg of total ID or total body weight. Mechanical ventilation with mid-ray Veto 660 anesthesia workstation, and target ventilatory parameters were end tidal CO2 was 30 to 40 milligram per kg and FiO2 of 50% was maintained, and ventilatory settings were not altered during this period. Assessment, pain was assessed during VAS score at 6 and 24 hours after receiving the recovery room, and post-operating nausea, vomiting after surgery was recorded at 1 hour after surgery, and then at 6 and 24 hours, and need for rescue antiemetic in first 24 hours were recorded. A note of comorbidity was kept. Data collection, customized proforma was designed for the specific requirement of all the studies, and all the pertaining data was to the patient was recording this proforma. Other outcome measures, comorbidities, HbA1c levels, incidence of post-operative nausea, vomiting, antiemetic pain scores form are in our outcome measures. Data analysis was initially captured in the customized proforma, and then in Microsoft Excel analysis and online statistical software such as GraphPad, AP information were recorded, calculating the p-values, and comparison of mean between the two groups was done using unpaired, and within the group was done during using paired t-test. Association between two non-parametric values was done using Pearson coefficient square test, and comparison of proportion between two groups was done using Z sample proportion. A p-value of less than 0.05 was taken as a statistically significant, the final presented in the form of tables and graphs. Observation, age distribution in study population was majority of the patients was 40 to 60 years. Number was 96 and percentage was 48 out of 200 patients. A mean age of the patients was 43.24, plus minus 11.79 years. Sex distribution in our study was 55% were female and 45% were male. And ASA distribution in study populations, majority were ASA grade 2 patients, 45%, and grade 3 was 42%. HbA1c and PONV distribution study population, HbA1c was normal in 47% of patients, and PONV was seen in 57 patients and 28.5% of patients. A relationship was found between HbA1c and PONV in study population with using unpaired t-test applied, and p-value was 0.516. That is not significant. The mean HbA1c was comparable in relation to PONV, and the p-value was 0.516. Discussion at present, no study has been found which has been shown any relationship between PONV and HbA1c. This is our initial attempt to study this relationship, but we also found no such relationship between PONV and HbA1c. Conclusion, laparoscopic bariatric surgery are the treatment of choice in morbidly obese patient. PONV incidence was seen in 1/3 of these patients, and no relationship has such been found between HbA1c and PONV, and could be established in our study.
Thank you, Dr. Sweety. Over to you, judges.
So I have two questions. One is, what is the target HbA1c in your study group? And other is, what are the predictors for PON?
My target was mostly a normal HbA1c. I was 6 as I have taken as the target level, ma'am.
Okay. And what are the predictors for PONV?
Predictors, ma'am, mostly I have seen PONV in female predominance was higher, ma'am.
Other, what intraoperatively you have given, any opioid association, any relation to the age?
Ma'am, age
because
mostly
the surgery is same, no, in every group, type of surgery is same. But these are the predictors, like you have to see whether the opioids are given or not.
Ma'am, in my
Female,
surgery, opioid-free surgery, ma'am, the surgery was opioid-free, ma'am. There's no opioid was given during the surgery, intra.
So how the patient was maintained?
Ma'am, induction was just given with propofol as well as relaxant, ma'am, only this much. And if required, then
for
it is
analgesia,
hardly
what you have taken?
maintained with inhalation, ma'am. No such opioid was given, ma'am. In between, because maximum 45.
Any other analgesic?
Ma'am, analgesic.
You have
given
you have
paracetamol.
done the opioid sparing technique, but you have
Yes,
used some other analgesic in such patients.
Ma'am, paracetamol I have given.
Because even if you are not using analgesic, it will cause PONV. Inadequate analgesia, females. So I'm asking, what are the predictors of PONV?
Paracetamol.
Okay, come on.
Paracetamol introp, if patient is showing some sort of tachycardia introp, then paracetamol I have given, ma'am.
When you are not using any analgesic.
Hello. Hello, ma'am, I'm audible. Hello.
Yes, you are audible. Am I audible to you?
Ji, ma'am.
When you are not using any opioid or you are giving paracetamol only, what is the time of giving paracetamol for these patients? When do you give this paracetamol to the patient?
Ma'am, after means after 30 minutes of 30 to 20, in between 30 to 20 minutes of surgery, ma'am.
Okay. I would like to know what made you to take this study as what is the relation of HbA1c and PONV as such?
Ma'am, because most of the obese patients have one or more comorbidities, we have seen, ma'am. But HbA1c is the only parameter which is reliable in diabetes as well as non-diabetic, which can't be influenced or which can't be changed, ma'am. That's why I have chosen this HbA1c as a parameter. And
but what is the relation between HbA1c and PONV?
Ma'am,
What
Okay,
is the
Dr.
result of your study? That means, madam, want to ask whether you have find a positive and significant relationship
Ma'am, no,
between
sir.
the.
I have not found any sort of relationship between in studies. As we
So,
have seen that in diabetes patient, most of the diabetes patient have more vomiting. So I just try to find out if there's a diabetes patient who's HbA1c by ruling out this
there can be Madam
association.
Shikha was right asking about the risk factors for the
Yeah.
vomiting in these type of patient. Now look at your patient. All the patients you have not mentioned since when they had this diabetes, the chronological age of diabetes. That's very important because that leads to autonomic neuropathy, and that's a big factor for the post-op nausea vomiting.
Nausea vomiting as such.
That is very important. So HbA1c not controlled for a
And
long
uncontrolled
duration.
diabetes, they are more prone for PONV as
Yeah.
such.
That is one thing. The second point I want to highlight again for everybody, with every participant, I want to at least always highlight one point. All the studies, which are the original studies, the comparative study, they should be registered with the Clinical Trial Registry of India. Whenever you conceive a plan, you always, after obtaining this one ethical committee clearance, always register these studies on the Clinical Trial Registry of India, so that whenever you want to publish, now in the JOCP or IJ, we are not accepting the studies which are not registered on the CTRI. So it's my request that everybody who's listening, they should always register their studies on the CTRI. Thank you, Dr.
Thank you, Dr. Sweetie.
Thank you, ma'am. Thank you, sir.
Thank you, Dr. Sweetie. Now we'll move on to our next candidate, Dr. Karishma Dhalwani from Sri Aurobindo Medical College.
I'm not able to share.
Not able to share?
Sorry, ma'am. Good afternoon, ma'am.
See on the Zoom, there is one option.
Sharing option is
your
there.
Slides.
The green color option.
Share screen is there. In the center only. In the center, there is a share screen. Can you see that?
Ji, ma'am. Ma'am, there is no option coming. It's just coming share content.
So share screen, share your screen there. Have you opened your this thing? Presentation?
Karishma, open your presentation in the background. Yeah. And then share screen. It will automatically come.
Open your presentation.
Actually, ma'am, the option is not coming.
Open your presentation first. Open your presentation.
Ji, ma'am.
Have you opened?
Ji, ma'am. I'm trying to.
Karishma, minimize your screen, open your presentation, then again maximize it and then share it.
And we go to the other two then, if they are ready with?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am, I'll do it. You can go to other.
You open it and then we'll start with yours. Are the Dr. Shubhangi and Dr.
Yes. Yes, ma'am.
Are you ready?
Yes, ma'am.
Dr. Shubhangi, yes.
Yes, ma'am.
Continue.
Okay, we'll go with you. Yes.
Can
Now go to
you?
the.
Yes, ma'am.
Now make it PowerPoint.
Make it PowerPoint. Okay.
Slideshow.
There is a slideshow. See again, there's slideshow in the upper.
You are closing it down. And now slideshow is there.
Yes, ma'am.
Can you see the option next to animation slideshow?
Or you can go ahead with this. Only.
Okay, go ahead with this only.
Go ahead with this. Yeah.
Okay, ma'am.
Okay.
Good evening, ma'am. Good evening. Am I audible, ma'am?
Yes, you are.
20% है मम्मा. अब आपसे स्ट्रेस मत दो. इधर ही बैठ के करते हो, ट्राई कर लूंगी, हो जाएगा.
Okay.
बस एक बार देख लो.
Dr. Karishma, mute yourself. Dr. Karishma, mute yourself. We are going with this. Shubhangi. Yes.
Good evening, ma'am.
Dr. Shubhangi, yes.
Good evening.
Don't get nervous, Dr. Shubhangi.
Yes, ma'am.
Don't get nervous. Okay. Start, please.
Good evening, respected ma'am and sir. My study is a comparative study of intravenous ondansetron and granisetron for the prophylaxis of post-operative nausea and vomiting following surgical procedure under general anesthesia.
Despite continuous advances in anesthetic and surgical technique, both the incidence and severity of post-operative nausea and vomiting have remained relatively unchanged. Along with pain, PONV is the most important complaint reported following surgery under general anesthesia. PONV occurs in 30 to 40% of all patients who undergo surgical procedure under general anesthesia using inhalational agents. But among patients with identified risk factor for developing PONV, it can occur up to 70 to 80%. The consequences of PONV include delayed discharge from post-anesthetic care unit, unanticipated hospital admission, increased incidence of dehydration, electrolyte abnormalities, wound dehiscence, bleeding esophageal rupture, pulmonary aspiration, and significant postoperative discomfort. This study was undertaken to compare two commonly used antiemetic drugs, intravenous ondansetron 4 mg and granisetron 1 mg, to determine which among them is more efficacious in preventing PONV, and also compare their adverse effects when used in patients undergoing elective surgery under general anesthesia. Half-life of ondansetron is 3 to 5 hours and duration of action is 4 to 12 hours. Granisetron is a recently introduced 5-HT receptor antagonist which has good potency and longer duration of action against MSCs. Half-life of granisetron is 3 to 9 hours. The onset of action following a single intravenous dose of granisetron is within 30 minutes and with a duration of more than 24 hours. My aim is to compare the antiemetic effects of both intravenous ondansetron and granisetron for the prophylaxis of postoperative nausea and vomiting in patients following the surgical procedure under general anesthesia, and to compare the side effects of both the drugs. My study design is sample size is 60 patients. Place of study is People's College of Medical Science and Research Center, Bhopal. Duration of study from 1st Jan 2021 to 1st September 2021. My inclusion criteria is age 18 years to 50 years, ASA grade 1 and 2, weighing more than 40 kg. Those scheduled under general anesthesia using inhalational agents will be included in the study. Exclusion criteria is patient not giving consent, ASA grade 3 and 4, age less than 18 years and more than 50 years, had taken antiemetic drugs within 24 hours before surgery, emergency surgeries like food and full stomach, history of motion sickness or previous PONV, and total intravenous anesthesia. Methodology in randomized prospective study, patients were allocated in two groups of 30 each, one control group who received ondansetron and one study group who received granisetron intravenously at the end of surgery. Patients of both gender were randomly allocated to study and control group. Patients with odd IPD number in control group and those with even IPD numbers in study group. Perioperative anesthetic care was standardized in all patients. Patients were then observed 24 hours after administration of the study drugs. Postoperatively, all patients were assessed at the PSU and department wards for episodes of nausea, vomiting, retching, and the need for rescue antiemetic at intervals of 0 to 1 hours, 1 to 3, 3 to 6, 6 to 12, and 12 to 24 hours. Episodes of PONV were identified by spontaneous complaints from patients and by direct questioning. The patients were observed for 24 hours postoperatively for the incidence of complete response and side effects. Complete response was defined as the absence of nausea, retching, or vomiting, and no need for rescue antiemetic during the 24 hours observation period. Rescue antiemetic in the form of an intravenous injection of metoclopramide 10 mg was given in the event of one or more episode of vomiting, depending on the observer discretion. This postoperative assessment were recorded on a standardized form. My classification of surgical procedure between two groups, like control groups and study groups, were comparable, and demographical data of the study population. Group O ondansetron, group G is for granisetron. Age, weight, sex, duration of surgery, and duration of anesthesia were comparable. And assessment of postoperative nausea and retching in control group and study group were comparable, and p-value is insignificant. Incidence of nausea and vomiting in granisetron group.
assessment of post-operative vomiting and need for rescue medication in control group and in study group. Both are comparable. Incidence of adverse effects. In ondansetron, headache and dizziness. Headache was found in 3 patients and dizziness in 1 patient. In granisetron, headache in 1 patient and in dizziness and 1 patient. Incidence of complete response found in the ondansetron group is 56% and in granisetron group is 89%. Result is a complete response was achieved in 57% of patients given ondansetron and 89% of patients given granisetron with the p-value less than 0.021%. There was no statistical difference noted between control group and study group. The p-value observed in control group less than 0.05 and in study group less than 0.021. Respectively. Both study drugs were well tolerated with slight difference in the adverse event were observed between the 2 groups. The overall incidence of complete response in the granisetron group is 89%, was significantly higher than the ondansetron group. It was 57%. Discussion part is 5-HT3 5-hydroxytryptamine 3 receptor stimulation is the primary event in the initiation of vomiting reflex. Patient posted for elective surgery under general anesthesia was chosen because of high incidence of PONV associated with it. In our study, the factors that would have contributed to PONV is complex and is dependent on a variety of factors, including age, gender, obesity, history of previous PONV, surgical procedure, anesthetic technique, use of antibiotics, and post-operative pain. We have conducted studies on 60 patients of ASA 1 and 2 with demographic data in terms of age, weight, which were similar in the 2 groups. Study done by Pierman in 1994 shows that post-operative nausea and vomiting is more common in young age group and obese patients. In our study, there was no statistical difference noted between control group and study group. Kiran Sawant in the 2016 studied that ondansetron and
sorry to interrupt you. Your time is up, so you can please wrap it fast. No?
Oh, no.
Yeah, go to conclusion or result.
Conclusion is this study concludes that the prophylactic intravenous administration of granisetron is more effective drug than ondansetron for controlling post-operative nausea and vomiting with less incidence of side effects. Intravenous dose of 1 milligram granisetron was found to be safe, well tolerated, and more effective by achieving the incidence of complete response compared to 4 milligram intravenous ondansetron when used for antiemetic prophylaxis in surgical procedure patients receiving general anesthesia. Granisetron is more potent and longer acting as compared to ondansetron. Benefits of granisetron include high receptor specificity and high potency, which make it valuable alternative to ondansetron. The choice between the 2 regimes can be dictated by their respective purchase price. And these are my references. Thank you. Thank you, ma'am.
In how many cases you have given rescue antiemetics? And why you have chosen metoclopropamide of all the antiemetics available?
Ma'am, patient who had vomiting 1 episode, either 1 episode, one episode or more than 1 episode of vomiting, we used metoclopramide 10 milligram as a rescue antiemetic, ma'am. And in ondansetron group, we used in 5 patients, and in the granisetron groups, we used in 1 patient as a rescue antiemetic.
You had fixed the dose for all the patients, right?
Yes, ma'am.
Either granisetron or
ondansetron. Yes,
you had fixed. Did you have a fixed BMI of the patients?
No, ma'am.
The anesthetic technique was the same in all the patients?
Yes, ma'am. Anesthetics are all elective cases, ma'am, under general anesthesia and ASA1
No,
and
the
2.
drugs used during
Yes, ma'am.
anesthesia
Yes,
are
ma'am.
the same or they are different?
No, ma'am. All drugs, all techniques are same. We use all patients in fentanyl and nitrous oxide inhalation and isoflurane as a volatile agent.
And the induction agent was the same propofol or?
Yes, ma'am. Propofol, ma'am.
weight of the patient would have made the difference for the patients.
Yes, ma'am.
Right?
Yes, ma'am.
Dr. Shubhangi, what is new in your study which has not been studied earlier?
Ma'am, sir, study earlier was done in many other surgeries like oral surgeries, ENT surgeries, tympanoplasty and all studies. But still, granisetron is not using. We are still using ondansetron drugs. So we like to.
There are many
And,
studies. Actually. There are many studies on granisetron and compared to ondansetron. Why you chose ondansetron? Why not pelonosetron? Why not ramosetron? All those things are also there. Anyway, forget about that that question. I just want to say, ask which type of drug will you want to use in the critical care setup among all these drugs for a PONV in critical care setup?
Sir, granisetron.
It's easily available with you.
Yes, sir, easily available.
And just last question: what is the side effects of ondansetron you can observe in the critical ill patients? I will also use granisetron.
Sir,
What side effect?
in ondansetron
No,
group
in
or
ondansetron group, what side effect do you expect to see in critical ill patient, especially the cardiac patients?
arrhythmia, QT prolongation,
Which one? Which one? Typical arrhythmia.
torsade D point is.
Have you seen in any patient?
No, sir. I'm
Till
not.
date in your life?
No, sir. No, sir. It is just in literature. It was
Literature
just.
only.
Yes.
So you haven't seen any arrhythmias with the use of
No, sir.
ondansetron?
No, sir. I haven't seen.
It's okay.
Have you ever thought about the multimodal approach of anti-emesis?
Yes,
in critical
ma'am.
care patients?
Yes,
to
ma'am.
avoid such adverse effects?
Yes, ma'am.
What do you understand?
Sorry, ma'am. Not audible.
What do you understand by multimodal approach?
Ma'am, we can use dexamethasone with ondansetron or with granisetron and other like ma'am.
Okay.
Domperidone or other dopamine antagonist drugs also we can use.
Okay. Thank you, Dr. Shubhangi.
Thank you. Thank you.
Thank you, Dr.
Who is ready
Shubhangi. We'll move on to Dr. Shambaran. Dr.
Yes,
Shambaran, are you ready now?
Yes, I am ready.
Okay, please share your presentation.
Yeah.
Zoom it and make it bigger.
Can you hear me?
Yes, you are audible.
Good evening, respected sir and ma'am. Thesis topic of my thesis is a comparative clinical study to assess pre-insufflation versus post-desufflation changes in arterial blood gas and pH in patients undergoing laparoscopic cholecystectomy under general anesthesia, under the guidance of Dr. Preeti Goyal ma'am and Dr. Seema Sindhi ma'am. Now come to the introduction. Laparoscopic cholecystectomy is minimally invasive procedure for surgical removal of gallbladder. It involves insufflation of gas into the peritoneal cavity to create the pneumoperitoneum. Most commonly used gas for pneumoperitoneum is carbon dioxide because it is non-inflammable, colorless, highly soluble in blood, and its elimination can be augmented by increasing the minute volume. This pneumoperitoneum leads to multiple change in mechanics of respiration and heart function. Arterial blood gas analysis can be used for the patient oxygenation, ventilation, gas exchange, and acid-base homeostasis, as well as to provide immediate information about electrolytes. The consequences of hypercapnia, rapid breathing, tachycardia, headache, dizziness, flushed skin and confusion, in severe case disorientation, convulsion, unconsciousness, and death may occur. Aims and objectives are to compare the arterial blood gas concentration and pH before CO2 insufflation, 30 minutes after desufflation in group 1 and 60 minutes after desufflation in group 2. To compare the hemodynamic changes before and after CO2 insufflation, 30 minutes after desufflation and 60 minutes after desufflation. To compare the end-tidal CO2 changes before and after CO2 insufflation. Material and methods. After ethical committee approval, this prospective comparative clinical study was carried out on 80 patients after written informed consent. The formula used for calculation of sample size is shown in this slide. Inclusion criteria are age between 25 to 45 year, weight between 45 to 70 kg, height between 59 to 67 inch, ASA grade 1 and 2. Exclusion criteria are patient not giving consent to participate in the study, patient with respiratory, cardiovascular, renal disease, obesity, and pregnancy. Randomization was done on the basis of systemic sampling method. In group 1, arterial blood sample was collected after 30 minutes of desufflation, and in group 2, arterial blood sample was collected after 60 minutes of desufflation. After complete routine pre-anesthetic assessment, patient was taken in operation theater. All the patients were uniformly pre-medicated with injection glycopyrrolate. Injection pentazocine intravenously was given as an analgesic. After pre-oxygenation, general anesthesia was induced using IV injection thiopental sodium according to 5 mg per kg body weight. Endotracheal intubation was facilitated with IV injection succinyl codeine 1.5 mg per kg body weight. Anesthesia was maintained with 66% N2 and 33% oxygen with isoflurane, and relaxation maintained with intermittent injection atracurium 0.1 mg per kg, and positive pressure ventilation maintained with tidal volume 6 to 8 ml per kg according to predicted body weight, and respiratory rate 15 per minute using Drager Fabius GS premium ventilator. Pre-operative arterial blood sample was collected just before insufflation from radial artery in pre-heparinide syringe. Residual effect of muscle relaxant was reversed by injection neostigmine and injection glycopyrrolate 0.5 mg IV, and patient was extubated after return of reflex and proper suctioning. Intraoperative monitoring and recording of hemodynamic parameter SpO2 and EtCO2 was done after induction, after creation of pneumoperitoneum, at interval of 5 minutes up to 30 minutes, and then at 15 minutes till the end of surgery, and continue for 30 minutes post-operatively. In half of the patient, arterial blood sample were collected after 30 minutes and remaining half after 60 minutes of desufflation. Statistical analysis. The statistical analysis of this study was carried out by pair t-test. P-value more than 0.05 was statistically insignificant. P-value less than 0.05 was statistically significant. P-value less than 0.01 was statistically highly significant. The statistical analysis was done using SPSS software version 20. Now come to the results. This is the table showing demographic parameters in both groups. There was no statistically significant difference in terms of demographic parameter in both groups. This is the table showing comparison of arterial blood gas changes in two groups at a different time. On intra-group comparison, there were statistically highly significant difference in PaCO2 bicarbonate and pH after desufflation as compared to pre-insufflation in both groups. This is the table showing inter-group comparison of arterial blood gas in two groups. On inter-group comparison, there were no statistically significant difference in PaCO2 bicarbonate and pH in between two groups. This is the table showing inter and intra-group comparison of pulse rate in two groups. On intra-group comparison, there was statistically highly significant increase in pulse rate after insufflation and post-desufflation as compared to pre-insufflation in both groups. On intergroup comparison, there was a statistically significant difference in pulse rate after desufflation. This is the table showing inter and intra-group comparison of blood pressure in two study groups. On intra-group comparison, there were statistically highly significant increase in systolic, diastolic, and mean arterial pressure after insufflation and post-desufflation as compared to pre-insufflation in both groups. On intergroup comparison, there were no statistically significant difference in systolic, diastolic, and mean arterial pressure after insufflation and post-desufflation between two groups. This is the table showing inter and intra-group comparison of end-tidal CO2 in two groups. On intra-group comparison, there was statistically highly significant increase in EtCO2 after insufflation as compared to pre-insufflation in both groups. On inter-group comparison, there was no statistically significant difference in EtCO2 after insufflation between two groups. Discussion. Pneumoperitoneum created by CO2 insufflation and laparoscopic surgery causes hypercarbia and respiratory acidosis. The absorbed CO2 causes hypercapnia, which stimulates the sympathetic nervous system that leads to increase in hemodynamic parameters. Arterial blood gas analysis can be used for patient oxygenation, ventilation, gas exchange, and acid-base homeostasis. The various studies have been done on changes in arterial blood gas concentration and hemodynamic due to creation of pneumoperitoneum, but the time to achieve normal CO2 concentration post-desufflation is still controversial. In this study, we compare two intervals, 30 minutes and 60 minutes post-desufflation. Know the changes ABG parameters. We found that elevation in PaCO2 and reduction in pH more in group 1 than group 2, which were statistically non-significant. We findings of arterial blood gas changes I have already discussed in table number 2 and 3, and findings of hemodynamic parameters and EtCO2 already discussed in table number 4, 5, and 6. Our findings correlate with the study done by Bhadoria et al. Findings of our study were similar in terms of EtCO2, PaCO2, pH, and hemodynamic parameters with the study done by Sobana G et al., but they got increase in bicarbonate and there was no significant change in heart rate, which is different from our study. Conclusion: pneumoperitoneum with CO2 insufflation caused a highly significant increase in PaCO2, significant reduction in pH and bicarbonate in the post-desufflation period as compared to pre-insufflation. There were highly significant increase in hemodynamic parameters after insufflation and post-desufflation compared to pre-insufflation. End-tidal CO2 was statistically highly significant increase after CO2 insufflation as compared to pre-insufflation. These changes were due to CO2 absorption through the peritoneal serosa, stimulation of sympathetic nervous system, and rate intra-abdominal pressure. These are the references. Thank you.
So what was the average IAP was kept in your study group?
Yes, ma'am. Yes.
What was the average intra-abdominal pressure was kept in your study group?
Ma'am, 20 to 14 mmHg. I was taken.
How much?
Intra-abdominal pressure by 20 to 12 to 14 mmHg. 12 to
What
14.
was the flow of carbon dioxide which was kept there?
Ma'am, 200 to 400 ml per minute. The maintenance flow.
So IAP was between 12 to 14.
Yes, ma'am. 12 to 14 mmHg.
Have you seen the intravascular volume status in such patients? Shambaran?
Yes, ma'am. Yeah, yes,
Can you hear me?
yes, ma'am. I not.
Have you noted any intravascular fluid status in such patients?
And what about the hemodynamic status of the patients?
Ma'am, hemodynamic parameters are increased after CO2 insufflation due to stimulation of sympathetic nervous system.
Have you observed that during desufflation as well? What was the hemodynamic status during desufflation?
During desufflation, just after desufflation,
Yes.
it remain increased because your time to taken CO2 elimination after sometimes, but the various study have time to normal CO2 concentration is still controversial.
What about the other monitoring of the patient?
End-tidal CO2 monitoring, other hemodynamic.
So actually, madam wants to know from you that what are the hemodynamic parameters during insufflation, pre-insufflation, after insufflation, and how they are affecting the parameters you have observed in your study.
What other parameters did you observe during your study? Apart from the ABG, what other things did you observe in your study?
But hemodynamic and EtCO2 are there. No other.
Peak pressures and everything, they were all right during the study?
Yes, ma'am. Yeah.
Peak pressures and all?
Peak pressure are increased due to increased intra-abdominal pressure. Peak pressure and relative pressure were increased due to increased intra-abdominal pressure.
Because doing such studies, you have to do proper hemodynamic and the ventilatory monitoring.
That is what I wanted to know actually.
Laparoscopic surgeries.
Right.
And you have to be very cautious about your IAP, your fluid status, because they are also going to impact your APG reading.
Right.
Yes, ma'am.
Dr. Sukhvinder?
Dr. Shambharan, na? It's not for Dr. Shambharan, it's for everyone again. Basically, whenever the slides, I'm telling you, all of them, that whenever you're going to prepare slides for the national competition, the aims and objectives should have only one aims and objective. Because the type of studies which I've seen today, almost the 14 studies. The studies are small studies, and many people try to elaborate the objective to 2 to 3 lines or aims like that, and that's not appropriate. That's not the way to present. Aims and objective should be only one. That will, because the study size sample is very small. The second part is the statistical slide. Everybody should work hard to prepare a statistical analysis slide in a good manner, and don't just write the p level less than 0.5 or p less than 0.001
Significant or significant.
Write every parameter. Say confidence limits are there, the confidence interval is there, everything, the single thing, whatever you've done in your study, that should be highlighted in the statistical test. Nobody is going to see your introduction, what is the background. Only one sentence in the background is good enough, that there was a lacuna in previously published literature. That's why we conducted this study. And in the future scope, that must cover, every slide must cover a future scope. There is not a single slide I've seen a future scope in any of the studies till date. So till now. So these are few points. I think everybody should gather these points. Whosoever moves to the next stage, they should be highlighting these things in their slides.
Yes, sir. Thank you, sir.
Next, the last candidate.
The last candidate is Dr. Karishma Dhalwani. Are you ready now, Karishma?
Hey, ma'am. Good afternoon, ma'am.
Please share the screen.
Hello.
It's coming now.
My topic is comparison of oral clonidine and
screen is
oral
not seen,
midazolam
Dr.
as
Karishma.
medication.
Dr. Karishma, we are not able to see your screen.
It's
No, it has
opening.
not. You are audible, but your screen is not seen.
Ma'am, here the audience stop sharing.
Is the
Share,
Wi-Fi
share.
Here the screen.
is the Wi-Fi
It is
okay
shared
at your
only.
end?
It is not. We are not able to see it.
Karishma, you have Wi-Fi or you're using internet, mobile net? I think there is some problem with your internet connection. Because it's showing here that you have started
Screen sharing, but we are not able to see your screen.
I think Wi-Fi is not working then.
Yes, ma'am, that's what. Karishma? Hello? Karishma, are you there? Karishma, unmute yourself. Yes, something came. Okay.
Why, it's a paper. It's not PowerPoint.
Karishma, in which format you have made your presentation? Karishma, please unmute yourself.
Yes, ma'am.
Yes. This is
PowerPoint is not opening. That's why I've opened this. I've made it in PowerPoint and submitted in PowerPoint only, but that is not opening. Sorry, ma'am.
Okay. Ma'am, can we continue in this?
Yes.
Okay,
Yes,
you
yes.
start with it now.
Thank you, ma'am. Thank you, ma'am. Sorry, ma'am. Ma'am, my topic is comparison of oral clonidine and oral midazolam as pre-medication for pediatric surgery in children. Introduction: children undergoing surgical procedures can experience significant anxiety and distress during the perioperative period. The use of sedative pre-medication may help to reduce the anxiety, minimize emotional trauma, and facilitate smooth induction. Midazolam is the most commonly used as a pre-medicate agent in children. Clonidine is central sympatholytic that provides sedation, anxiolysis, and analgesic effects without causing respiratory depression. The material and methods: the study was undertaken in Department of Anesthesiology and Critical Care in Aurobindo, Sri Aurobindo Institute of Medical Sciences, after validation of committee of the institution of 60 pediatric patients of either sex undergoing surgery. Pediatric patients aged between 2 to 10 years of either sex belonging to ASA grade 1 and 2, and patient posted for pediatric surgery under general anesthesia, and those patients whose parents and guardians give consent for getting induced in the study, included in the study, were included in the present study. Patients belonging to ASA grade 3 and 4 and refusal, patient with or contraindications to clonidine or midazolam, patients of age less than 2 or more than 10 years, or with history of nausea, vomiting, or retching 24 hours before anesthesia, and patients with active infection or history of motion sickness were excluded from the study. Pre-anesthetic checkup was done for all patients before the procedure as routine. An informed consent was taken from relatives and guardians, explaining the whole procedure and the aim behind the conducting the study. Patients kept nil buyout 6 hours before the procedure as per guidelines. 60 patients were randomly allocated into 2 groups of 30 patients each. Group A had oral clonidine 3 microgram per kg, and group B oral midazolam as pre-medication 0.5 mg per kg. In group A for clonidine, oral clonidine was given to child 60 minutes before shifting to the OT. In group B, oral midazolam is not commercially available, so a preparation of 5 mg per ml mixed with mango juice was given 60 minutes before shifting to OT. Patient was shifted to the OT and mandatory monitors were attached: saturation probe, blood pressure cuff, ventimask for oxygen administration, and large gauge IV line. Following parameters were studied: parent separation anxiety score, mass acceptance score, hemodynamic variables like heart, blood pressure, saturation, wake-up behavior, and sedation behavior. Pediatric separation anxiety score was given a 4-point scale: 1, easy separation; 2, whimpers but easily assurable; 3, cries and cannot be easily assured but clinging to parents. Mass acceptance score: excellent, unafraid, cooperative, accept mass readily; good, slight fear of mass, easily assured; fair, moderate fear of mass, not calm with reassurance; poor, terrified, crying, or combative. Subject with score 1 or 2 are considered as satisfactory. Acceptance of mass scores of 3 and 4 are considered unsatisfactory. Sedation score does not respond to mild protruding or shaking 1. Second, responds only to mild protruding or shaking. The wake-up behavior was studied. 1, calm and cooperative; 2, not calm but can easily be calm; 3, not easily calm, moderately agitated or restless, combative, excited, or disoriented for 4. Subjects with score of 1 to 2 are satisfactory, and subjects with score of 3 to 4 are not considered satisfactory. Data was collected into an Excel sheet. The analysis was done using the 16 software. The mean of systolic BP, diastolic BP, heart rate, and saturation between different groups at the same time interval was analyzed using T-square test. Unpaired T-test was used to compare the parent separation anxiety and mass acceptance in both the groups. Pearson chi-square test was used to compare the sedation and wake-up behavior between both the groups. P-value less than 0 or equal to 0.05 was considered statistically significant. Results: the mean parent separation anxiety in oral clonidine was 1 plus minus 0, while in oral midazolam was 2.1 plus minus 0.3. The difference was found to be statistically significant, showing a higher mean parent separation anxiety score in oral midazolam group as compared to oral clonidine. The mean PS in oral clonidine was 1 plus minus 0, while in oral midazolam was 2.3 plus 0.03. The difference was found to be statistically significant, showing a higher mean in oral midazolam in comparison to oral clonidine. The comparison of mean heart rate between the groups showed that the mean heart rate was comparable between the two groups till 60 minutes. The mean heart rate in oral clonidine from 75 minutes till the end of 160 minutes was significantly lower than in oral midazolam group. The comparison of mean systolic blood pressure between the two groups was comparable till 105 minutes. The mean systolic in oral clonidine at 115 minutes till the end of 160 minutes was statistically lower than oral midazolam. The comparison of diastolic group, the mean diastolic pressure in oral clonidine was lower than oral midazolam. The comparison of mean systolic between the two groups was comparable till 105, as I told earlier. And in oral clonidine, all patients having sedation grade 2. In oral midazolam, all patients have sedation grade 1. There was statistically significant association between sedation grade and the groups. Discussion: in our analysis, we found that the oral midazolam is better and effective for parent separation anxiety in comparison to clonidine. Mustafa et al. Conducted a randomized double-blind controlled trial in 96 children aged 2 to 8 years scheduled for bone marrow biopsy and aspirate. Patients with child separation anxiety score grade 1 was statistically higher in midazolam group than clonidine. In our analysis, oral value was treated 70 children of American Society anesthesiological classification physical status aged 3 to 6 years were randomly assigned to one of the two groups equally. Group A received oral midazolam 0.5 mg per kg and Group C received oral clonidine 3 microgram per kg. The patient hemodynamic parameters were recorded by an observer until anesthesia induction. There was no incidence of bradycardia, hypotension in either of the groups during study observation. In our analysis, we found oral midazolam have better wake-up and sedation score in comparison to oral clonidine. Kawanda et al. Conducted a study in which 80 children, median age 3 years, were recruited and 140 surgical procedures were performed and found similarly that oral midazolam have better sedation and wake-up behavior as compared to oral clonidine. Conclusion, oral midazolam 0.5 mg per kg is an effective and safe alternative for pre-medication in children undergoing surgery under general anesthesia. Oral midazolam decreases anxiety levels, allow better parent separation, and results in better mass acceptance at the time of induction when compared with oral clonidine 3 microgram per kg. Oral clonidine has better sedation and wake-up behavior and works without causing much side effects or post-operative calculation. These are my references.
Thank you, Dr. Karishma. Over to you, Raji.
So
Hello?
what was the yes, Karishma? So what was
Yes?
what was the oral acceptance of the both drugs with your patients? That is very important with the
in both the
pediatric age group.
in the pediatric age group, I gave it with mango juice also and with PCM syrup also, and the patient was readily taking it. There was no problem in giving oral medication. When I gave it with
So it
mango
was
juice,
accepted both the drugs.
yes, ma'am, both the drugs. Patient was more acceptable towards midazolam because that was the tablet to be crushed, and it was little difficult with clonidine. Midazolam had better acceptance.
But
with children.
midazolam has a very bitter taste.
Yeah.
It is a
Yes,
real
ma'am.
bitter
That's why
taste.
I gave midazolam with my mango juice. With 2
With
sips of
honey,
mango
with
juice
mango,
and
with anything,
midazolam 5
still it
mg
has
per
a very
ml.
bitter taste. And same time, clonidine causes sedation. It causes analgesia.
Yes, ma'am.
So it has better
Yes,
effects
ma'am.
than midazolam. What was the maladaptive behaviors in the
Midazolam has
post-operative period? Actually, there is some.
Ma'am, in the post-operative period.
Your connection
Ma'am,
is
in the
loose.
post-operative period,
You're not very clearly audible, Dr. Karishma. Your voice
sorry,
quality
ma'am.
is very bad.
Ji, ma'am. Sorry, ma'am. Ma'am, actually, midazolam has better sedation.
Yeah. Only sedation is there, but as far as the analgesia and
sedation,
when you
anxiolysis,
compare both
everything
the
is
things,
quite-
clonidine has better analgesia as well.
Clonidine has better analgesia, but midazolam, the patient was easily separated from the parents. In clonidine, patient did cling to the parents. The pediatric separation anxiety score was 2 with clonidine, and in midazolam, most of the patient had 1, easily separable from parents.
So you had all the patients with intravenous line in situ, or you had to take that?
No, in my study, all the patient had intravenous line after giving midazolam and clonidine when the patient was sedated. Because
so did you find any difference in that while taking the intravenous line?
Ji, ma'am.
In both the groups, did you find any difference when you were taking intravenous line?
No, ma'am. The patient was in both the groups. The patient was sedated. Quite. There was no problem with intravenous line.
But once you put the prick, did the patient put their hands back?
No, ma'am. Patient did not.
Hope she has used that amla cream.
Hopefully, yes. Okay, Dr. Sukhwinder.
Nothing from my side, ma'am. You have asked everything almost.
Chala, thank you so much, Dr. Karishma.
Thank you, ma'am.
Thank you, Dr. Karishma.
Thank you so much, respected judges. It was such a knowledgeable
It's
session.
our pleasure, Dr. Neha, to be judged for this prestigious papers. Thank you so much, Sagar City Branch, and you all organizers for giving us this opportunity. And I am more thankful to my co-judges. They are so wonderful judges, and good interaction we had in between. And wish you all a very happy Anesthesia World Anesthesia Day. And we are all open to enjoy now by the evening. And you arrange a conference in such a way that we can have the banquet in our own cities. Thank you so much.
Thank you so much.
I'm so pleased to get the inputs from Dr. Sukhminder Bajwa. Actually,
yeah, surely.
It is really, he has given the real inputs to the PG students, like when they go for publication, their publications, they are always rejected because of these issues.
Yeah.
Hope everyone has noted that. And I'm really feeling so privileged to be a co-judge with him in this session.
Yeah.
No,
And
rather,
with
ma'am,
Sadhna,
I'm feeling
obviously.
privileged. I'm feeling privileged rather to be co-judge with you people. Thank you very much, ma'am. Thank you very much.
Thank you so much.
Okay,
Happy World Anesthesia
well,
Day.
yeah, I am on the
side, both of you.
Thank you.
I'm simultaneously on the GC meeting going on for the World Anesthesia Day.
Oh,
you are multitask person.
Yeah.
You are a multitask person.
Yeah,
Right?
And we are just going to rush for our celebration in a few
Right.
minutes.
Thank you.
Nice meeting here on the platform.
Thank you, ma'am. Thank you, everybody. And all the PG should be feeling encouraged, ma'am. Rather.
Yeah, they should be. They should be encouraged by your comments, especially.
Thank you, ma'am. Thank you. Thank you.
Okay, thank you, organizers.
Thank you.
Thank you, ma'am.
Thank
Neha,
you all
for
the
conducting
speakers.
the session wonderfully.
Thank you, ma'am.
Thank you, Dr. Neha, for conducting
you,
this
ma'am.
session wonderfully.
Thank you, ma'am.
Good night.
Okay, thank you so much.
Thank you. Okay. Now we'll move on to our next session. We are taking some free papers here, 5 of which are left here. And the judge for the session is Dr. Ranjita ma'am and Dr. Shaleen Davar, sir. Dr. Shaleen Davar. Dr. Shaleen Davar.
यार मैडम आ गई मैडम बैठी
Hello, Dr. Ranjita and Dr. Shailendra. Good evening.
Good
And all
evening.
the best for your paper.
Good evening, ma'am.
Good evening, sir. Good evening, ma'am. Dr. Shaleen Davar, he's MBBS, MD, ID, CCM. He is a professor and head Department of Anesthesiology, Government Medical College, Ratlam. He's assistant professor in Chirayu Medical College, Bhopal from 2012 to 2018, and associate professor in GMC Ratlam from 2018 to October 2021. And he is a professor from 7th October to till date. Welcome, sir.
Thank you.
Our next judge with this is Dr. Ranjita ma'am. Dr. Ranjita Davar. I'll be introducing her CV. Dr. Ranjita Aske Davar. She is Associate Professor GMC Ratlam, and she has done her MBBS from GMC Bhopal, MD from GMC Bhopal. She was Assistant Professor in GMC Bhopal from 2012 to 2018, Associate Professor in GMC Ratlam from 2018 to till date, and she has done 10 research publications in international and national journals. Welcome, sir and ma'am.
Thank you. Thank you.
We would like to start with our first candidate. Can we start, sir? Our first candidate is Dr. Keshav Midha from MGM Medical College and NY Hospital. Dr. Keshav, are you there?
Yeah, my voice is audible.
Yes, yes.
Audible.
Okay. You can start your presentation.
Good evening, respected judges and seniors. My topic, myself, Dr. Keshav Midha, postgraduate students in MGM Medical College and MY Hospital, Indore. My title is a randomized comparative clinical study between the nerve block with IV sedation versus general anesthesia in patients of post-COVID-19 mucormycosis undergoing sinus surgeries. Introduction. Since the onset of COVID-19 pandemic, there are very high incidence of mucormycosis among the patients with COVID-19, especially in those who are diabetic and those who have unjudicious and unsupervised use of systemic steroids. Patient already lung capacity is compromised, because of which there are more chances because of which there are more chances of post-operative delayed recovery, which might mandate requirement of post-operative mechanical ventilations. The airway is the foremost challenge in the sinus surgeries. The major concerns are difficulty in managing the patient's airway and sharing it between the anesthetist and the surgeons. We assess the efficacy and safety of a regional block with sedation technique in certain sinus operation and compared it with the conventional general anesthesia. We compared the time to discharge from the post-anesthesia care unit and the occurrence of side effects, as well as the surgeons and the patient satisfaction with the anesthetic techniques between the two groups. So my aims and objectives: the primary objective is to compare the patient's and the surgeon's satisfaction with the anesthetic techniques and to compare the time to discharge from the post-anesthesia care unit. Secondary objectives were to compare the intraoperative hemodynamic parameters and to compare the need of post-operative mechanical ventilations. The study center was the Department of Anesthesiology, MGM Medical College and MY Hospital, Indore, and the type of study is randomized control study. The study duration is 1 year and the study population taken were 100 patients. The materials required were anesthesia workstation with multiparameter monitors and the drugs in general anesthesia, various emergency drugs, local anesthetic drugs, injection bupivacaine, injection lignocaine with adrenaline, and for sedation injection dexmedetomidine. The include criteria was the age patient of age between 18 to 55 years and the ASA status grade 1 and 2 and the Mallampati class 1 and 2, and the patients were RT-PCR or rapid antigen negative patients. The exclude criteria was the patient refusal and those with a history of BiPAP mode of ventilation during their COVID period or those with a history of mechanical ventilation during their COVID period. The study design: a randomized comparative clinical study was conducted on the 100 patients undergone post-COVID-19 mucormycosis sinus surgery were divided randomly by check method into two groups. The group A was 50 patients and group B with 50. The group A was induced with a nerve block with IV sedation and group B was induced with the general anesthesia. After selecting the patient were randomly allocated to two groups, although a thorough pre-anesthetic evaluation was carried out before the surgery, and each patient was taken in OT after taking informed consent and multipara monitor was connected. Vital signs are recorded. IV access was secured with 18 gauge or 20 gauge cannula and appropriate IV fluid was started. Patient in group A and group B both were pre-medicated with injection glycopyrrolate 0.2 mg IM and injection midazolam 1 mg IV was given in each patient. Group A induced with the infraorbital posterior superior alveolar, nasopalatine and greater palatine nerve block with IV dexmedetomidine with loading dose of 1 mg per kg over 10 minutes and maintenance dose with 0.2 to 0.7 mg per kg per hour continuous IV infusion. And group B with general anesthesia as per our institutional hospital standard protocol. Hemodynamic parameters were monitored at every 5 minutes with 5, 10, 15, 30, 45 and 60 minutes. Patient was assessed for the intraoperative pain and anxiety. Postoperative first requirement of analgesia was noted on the basis of VAS score, and the patient satisfaction, that is verbal rating scale 1 to 5, and the surgeon satisfaction numerical rating scale with 0 to 10 were noted. The observation: the hemodynamic parameters were monitored by systolic blood pressure, diastolic blood pressure, pulse rate, and saturation pulse oximetry for group A and for group B. And the mean patient satisfaction score was 4 for group A, which was more than group B, that is 4.3. And the mean surgeon satisfaction score, that is according to the patient, according to the surgeon, they scored group A 8 score, and for group B they scored only 6. And the VAS score, the patient in group A had lower VAS score after surgery and remained pain-free for the longer than in group B. There was no significant variation in the intraoperative hemodynamic parameters between group A and group B, but both patients and the surgeons are more satisfied with group A mode of anesthesia compared to group B. And the groups were compared with respect to demographic profile, intraoperative hemodynamic parameters, surgical time, and the amount of blood loss. The postoperative pain was assessed using the visual analog score. Patient in group A had lower visual analog scores after surgery and remained pain-free for longer than in group B. The mean pre-interval in group A was 159.12 plus or minus 43 minutes, and in group B was 60 plus 19.77 minutes, in which P was taken less than 0.005. And the patient in group A required lower doses of rescue analgesia than those undergoing the surgery under general anesthesia. Patient receiving the regional block also had fewer episodes of postoperative nausea and vomiting. These results lead to the earlier discharge of patients in group A from the post-anesthesia care units. From this, we conclude that from experience, we can conclude that the nerve block, that is infraorbital, posterior superior alveolar, nasopalatine, and greater palatine, both all other maxillary nerve block with IV dexmedetomidine, that is for the sedation, is a safe alternative technique for the COVID-19 mucormycosis undergoing sinus surgery with clear advantages over the general anesthesia. while the nerve block with IV dexmedetomidine have associated with better outcomes than general anesthesia in terms of mortality, intensive care, and the ventilatory supportive care. As a patient with group A need less post-operative mechanical ventilation as compared to group B. Regional anesthesia is also a cost-effective technique with less requirement of drugs and equipment and with decreased length of hospital stay or ICU stay. The differences are given as such. Thank you.
Thank you, Dr. Keshav. It was a nice presentation. Now over to you, judges.
Hello.
Hello. Am I audible?
Hello, ma'am.
Hello.
Hello.
Yes, sir. You are audible.
Yes, ma'am.
Dr. Keshav, nice delivery. My question is, how you calculate the sample size in your study?
Sir, I just take randomly the 500 patients. Total for the study. Okay, sir, master study नहीं थे, so just we deal with the statisticians to how to take the patient size. So for the better outcome with bar chart or randomly, we take the 100 patients in our hospitals.
Okay. What is the type of your study design?
Sir, it is randomized comparative study. We compare both the groups in comparison to patient satisfaction as anxiety score and the visual analog score, pain scoring, and the surgeon satisfaction with the field of anesthesia, with the field of surgery they want.
Okay. And in your general anesthesia group for maintenance, which agent you use?
Sir,
inhalational anesthetic agent.
Sir, we use inhalational agents, isoflurane.
Isoflurane. Okay.
Yes, isoflurane is also
Okay.
fungostatic, so we use isoflurane.
Okay. And volume of local anesthetic agent for block?
So normally we take the dose according to the weight of the patient. So that is for the lignoid we use 5 milligram per kg per body weight, and for the bupivacaine we take 2 milligram per kg. And
Okay.
proper sedated on both the sides as the sinus of maxillary sinus both sides involved mostly in this.
Okay, okay. And time of block just before surgery?
Sir, we pre-medicate 30 minutes before, and after giving the block, we wait for 10 minutes to act on, and after 10 minutes we start our loading dose of dexmedetomidine with 1 max per kg. And after completing our maintenance loading dose, we start with the maintenance dose for the whole surgery, sir, for 1 month.
Okay. Thank you. Thank you, Dr. Keshav.
And what rescue analgesic you had used intraoperative period in group B?
Sir, group B for general anesthesia, we use the paracetamol. But start with the general normal protocol, we gives the injection fentanyl, and after.
Paracetamol?
Sir, firstly we give injection fentanyl, 1 to 2 microgram per kg per watt. Dose. Start with 1 to 2 mics per kg.
Okay, okay. And group A?
The group A, we just give them a regional block and with the sedative with dexmedetomidine.
No, any other rescue analgesic?
No other rescue analgesic. If they need, we start in the end of the week with the paracetamol.
Okay.
Okay. Thank you. Thank you, Dr. Keshav.
Thank you, sir. Thank you, ma'am.
Thank you.
Thank you, Dr. Keshav. Our next candidate is Dr. Priyanka Goyal from GRNC Gwalior. Priyanka, are you there? I think I'm not seeing her name in the list, login list. So we'll move on to next Dr. Rashmi Pandey from Gandhi Medical College. Dr. Rashmi, are you there? Hello? Dr. Rashmi?
Am I audible, ma'am?
Yes, Rashmi, you are audible. Please start your presentation. Share your screen.
Yes, ma'am. Ma'am, is it visible, ma'am?
No, not yet. I think there's a network issue. I can see all documents like Rashmi paper 2021. The slide is not there.
Rashmi, you are in Wi-Fi or mobile net? Just a reminder to all the candidates, you will have 7 minutes time and
Ma'am, is
2 minutes for, yes, it's now visible.
Ma'am, is
And
it
2
visible
minutes
now?
for discussion. Yes, Rashmi, visible now. You can start.
Yes, ma'am.
Rashmi, make it bigger from slideshow. Let's zoom, just zoom it a little.
Yes, ma'am.
Yes, okay, now start.
Good evening, sir. Good evening, ma'am. My topic is I'm Rashmi Pandey. My topic is comparison of diltiazem and lignocaine in attenuating hemodynamic responses to endotracheal extubation. My moderators are Dr. Shikha Mehrotra, ma'am, Professor and Head of the Department of Gandhi Medical College, Dipesh Gupta, sir, and Rajkumar, sir, of Department of Gandhi Medical College. Introduction. Problems associated with extubation, recovery, and emergence are equally common as the problems at intubation. Endotracheal extubation causes transient hemodynamic stimulation, leading to increase in blood pressure and heart rate due to increase in sympathogenic activity caused by epipharyngeal and laryngopharyngeal stimulation. Most patients tolerate hypertension and tachycardia without any significant consequences, but some show an exaggerated response which is poorly tolerated and may lead to myocardial ischemia, cardiac decompensation, pulmonary edema, and cerebral hemorrhage. Respiratory complications are cough, sore throat, laryngospasm, and bronchospasm, which leads to hypoxemia. Laryngospasm is the most common cause for post-extubation upper airway obstruction. Lidocaine, a sodium channel blocker, attenuates the hemodynamic response to tracheal extubation by inhibiting sodium channels in the neuronal cell membrane, decreasing the sensitivity of the heart muscle to electric impulses. It is also a direct cardiac depressant and peripheral vasodilator. It also suppresses airway reflexes. It has analgesic as well as antiarrhythmic properties. Diltiazem, another study drug, a calcium channel blocker, attenuates hemodynamic responses by blocking voltage-sensitive L-type channel and inhibiting calcium entry-mediated action potential in smooth and cardiac muscle. It has also vasodilatory property. My aims and objective are: primary objective to compare the effect of intravenous diltiazem and intravenous lignocaine on blunting the hemodynamic response to endotracheal extubation. Secondary objectives are changes in vital parameters such as heart rate, systolic blood pressure, diastolic blood pressure, mean arterial pressure, airway reflexes, cough, laryngospasm, and bronchospasm. Complications such as hypotension, bradycardia associated with the drug. Materials and methods. Study Center, Department of Anesthesiology, Hamidya Hospital. Study design is observational hospital-based study. Sample size is 60 patient. Group A, randomly we divide the patient. Patient receive 0.2 mg per kg diltiazem intravenously 2 minutes before extubation. And group B, patients will receive 1 mg per kg lignocaine intravenously 2 minutes before extubation. Inclusion criteria: all elective patients belonging to age group 18 years to 16 years, ASC grade 1 and 2. Exclusion criteria: patient refusal, patient suffering from cardiac diseases and like ischemic heart disease, arrhythmias, angina, patient with pulmonary diseases, pregnant and lactating women, patient posted for emergency surgery, patient with psychiatric and neurovascular disorders, any contraindication to study drugs, lignocaine and diltiazem. Methodology: this prospective randomized observation single center trial will be conducted after approval of the Institutional Ethics Committee of Hospital. We will include all ASA physical state 1 and 2 patient of either sex between 18 to 60 years. Standard pre-anesthetic assessment was done. On the arrival of patient in the operating room, intravenous cannula inserted, standard monitors were connected, and baseline vitals were recorded: heart rate, SBP, DBP, and MAP. Patient will be pre-medicated with injection IV glycopyrrolate, 0.2 mg, injection fentanyl, 2 mcg per kg. Pre-oxygenation will be done for 3-minute induction with injection propofol 2 mg per kg and succinylcholine 2 mg per kg for muscle relaxation before intubation will be done. General anesthesia, patient intubated, and general anesthesia maintained with 60% N2 or 40% O2 and isoflurane, followed by atracurium dicillate, a neuromuscular blocking agent, 0.5 mg per kg as loading dose and 0.1 mg per kg maintenance dose. At the end of surgery and 2 minutes before extubation, out of 60 patients, 30 patients received injection diltiazem 0.2 mg per kg, and another 30 patient will receive injection lignocaine IV 1 mg per kg. At the end of the surgery, heart rate, systolic and diastolic blood pressure were recorded. They served the baseline values. Then after giving reversal with neostitin 0.05 mg per kg and glycopyrrolate 0.001 per kg at 1 minute and 2 minutes after administration of study drugs, at the time of extubation and after extubation at 1 minute, 2 minute, 3 minute and 4 and 5 minutes, the heart rate and SPP were recorded. Data analysis, the results were successfully evaluated using the student t-test comparing between the groups and within the group. The quality of tracheal extubation was evaluated using a 5-point rating scale. No cuff or strain, very smooth minimal cuffing, moderate cuffing, high degree of cuffing or straining, poor extubation, very uncomfortable. Comparison of heart rate between two groups. Group one and these are the study, and these are the changes in mean systolic blood pressure. This is the result. Changes in heart rate is in group one. The baseline value 1 minute after extubation, it increases by 4, and group 2 5.28. And changes in SBP, it decreases by 19, and in group 2 by 2.6. And in diastolic blood pressure changes, it decreases by 2, and in group 2 it increases by 2. Discussion: heart rate changes and blood pressure changes. Group 1, in this group where diltiazem was used, there was significantly less rise in heart rate and fall in systolic blood pressure 8.6% and diastolic blood pressure 2.4% and mean arterial pressure 5.2% at 1 minute following extubation compared to baseline values. These parameters remain stable up to 5 minutes after extubation. The probable effects of diltiazem are due to its direct vasodilator and its negative chronotropic and dromotropic properties. Group 2, in this group where lignocaine was used, we observed a rise in heart rate, diastolic blood pressure 3.6% and mean arterial pressure 1% and fall in systolic blood pressure 2.3% compared to the baseline values. These values indicate that lignocaine significantly suppressed the increase in heart rate and arterial pressure during extubation compared to control group. The beneficial effect of lignocaine is attributed to its suppression of airway reflexes, depression of autonomic nervous system, and peripheral vasodilatation. The onset of antihypertensive action of diltiazem occurs with approximately 30 seconds after a single IV injection, with a peak effect occurring at 1.5 to 2 minutes. The decision to give the drug 2 minutes prior to tracheal extubation was based on this data. Conclusion is diltiazem hydrochloride, a calcium channel blocker, belongs to the benzodiazepine group given in dose of 0.2 mg per kg. IV 2 minutes before tracheal extubation. ASA grade 1 and 2 in ASA grade 1 and 2 patient is a simple, effective, and practical method of blunting cardiovascular responses to tracheal extubation. This suppressive effect of diltiazem was comparable to or even more potent than the lignocaine 1 mg per kg given IV 2 minutes before tracheal extubation. Thank you.
Thank you, Dr. Rashmi. It was a nice presentation. Now over to you, judges.
Hello.
Hello. Good evening, sir.
Good evening. Am I audible?
Yes, sir.
Dr. Rashmi, nice delivery. My question is how you calculate sample size in your study?
So, it is a rough estimation.
Okay.
Actually,
okay. And any complication with your study?
So yes, sir. Due to diltiazem, there is a chances of hypotension during maybe hypotension can occur, sir.
Okay. Okay. And have you seen intravascular volume status just before surgery?
Sorry, sir.
Have you seen intravascular volume status just before surgery in your patient?
Yes, sir.
Okay. Okay, and which inhalational agent you used in your study for maintenance?
Maintenance in our institutions are mainly isoflurane is used, sir. So isoflurane is used.
Okay. And any other specific contraindication to use diltiazem? Did you mention in your exclusion criteria?
Yes, sir. Cardiac patient and so cardiac patient I have mentioned, sir.
Okay. Okay.
Okay, thank you,
Thank
Dr.
you.
Rashmi.
Thank you, doctor.
Thank you, sir.
Thank you, Dr. Rashmi. Now we move on to Saladi Venkat Akshay.
Yeah.
He's from Gandhi Medical College, Bhopal.
Yeah,
Saladi?
hello. Yeah, ma'am. Hello. Am I audible, ma'am?
Yes, yes, you are audible. Saladi,
Yeah,
share
ma'am.
your
Yeah, ma'am. Ma'am, I'm getting like you can't start screen sharing while the other participant is sharing.
Who are they sharing?
Yeah, yeah, ma'am. I'm sharing my screen, ma'am. One
Okay.
second. Yeah, 1 second. No. Yeah, ma'am. Is my screen visible, ma'am? Hello.
Yes, the presentation is not visible. You are visible right now.
Ma'am, 1 second. Screen. Yeah, ma'am. Yeah, it's starting, ma'am. 1 second.
Okay. Yes, it's coming. Something. You're sharing screen. It's coming.
Yeah, ma'am. Is my screen visible, ma'am?
Yes, it's visible. Can you make it bigger?
Yeah, ma'am. Now is it fine, ma'am?
Okay. Sir, is it fine for you?
Yeah. Hello.
Shall we say?
Yes, sir. Yes, fine.
Okay. Continue, Salad.
Yeah. Good evening, respected judges. Thank you for giving this opportunity. My topic for the paper presentation is a comparison of ropivacaine 0.5% in the dose of 4 mg per kg along with dexmedetomidine as adjuvant in the dose of 1 microgram per kg and ropivacaine 0.5% in the dose of 4 mg per kg alone during ultrasound guided interscalene brachial plexus block for shoulder and upper arm surgeries. Yeah, introduction. Interscalene brachial plexus block is a common nerve block given to patients who are undergoing shoulder and upper arm surgeries. The block involves injection of local anesthetic in the interscalene groove between the anterior and the middle scalene muscles to block the brachial plexus. And during this procedure, we are using ultrasound guided technique, which has a significant role in preventing the complications due to real-time imaging of needle advancement and local anesthetic spread. This technique also decreases the incidence of hemidiaphragmatic paresis. And the drug ropivacaine, it is an aminoamide local anesthetic, which is structurally similar to bupivacaine. The decreased cardiovascular and central nervous system toxicity makes ropivacaine interesting alternative to bupivacaine in procedures requiring large dose of local anesthetic. And as adjuvant, we are using dexmedetomidine, which is a highly selective and specific potent alpha-adrenergic agonist. It is having analgesic, sedative, antihypertensive, and anxiolytic effects. Adding dexmedetomidine to local anesthetic during peripheral nerve blockade and regional anesthesia procedures, it may also prove efficacious for the surgical patient. It acts on both pre and post-synaptic sympathetic nerve terminals and central nervous system, thereby decreasing the sympathetic outflow and norepinephrine release, causing sedative, anti-anxiety, analgesic, and there is also stable hemodynamic effects. Clinical studies have shown that dexmedetomidine can prolong the duration of analgesia when used in combination with local anesthetic agents like ropivacaine. So we plan to evaluate the effect of adding dexmedetomidine to ropivacaine in interscalene brachial plexus block. And coming to objectives, we are focusing on onset of complete sensory block, onset of complete motor block, duration of sensory block, and the duration of motor block. And we conducted this study in Gandhi Medical College and associated Hamidia Hospital. My study design is observational hospital-based study. It's a cross-sectional study as we are assessing the patient at one point of time. And duration was 10 months. The sample size is 92. The sampling was taken based on non-probability convenience sampling. And patients are included on based on age between 18 to 50 years, ASA grade 1 and 2, and surgery involving this shoulder and upper arm. And exclusion criteria is if patient is refusing for the procedure, if patient is suffering with any coagulopathies, any contraindications for interscalene block, any pre-existing significant systemic diseases, patients with psychiatric history, and patients who are allergic to local anesthetics. As per the allocation, either of the patient will receive plain ropivacaine 0.5% in the dose of 4 mg per kg, or will receive ropivacaine with dexmedetomidine in the dose of 1 microgram per kg out of 92 patients. That patient will undergo routine PAC, and patients are explained about the procedure. Informed consent has been taken. An intravenous line is secured on the opposite side of the limb undergoing the surgery, with all precautions using the ultrasound with a linear probe. Interscalene brachial plexus block is performed using plain ropivacaine, local anesthetic drug, or ropivacaine with adjuvant. This is the image showing the USG, showing the hypoechoic areas. Whereas if we go distally to the brachial plexus, we can find a classical honeycomb appearance. But at the level of interscalene groove, we can find as hypoechoic structures, dark color structures, and there is also the needle advancement. Results were expressed by standard methods. A mean and standard deviation were taken. Onset and duration of sensory and motor blockade and duration of analgesia was analyzed by unpaired t-test as we are comparing it. Statistical analysis were performed by using a software EPI Info 7 software. Here we are considering the patient as mentioned in the inclusion criteria, including the gender male and female. These are the mean values of the patient in weight, and the patient belong to grade 1, grade 2 ASA. In our study, the onset of complete sensory blockade while using the ropivacaine is 15 minutes with standard deviation of 1.42, whereas the sensory blockade onset while using the ropivacaine with adjuvant is 11 minutes with standard deviation of 1.08, which is significant. The complete motor blockade is 19 minutes with standard deviation of 1.5, and with adjuvant is 14 minutes with standard deviation of 1.08. The duration of motor blockade with ropivacaine alone at the dose of 4 mg per kg is 374 minutes with standard deviation of 30 minutes, whereas with use of adjuvant is 447 minutes with standard deviation of 34. And duration of sensory blockade while using ropivacaine alone is 403 minutes with standard deviation of 32, whereas with use of adjuvant is 486 minutes with standard deviation of 35. All these are significant. This is the diagram showing the complete onset of sensory blockade and complete onset of motor blockade. The left-sided one is showing the sensory. The blue color indicates the use of only ropivacaine alone, whereas the orange color indicates the use of ropivacaine with adjuvant dexmedetomidine. Whereas the figure 2 is showing the duration of sensory blockade and duration of the motor blockade. The discussion. Peripheral nerve blockade provides excellent anesthesia. It markedly decreases the post-operative analgesic requirement. Adjuvants are used along with local anesthesia to improve the onset and duration of brachial plexus block. In this study, we investigated whether adding dexmedetomidine to ropivacaine for interscalene brachial plexus block would affect the onset of complete sensory and complete motor block and duration of sensory and motor block. And while the study, after adding a dexmedetomidine to ropivacaine 0.5% in the dose of 1 microgram per kg as adjuvant in interscalene brachial plexus block, the onset of complete sensory and complete motor block has been shortened while compared with the ropivacaine alone. And at the same time, duration of both sensory and motor block has been increased significantly. The heart rate, mean arterial pressure remains stable, and the blood pressure never decreased below the 20% of the baseline values. There is no significant hypertension and bradycardia were observed. The similar type of study has also been conducted by others, such as Mohit Mangal et al. and Vinith Chemical.
Sorry to interrupt you. Your time is up, so you just coming to conclusion. No?
Yeah, ma'am. Similar studies has been done by others, but the duration of action is longer because they have used a fixed dose 30 ml of 0.5% ropivacaine and 150 micrograms, whereas we are using as per the weight of the patient. The conclusion is ropivacaine used in brachial plexus block is well tolerated and provides effective surgical anesthesia as well as relief of post-operative pain. And dexmedetomidine as adjuvant to ropivacaine enhances the quality of block by faster onset of sensory and motor blockade. Dexmedetomidine increases duration of both sensory and motor blockade. Duration of analgesia was significantly increased by dexmedetomidine when added to ropivacaine in brachial plexus block. These are the references. Thank you.
Thank you, Dr. Saladi. It was a very nice
Yeah, ma'am.
presentation, I must say. Very
Yeah, ma'am.
clear. And over to you, judges, now.
Yeah.
Oh, thank you, Dr. Adi. Nice presentation.
Yes, sir. Thank you for giving this opportunity, sir. Thank you.
Okay. So, Dr. Saladi,
Yes, sir.
volume of local anesthetic you used in your study?
Yes, sir. It is 0.5% concentration we have taken, sir. We've been using 4 mg per kg, sir.
Volume.
Yes, sir. Sir, 4 mg per kg in the sense our drug contains 1 ml has 5 mg, sir. If a patient has if patient is 50 mg.
Okay.
So based on that, we are calculating and using, sir, volume.
Okay.
It will be around 25 ml.
Any complication with your study?
Sir, complications are rarely observed, sir. Not even one, I guess, because we are using ultrasound guided techniques, sir. And based on that technique, we are after seeing the needle approachment to the brachial plexus and after confirming with the Doppler of ultrasound, we are installing the drug, sir.
Okay. And what is type of study design? Is it a double-blind study?
Sir, non-blinded study, sir. It is observational cross-sectional study, sir. Non-blinded study. Yes, sir. Yes, sir.
Observational process. Okay.
Yes.
Okay. Thank you. You calculate a sample size in your study?
Sir, it's a sir. It is a sir. Hello. Yes, sir.
Yeah. Am I audible?
Yes, sir. Sir, you are audible, sir.
How you calculate sample size in your study?
Sir, it is a non-probability convenient sampling, sir.
Okay.
Yes,
okay. Is sample size is adequate for outcome?
Yes, sir. As the duration I've been doing is 10 months. So I've chosen this type of technique, sir, for taking the sampling size. I've taken 92 patients and I divided into 2 groups.
Okay.
Yes, sir.
Nice, Dr. Saladi.
Yes, sir.
Any hemodynamic difference between 2 groups?
Yes, ma'am. While using the dexmedetomidine, I observed the changes in blood pressure and heart rate, but it is not as significant as to maintain with the drugs and all, ma'am.
Okay.
Yeah,
okay. Thank you, Dr. Saladi.
Yeah, ma'am. Thank you, judges. Thank you, Dr. Neha Soni, for conducting such a well-planned session. Thank you.
Thank you, Dr.
Thank you.
Saladi.
Yeah,
Next, we move on to Dr. Saleha Tabassum. She's from MGM Medical College and NY Hospital. Dr. Saleha.
Am I audible now?
Yes, you're audible. Please share your screen. Saleha?
Is my screen visible?
No, it's not visible yet.
Okay, I'll just try again.
Saleha, your screen is still not visible. Yes, it has started connecting now. Okay. Please, Saleha, please speak a little louder.
Okay.
Okay, your voice is not audible clearly. Yeah, okay. Now start.
Am I audible clearly now?
Audible, Dr. Saleh.
Okay, sir. I'll start now. Myself, Dr. Saleha Tabassum. I'm an RMO in Department of Anesthesiology at MGM Medical College and NY Hospital. And the topic of my research was a clinical study to evaluate the feasibility of spinal anesthesia in neonates.
In 1899 August, Bayer reported the successful use of spinal anesthesia in a child, and despite its popularity in adults, the technique never gained great popularity in pediatric anesthesia until 1980s, when it was shown to be a suitable alternative to general anesthesia in a high-risk former preterm. Advancements in pediatric anesthesiology training, monitoring techniques, and new medications contributed to the safety of contemporary pediatric anesthesia practice, leading to resurgence in spinal anesthesia. However, despite these issues, perioperative cardiac arrest may occur during anesthetic care, age being an important factor. And more recently, concern has been expressed regarding the potential neurocognitive effects of general anesthesia during neonatal period of infancy. The primary aim of the study was to study the success rate and feasibility of spinal anesthesia in neonates, and the secondary aim was to study hemodynamic changes and to look for complications, if any, of spinal anesthesia in neonates. The materials required were most importantly injection bupivacaine 0.5% hyperbaric, and sterile syringes, 24 and a half gauge needle, and IV fluid
वाला
with
question तो ठीक
uh, the study was a prospective study conducted at the Department of Anesthesiology at MGM Medical College and MY Hospital, Indore, over the period of 6 months after the approval from Institutional Ethics Committee, and the 15 units were taken as the sample. The inclusion criteria included ASA grade 1 and 2 term and preterm babies undergoing surgery below umbilicus and lower limb surgeries lasting less than 2 hours. And exclusion criteria includes parental refusal, any contraindication of spinal anesthesia, and low toxicity of local anesthetic. Procedure. After arrival in the operating room, an intravenous access is secured and all patients were given IV fluid according to Holiday and Segar formula. Standard monitoring including heart rate, oxygen saturation, blood pressure, and ECG were recorded and baseline values noted. All the neonates were pre-medicated with injection atropine 0.01 mg per kg and sedated with ketamine 2 mg per kg before block to achieve an immobile patient for lumbar puncture. Spinal anesthesia was given with patient in lateral position via midline approach using all aseptic precautions, and puncture was performed at L4 L5 interspinal space using 24 into 1.5-inch needle. After getting free flow of CSF, hyperbaric bupivacaine in a dose of 0.5 mg per kg was injected in the subarachnoid space. Success of block was assessed by loss of tone in both lower limb and lack of response to firm pinprick to T10 level. After 10 minutes of the block, if peak sensory level was at least T10, surgery was allowed to start. If the peak sensory level was below T10, then the case was classified as failed spinal block, and such patients were given general anesthesia with intubation and excluded from the study. The data was recorded in patient assessment pro forma and analyzed. Statistical analysis was done using the software, and the results were that the success rate of the study was 92%, while the remaining 8% were classified as failure and given general anesthesia. All the successful blocks had peak sensory level of T10 and loss of tone in bilateral lower limb. Lumbar puncture was successful in first attempt in 36 patients, and remaining 14 required second attempts. And during the study, there was no significant variation in mean systolic blood pressure, diastolic blood pressure, oxygen saturation, and pulse rate of the studied patients. Spinal anesthesia is safe and cost-effective technique with good muscle relaxation and uniform sensory block. Spinal anesthesia shows better stress response to surgery, minimum respiratory complications, and fast recovery. In present study, the failure rate of spinal anesthesia was 8%, which was similar to that of DOMS and all, where failure rate was 7.5% and 16% required supplemental anesthesia. Also, more than 2 punctures were needed in 28%. Heart rates were stable throughout the perioperative period, and spinal anesthesia also shows remarkable cardiovascular stability and can avoid bradycardia with minimum cardiac complications. In our study, we did not face any complications of spinal anesthesia intraoperatively. And the potential limitation to the use of spinal anesthesia in neonates can be short duration of surgical anesthesia as compared to adults. Conclusion: from our experience, we can conclude that spinal anesthesia is an effective and safe method of anesthesia in neonates. Spinal anesthesia is also a cost-effective technique with less requirement of drugs and equipments and decreased length of hospital stay. These are my references. Thank you.
Thank you, Dr. Saleh Tabusam. Over to you, judges now.
Hello. Am I audible, Dr. Saleh?
Yes, sir. Yes, sir.
Okay. Any complication with your study?
So there are reported complications of spinal block in neonates, but during our study, we did not face any such complications.
Okay. And any other difficulties you face in your study?
Actually, the space is slightly narrow, so we did face in some difficulty in putting the needle inside and achieving the CSF flow, free CSF flow.
Which gauge needle you had used, Dr. Salia?
Ma'am, we used 24 gauge 1.5 inch needle.
Is it safe for neonates?
Ma'am, it is some studies shows that without a stellate needle has shown epidural tumor in neonates, but we did not till now we have not seen any such complication.
Okay.
Okay. How will you calculate the sample size in your study?
Sir, sample size was calculated by taking the hospital census only. We took out the neonatal surgeries we have in our hospital, and the rough estimate was calculated.
Okay. And pre-medication agent, which pre-medication agent you use before surgery?
The pre-medication was done with atropine, 0.01 mg per kg, and the ketamine was also given to so that the neonate does not move during lumbar puncture.
Okay. Okay. Thank you. Thank you, Dr. Saleh.
Thank you.
Thank you, Dr. Saleha, and thank you, respected judges. Our 5 candidates are over now.
Okay.
This was the last one. Thank you, sir, for cooperating us in the last minute. Thank you so much.
Thank you, Dr. Neha, and thank you, BMC team for nice noise.
Thank you so much. Thank you so much, sir. Thank you so much, ma'am. We are done with the session of Foley now for the day.